Welcome to day 2 of OPMAN XXXIII. We're happy you're here. For a day, we'll focus on hepatitis, liver disease, and closely related to that, we'll talk more about obesity, topics that came up yesterday in discussions, drilling in on Hep B today, as well as Hep C, and also metabolic-associated steatotic liver disease and obesity. So I'm Mark Solkowski. I'm at Johns Hopkins, just up the road in Baltimore. Sometimes it's an hour away by car. Sometimes it's 3 hours away. Just depends on the time of day. So this is the Wi-Fi access code, JW 2025. Those of you here in the room with us can log on. Those of you at home watching on the internet, hopefully your Wi-Fi is up and running. This is a hybrid conference. We are pleased that folks are here in person in Washington, D.C. with us, and we do have virtual attendees. So when you do ask questions, please use the microphone. That way the virtual folks can hear that as well. And we do have an iPad up front, which is getting questions from those of you at home, so please send those in anytime. We're going to gather those, and during the question period, we'll get to those questions. You, of course, can also vote in person or at home, scanning the QR code you have on your tabletops. Accreditation from Rush University Medical Center, up to in-person 12 credits, virtual 10 credits. The round tables are not available for virtual attendees. These are the groups that can get educational credits for today: physicians, nurses, and pharmacists. You'll hear opinions and off-label discussion. In fact, that's really the art of OPMAN, I think, is, we know the studies and we'll talk about those. But the question is, what do you do when your patient doesn't quite fit into a randomized controlled trial or the guidelines? We heard yesterday some place where the guidelines maybe need to be tweaked a bit for modern or some of the newer data. So we will talk about things that are off-label and not in package inserts. We're grateful for our commercial supporters. You can see them listed here: platinum support from ViiV, gold support from Gilead, and bronze support from Merck and Theratechnologies. There is an in-person brochure. It's on your, there's some out front if you don't have the one from yesterday. Those of you who are online don't get the paper brochure, but do have access to the brochure by clicking this link on the OPMAN XXXIII website. There's also availability as we get to the slides. By clicking on the talk, you'll be able to have those slides at home. Email was sent last night with access to day 2 slides. That's for the in-person presentations. And for the virtual as well, you log in and can go to the agenda. Technical assistance: if you need help, click the help button, or you can also email support. You see the email there, performmedia.com. So hopefully things will go smoothly as they did yesterday. We are recording, so both audio and video. We have cameras in the back of the room and a microphone in the middle of the room for your questions. As I mentioned earlier, hold your questions till the end of presentations. We'll have time, and then please use the microphones and silence your cell phones during the presentations. Post-conference, Mike Sag mentioned this yesterday, you will receive an online survey. It'll be sent to the email you use for registration. You'll get reminder emails for up to 5 days until it's completed. My advice: just when you get it, complete it, because they will email you the next day and the next day. So just go ahead and complete it, and that information and feedback is really valuable to us. We actually take it into account. We'll meet, we'll review all the comments, what you like, what you didn't like, what we should have covered, and we will incorporate that in future meetings. We do it every year. Long-term outcome measures, this is really important. Hopefully this meeting, the OPMAN, is optimal management. It's always been geared towards helping people in their clinic take care of patients with the diseases that we discussed, particularly HIV and hepatitis, and now what's been called fatty liver disease. So you will get a survey a few months down the road and respond to that, because this will tell us, did the teaching here and the conversations change your practice? Really important. This will be archived in the future, and you'll be able to see this probably sometime in early April, and you can refer colleagues to this site as well. So it brings me to the agenda. Today, the introduction is me. We'll then talk about hepatitis C. And of course, at one point, this was a major topic, but since treatment has really been simplified, we've lumped it into one lecture, and we'll ask Dr. Nagy from Duke who has joined us in previous OPMANs, to really go through the entire focus on hepatitis C. A lot to cover, but she talks fast, and I'm pretty sure we'll get this done. But we do have time for questions if there's things that we didn't get to. And then we're going to do the same thing for hepatitis B with a focus on HIV. Now, Hep B came up a lot yesterday, so I think there'll be opportunities for some thoughts from Deepika Bhattacharya from UCLA, who can talk to us about some of the strategies of someone who's thinking about hepatitis B most days of the week. And then we'll have time for a panel discussion. And then Ken Sherman will talk to you about hepatitis A, D, and E. We gave him that grab bag or alphabet soup of viral hepatitis. These are important. They came up a bit yesterday. We talked about hepatitis A vaccine. We talked about Mike Sag had a case on Delta. We'll dig into that a little bit more. And hepatitis E is something that we don't think about that much, but maybe we should be thinking about a bit more. Ken is from now Mass General Brigham in Boston, with a foot in the door at University of Cincinnati, where he spent much of his career. We'll then talk about obesity and HIV, and this is a talk that I'm really excited to hear about. I think this is something that also came up yesterday in respect to antiretrovirals, and of course the GLP-1 agonist came up yesterday multiple times. I think it was one of the options on every multiple choice question. So we're really thrilled that Suman Srinivasa from Mass General Brigham has come. She is an endocrinologist and will give us the perspective really on how we should be thinking about weight in our patients with HIV. So excited about that. We'll have time for a panel discussion and answers. We'll pick that back up, and then we're thrilled that Richard Sterling has come up from Richmond, Virginia, where he's a professor at VCU, and he'll talk about what is now called metabolic dysfunction-associated steatotic liver disease, or MASLD. Some of you may be more familiar with the term fatty liver, but this recently changed, and we'll talk about kind of why that changed and how that's fitting in people with HIV. Then our last talk of the day will be Glenn Treisman, and Glenn, of course, has been at OPMAN for many of, if not all, 33 sessions, but certainly a lot of them. And he's going to talk to us about substance use and alcohol use disorder. And this is actually really, I think, every year I learn something from Glenn. To take optimal care of our patients with viral hepatitis, with HIV, or both, we really need to consider substance use disorder in our formulation of treatment plans and a holistic approach to patients. So we're thrilled to have Glenn with us. We'll have time for a panel discussion. We'll take a break. You'll grab food and come on back, and we'll have a working lunch. We'll be in the room here, and we'll go through some case presentations trying to pull together some of the things we've talked about. After that, we'll break for faculty roundtables, and we'll have an opportunity there to have kind of a smaller group session. In general, these don't have PowerPoint slides. You'll have seen hundreds by the end of the morning, and a chance to really talk to our faculty about things in your practice or cases you may have, really interactive sessions. Unfortunately for those, they're only available for people attending in person. So for those of you online, after the case presentations, you can then enjoy the rest of your day. Hopefully the weather is good where you're watching from. For those of you who are here, we'll have 3 options, and if we time it up right, you'll be able to get to 2 of them. You can go to 1, and then halfway through we'll break and you'll switch. We've got hepatitis C challenging cases. We've got hepatitis B and D, more questions and answers. And then we'll have one that's focused on steatotic liver disease. I think that will be they'll all be very interesting, and hopefully you can get to 2 of those if we finish up on time.
Well, good morning, everyone. It's great to be back. I see lots of familiar faces. It's always a question of how much do we talk to an audience of folks who are, have been doing this for a while, and how much do we talk to folks who are beginning to think about getting into this? Because frankly, that's what we still need. So it's great to be here. I hope folks got to enjoy some outside activities yesterday. It was actually a beautiful day here in DC. Disclosures. So I am going to move into this pretty quickly. I am not going to try to cover everything. It's impossible, and those of you who have heard me talk really fast know that it's actually not much fun. So what I want to do, and what I usually try to do for many of you who are returning, is to try to focus on areas that in my own clinical practice that we are trying to do, and what the issues that we're trying to address. The challenges, I think, nationally, and try to bring that to you all so that you can take this back to your practices to think about how you can also contribute to what I think we still hope would be the opportunity for HCV elimination. I'll touch on a number of these things, and I will go back to some basics just to make sure we're all on the same page. But I really want to spend most of our time talking about some of the data that came out of CROI, recent publications, and how that's relevant to how we all need to think about innovative ways to reach our patients who have not yet been either diagnosed or treated. So I will start with some epidemiology, and much of this remains the same from the CDC. And frankly, I'm not sure if we're ever going to see new data from the CDC. So we should just acknowledge that I thought about that putting this together, not to take us in a different road, but how, maybe we've taken some of these things for granted, and thinking about, our need as scientists and clinicians to advocate for how critical these data are for us to take care of our patients and to educate each other. But you all know that the epidemic of hepatitis C really has been biphasic now for some time. We always thought, when I was learning about this, we always thought of this as folks who were in the baby boomer cohort, folks who were older, infected, in the 1960s and 70s. But really, we now know that there is a huge, and as we will talk about, ever-growing population of young people in our country who, because of the opioid epidemic, are getting infected and continue to get infected at really high rates that will make it very difficult for us as a nation to eliminate a disease and an infection that really we believe could be eliminated. And again, when you look at the numbers here, you also see that women are pretty well represented in this epidemic, which is concerning. And we also know, at least by the recent numbers, that almost half, 40% of people who live in this nation still do not know that they have hepatitis C. So one of the things we want to talk about is how do we get those people diagnosed and then immediately into treatment with no delay. And again, this just really highlights those age groups. We know that over the past decade plus, we have seen a 400% increase, again, driven by the epidemic of hepatitis C and acute hepatitis C specifically in these young people. So we all know that the WHO, it's actually amazing. I remember when these first came out, it is 2030 is closer than I'd like to admit. And if you notice in those pictures, I have way less gray hair. So time has moved pretty quickly. And it's amazing that, where we still are in terms of thinking about achieving the concept of hepatitis C elimination. And frankly, as we will talk about, where we as a nation, we were never on the curve, but we are definitely falling off the curve in some of these areas. Liver-related death is the place that we have seen as a nation that we have achieved very well, and I think this is largely driven by direct-acting antivirals and access for people with severe liver disease to a cure. We know that saves lives. We know that prevents people from going on to have decompensation, hepatocellular carcinoma, et cetera. And yet we continue to have major challenges. And I actually think emerging data this year that's really giving us an understanding of people who go into hep C treatment with severe liver disease, that their risk continues. And I think we're now seeing data emerging, 6, 7, 8-year follow-up data from the DAA era that maybe is not exactly what we want to hear and probably what we are experiencing in our clinical practice, which is that those patients are going to continue to suffer from that liver disease for a very long time. I think longer than maybe I would have estimated. And then you can see here that incidence is really where our challenge sits. So we continue to see high incidence of HCV infection. And I will show you that this is where, as a nation, we lead the world, not exactly a place where we want to lead the world. So recent data that came out in terms of just projections, specifically focused on HCV incidence. This is a challenge to elimination globally for hepatitis C. But you can see here that across, this is actually, there's a lot of modeling that's done throughout this, and this is one that I pulled out because it specifically looks at those countries with the highest incidence rates of hepatitis C globally. The U.S. is one of them. This specifically looks at people who inject drugs. So this is a key population that we have got to learn how to reach. Right now, we are failing them because we are failing to reach them, we are failing to diagnose them, and we are failing to get them access. I think last year I talked about this, right? Pill in hand, they need to, when they hit any healthcare provider, when they are accessing any resources, that is the time to get them access to treatment. And Mark mentioned the simplification of hepatitis C. The move that I've tried to make is to make it clear that as complicated as it can still look by the guidelines, the ASOD IDSA guidelines. I think they've done a great job to give you figures and to give you guidance in terms of you can do this in a much more simplified way. In a very resource clinic, there are a lot of things that we can do. Actually, I would query, should we be doing them? Do we need to do them? Because I think those complexities have continued to make it difficult for us to practice in a way that gets access to our most needy patients. So again, right here you can see that the estimated annual number of infections for people in the United States who inject drugs is exceptionally higher compared to all other nations. So our approaches, interestingly, our approaches haven't changed much, right? So you may not remember the title of the talk last year, but I do. And it actually tied to the fact that our very first all oral therapies for genotype 1 infection was exactly a decade last year, right? We had these drugs at hand for a decade, and now it is longer than that. And we are still talking about some of the challenges of getting people access to these drugs, right? So I would argue we have the tools at hand. For elimination, I think you could argue that without vaccination, this may be very difficult, but we have the tools at hand to have much better control over this infection than we currently have. And as you can see, we really have the tools in hand for almost all populations. I would argue with the exception of pregnant people. And that data is coming, right? We know an ongoing clinical trial is enrolling pregnant people currently. And I think many folks, when we can talk about this more, are considering and having conversations with people who are pregnant in their clinics to think about, whether that is the right thing for them to initiate therapy and at what point that should be happening in their pregnancy or after their pregnancy. As I mentioned, we have great tools, and currently, we used to be able to draw on the iPad, and that was super fun. It's hard to be able to point some of these things out for you, but suffice it to say, the summary of this slide is the tools that we are now working with are very high potency and have very high barriers to resistance. And I actually still reflect on this, and we are now working with pan-genotypic regimens. And that is great. The combinations could be with 2 or 3 mechanisms of action, whether those are targeting the protease, whether that is targeting the NS5A protein that does not have an enzymatic activity, but when blocked and bound is has highly active antiviral activity, or targets the actual polymerase itself, right? So we use 2 drug combinations to treat people who have never been treated before, and we use 3 drug combinations to treat people who have been treated with prior therapies on this table and who have failed. I still think, sitting in the room, many of you are also HIV providers, obviously. I still think hepatitis C completely defied what we as HIV providers thought would be the case when we thought about resistance and never retreating with the same regimen. The truth is you can rescue most people, even with a true drug regimen, if you treat them long enough, which is super unique, in my opinion, about hepatitis C. It's a virus that loves to keep us on our toes. So I will talk about simplified treatment, and then further down, further in the talk, we will talk about the potential of using simplification of treatment for same visit treatment. And that is a concept that if you haven't thought about it, if there's one thing that you leave here with, it is to think about how do I treat a patient in the exact moment that I am interacting with them? How do we create a system that treats a patient the day they're diagnosed, or the day they show up into your clinic with a diagnosis, as opposed to saying that we're going to bring you back later, treat you later, think about a different time? I would argue that the time is now, the moment is now to get these people access to treatment. And I worry that we focus so much on 98% cure that we don't think so much about what is better than 0 cure. And what are we comfortable with in terms of, I do think that perfection is the enemy of good. So I want you all to think about that in terms of a mindset. Can you tell that I have 2 13-year-olds? I talk about mindset a lot. So as I mentioned, the AASOD IDSA guidelines have these great simplified strategies to treatment. And I always give them props for putting this out. Even, I would argue, before the data supported it. And I think that's sometimes important to make sure that our clinical practice is ahead or is doing what our patients need. And sometimes that cannot be evidence-based with 5 randomized controlled trials. I'm just going to target a couple of things here that I just want you to think about in terms of what is important, right? What do we not want to do? We don't want to treat someone who has decompensated liver disease with a protease inhibitor or without engaging the potential for transplant, right, a transplant center. So you don't want to treat someone with decompensated liver disease. We don't want to do that. I would argue treating someone with cirrhosis who has fully compensated disease is something you absolutely want to do, and we want to make sure that you're comfortable that that person doesn't have decompensation. But beyond that, we should not make this more complex than it needs to be. In terms of laboratory data, I think you could question, right? Right now, we largely encourage the use of FIB4, which requires someone's age, AST, ALT, platelet count. But I think the question is, how old do those need to be? As a clinician, can you generally assess someone with labs that are a year old and make a determination as to whether or not you think they're at risk of actually being a decompensated patient in your clinic? And I would argue that we can. We can use these treatments now that we currently use in people who have severe kidney disease, even end-stage renal disease. And in fact, we don't give patients ribavirin much anymore these days. So you could argue, the needs of some of these additional labs that we get. One of the things that is really critical, I think, is you don't want to treat someone who has active hepatitis B. So this is going to keep coming back to this. That is one that I think becomes a little bit harder to get around. We don't yet have point-of-care Hep B tests, but we can talk about that, approved yet in the United States. But we do expect that to come. At least we hope that we are on the trajectory of getting point-of-care hepatitis B tests. We'll talk about this, right? We now have point-of-care hepatitis C testing. How many people in this room are using point-of-care hepatitis C testing? Awesome. We have 1 plus 0.5. That was a halfway hand raise. So that's great to see, but it's amazing, right? That this has been a big challenge for folks to actually integrate into their clinical care. And so we need to think about how we can improve that, but also the lack of point of care Hep B testing, I think, has been a challenge for folks. But generally, you would hope that you have people who you could access medical records and understand where they are in their hepatitis B status and understand if they have hepatitis B, that's going to be a slightly different course. And again, the IDSA guidelines have addressed this. They provided guidance now in the guidelines on how can you manage someone that you are testing for hepatitis B in this moment and you want to give them access to therapy, but you're not going to have that result back. And we should talk about this more, I think, in the clinical cases and on the panel, but really thinking about novel ways or innovative ways to not have every piece of information in the moment, but to have the insight and the knowledge coming and to know that you can manage that patient through that clinical situation. You probably also know your patient populations well to know how many, which patients are going to be more at risk of hepatitis B than others. And ensuring that you understand their vaccination status. And there's obviously been great evolution in vaccine knowledge and vaccine access in the past couple of years. And again, pregnancy testing is obviously really important. We don't want to test someone who's pregnant in their first trimester. As I mentioned, pangenotypic regimens, generally I only use 2 at this point in time. It's either the glecaprevir-preventasphere regimen or the sofosbuvir-velpatasvir regimen. Pangenotypic, I don't view them much any differently at all, other than you don't want to use a protease inhibitor in people who have decompensated liver disease or where you are not sure. And we do have some issues with proton pump inhibitor use, et cetera, et cetera. But shy of that, these are fantastic regimens, very well tolerated, and hopefully we can see increasing utilization of these. But these are the key things, right? Decompensated liver disease and hepatitis B, those are the main things, and pregnancy are the things that I think we really have to think about in terms of these more simplified strategies. People with cirrhosis, as I mentioned, these patients absolutely can be treated as part of a streamlined approach. We'll talk about the MIN-MON study that I think really gives us the evidence for this. But again, the key is you do not want to treat someone who may have decompensated liver disease. For people with cirrhosis, we do want to know that they are in a screening program for hepatocellular carcinoma. We don't want to treat someone if they have a known hepatocellular carcinoma. But again, if you are in a clinic where you can either give them treatment now or try to find out if you can get them HCC screening, I would say you should be doing both at the same time. So you can get them screened for HCC while they're on active therapy. So many of you, I hope, know about the MIN-MON study. I think this really was the critical data. There are several other studies that looked at stratified therapies, but the MIN-MON really was the critical study that was a global trial that asked a question. Can we use labs only to determine safety for giving people access to treatment? And can we give them the entire course of therapy and let them walk out the door and not see them again, right? I mean, it's a bit of a question is, can we trust our patients to take their pills? And I think I've learned over many years that we can trust the vast majority of our patients to do what they know is best for their health. And then for others, it can be a struggle because of mental health or current drug use, et cetera. And those patients may need more support and more help to be able to get through that. But as you know, there was no genotyping done. We kind of really wanted to make sure that folks understood that this was not absolutely necessary. Again, in our current days of the fiscal environment, how many of you are asking, what's nice to have, what's not necessary? So that's a pretty good question to ask when you're treating these patients. What's nice to have? All patients got all 84 tablets at the same time. There was no on-treatment follow-up, but there was the ability to contact patients via phone, via SMS, texting, et cetera. And as you all know, cirrhosis was determined by FIB4 only. I mean, Mark, I don't know if you remember when we designed this study, which was run by Sunil Solomon. We really were asking some of these questions. The other thing that was a great debate is, do we have to check core antibody for hepatitis B to enroll people in this study? And we felt very strongly that if we did that, it would not make the ability to get people on hepatitis C treatment easy, and so we decided against it. So again, really proved that the knowledge of isolated core was not critical to initiating people on treatment and achieving a safe access to cure. And what happened, as you all know, 95% cure. And so, this really was data to say that this can be done, it can be done safely, and it can be done in a much more minimalized approach. It doesn't have to be done that way. But I think we need to think about patient populations where it needs to be done that way if we're ever going to be able to get them access to therapy. So this is not old data. I showed this to you all last year. Where are we now? We still have only 1 in 3 people who know that they have hepatitis C cured in this country. 1 in 3. And if you start thinking about other social drivers of health, do they have insurance? Do they currently use drugs or inject drugs, which is the group under 40, as you can imagine, or do they have both? And you begin to see that those numbers are even worse, right? So this population, we are not reaching in the way that we need to. That is related to the incidence, and that also is related to the fact that we have to think more creatively about how we get to folks who may not be able to make it into our clinics. There are some other statistics that are out there I'm going to share with you. Some of this is from the past couple of years, but I've tried to also pull data that has been published in the past year and or was presented at CROI just to give the landscape of where we are today on maybe making the argument for why we need to do things in a more innovative approach. So one is we know from data, of prescription data for people for DAAs, that if you are diagnosed, and what that really meant was if you had a test that said that you had hepatitis C, your chance of getting access to a DAA treatment in the next year is about 35% at best. And I want you to just pause and think about, if I had a patient in my clinic who I knew had hepatitis C, why would it take me more than a year to get them access to treatment? And there have been barriers, right? Prior authorization, other challenges. Some of those have gotten much better. But the question is, are we continuing as providers to be able to take advantage of that and to improve these numbers? And you can see that that's for people who have private insurance. If you don't have private insurance, those numbers are actually less than 25% getting access to a DAA with a known hepatitis C diagnosis, where someone tested the test, so they were interested in knowing if that person had hepatitis C, but had not been able to get over the hump to get them access to treatment. In this other figure that you can see that has 2 lines on it, the green line is DAA. The green line, this is actually totally backwards. The colors are wrong. So the orange line is actually the DAA initiations. How I didn't catch that before, I don't know. But and then the green line is the actual new infections or incidence infections. So a couple things. One is you can see that when the oral therapies were approved for DAAs in 2014, we saw a great increase immediately in DAA prescriptions. And then they fell. And it's continued to fall every year that we have seen. And this data is from one large prescription pharmacy database. But this was literally just replicated in a totally different, very large national prescription database. And it's exactly the same. and that is updated through 2023. So we are not prescribing as much. Now, granted, you could argue that's because there was a huge number of warehousing patients, and that is part of the issue. But remember, we are seeing still delays and large numbers of people. If you would argue that that was true, then ideally we would be more at like 80% of people have been treated, not a third of people have been treated, right? So there are a lot of people out there. We're just not getting to them for various reasons. And again, you can see in the green line, which is the new infections, we have plateaued in incidence. So actually incidence numbers have plateaued. They're certainly not going down. They're not continuing to go up as of the most recent data. But this remains a significant challenge. So pulling data out from CROI, which really focuses on, because most of what I've shown you to date are in people without HIV, but this is data from CROI that tells a little bit of a different story. I'll give you several different stories from CROI regarding hepatitis C and people with HIV, Hep C. But the first panel is from the NA Accord cohort. And what they wanted to look at was in over a period of time, which was from 2014 up to 2021, they thought of people from their cohort, right, very large data set, who met criteria for DAA therapy, but were not initiated on DAA therapy. So you can see in 2014, when they first looked at that, there was a gap between people who met criteria and people who had received DAA therapy. And that gap was 77%. It actually is great to see. That gap has closed, as you can see, from 2021 to 6%. Now, part of that, as you can see, the blue line and the red line are people who no longer have the ability to get HCV therapy or meet criteria. Some of those people's viral loads cleared, probably because they got treated outside their system that they couldn't see or somehow had natural clearance over time. And then some of those people did die with hepatitis C. But that's really great to see. So we're closing the gap potentially in people with HIV more so than people with Hep C monoinfection. And that's because those people are probably coming into clinic, right? Potentially more engaged in care because of their HIV. The other slide is actually from CNICS, which is the CFAR Integrated Network of Clinical Sites, that is looking at incidence in people with HIV and hepatitis C. So looking at new cases in their cohort, as you can see, over periods of time. And you can see that even though in people who inject drugs, which is the folks on the end, on the right side, you see numbers dropping over time, you would also argue that they drop from, right, the 1995 to 2005. Moving forward, but now they've plateaued. So I would actually argue looking at incidence of hepatitis C in people with HIV looks very much like our country. We've plateaued. We're not getting anywhere right now. And generally, I know people in this room do not like the concept or the idea of we're plateaued and we're not getting anywhere right now, right? I think the other thing that this group really targeted and focused on was in the men who have sex with men group. You can actually see an increase, in fact, a doubling of incidence in that very specific population who do not report injection drug use. And this is something I think that we are all seeing, right? If you actually look at our PrEP clinics, we see new cases of hepatitis C in our men who are in our PrEP clinics who are not reporting injection drug use, right? So this is a really important group for us to think about. And again, I'm not going to dig as deeply into this one, but this was a really nice publication that came out recently looking at a very large global cohort of patients. What this gets to is the delay in access to treatment. And showing that in people who have a delay in access to treatment for up to 36 months, there is a very clear, as you can imagine, negative benefit as it relates to them developing liver-related events. They also saw that in that 36-month period, people with HIV and hepatitis C had still not been treated over a 36-month period for their hepatitis C infection. And again, recent data looking at, so in the panel on the left that has the three lines, green, purple, and blue, is actually data from the DAA era, looking at people who are coming into treatment with DAAs with severe liver disease or cirrhosis, and actually showing over a 6-year follow-up period. I think what matters most to me is that green trend line of HCC cases. So HCC cases, as opposed to the lines that I think of from the interferon cure days, where you had an increase for about 3 to 4 years, and then you kind of had more of a plateau, that this line just kind of keeps on going. And I think we're all seeing this, right? An 8% rate incidence per year of HCCs, and that is exactly what we are seeing in our clinical practice currently for HCCs in particular, and that's very concerning, as you can imagine. And then the data, the other two slides really is looking at people with HIV and showing that if a person with HIV, if you come into DAA cure with severe liver disease, over 3 to 5 year periods of follow-up that folks are reporting on right now, we are not seeing the regression of liver disease. And this is based on follow-up with elastography over time. We are not seeing that quote-unquote regression or that decreased risk, I would argue, with elastography, which can't really get to regression in my opinion, but that decreased risk that you would hope to see of having severe enough liver disease and a high enough elastography to predict a risk of HCC, that risk is continuing. So it really gets to the urgency of getting these folks on therapy. All right, so for the sake of time, I will say that so when we think about what the challenges have been to date, we know that risk-based screening strategies were a major hurdle for us. We no longer have those. We have universal screening. We're still missing 40% of people. Complex testing algorithms, right? So we've moved from an antibody and then a new visit for an RNA to reflex testing, but that is still a major challenge for us because we're still waiting for a period of time to know whether that person sitting in front of you in clinic actually has active infection. We have people who have tried things like giving them drug anyway, getting their test back, and then deciding whether or not to withdraw drug. Those have been tested in clinical trials or clinical studies. But really, point-of-care testing is what needs to address that for us. And how do we get more than 1.5 hands raised in this room to be able to access point-of-care testing? Again, before our therapies were, not fun to talk about. Now we have DAAs, but I don't really think that we're leveraging DAAs in the way that we need to get access to our patient populations. And so I am going to talk really briefly about something that we've been doing in our clinical practice in our VA. So I'm going to burn through a couple of slides just because of the sake of time to try to get to people who are walking in our doors. So this is just talking about point-of-care testing. And as you can imagine, point-of-care testing allows same-visit treatment. Now, you could think about point-of-care testing and same-visit treatment, but many of us may sit in clinical practices, right? So how do we apply that concept? And we thought about this in our VA practice, and we actually mimicked this on a clinical study that was actually done in Iceland called the Opportunity C study that actually looked at, right, they have a large injection drug use population. They're a very small country. They took people who were being admitted to the hospital for complications related to injection drug use or other reasons and said, can we get these people on treatment during their hospitalization? Or at the time that they walk out the doors of the hospital. And what they were able to show, as you can see here, is that they could get people to treatment completion at twice the rate as people who were basically, their hepatitis C was addressed as part of standard of care, which was we're going to refer you to a clinic. They were able to get people initiated on treatment at 86%, again, about twice the rate. Now, interestingly, if you look at actual SVR numbers, they were almost the same. But that is because they lost people to follow-up, not because people lost opportunity for access to treatment. And to me, those are two very different things in defining an SVR. So we have started doing this in our VA patient population. I'm happy to talk about how we're actually starting this at our Duke University Hospital as well. But we use a national dashboard. In the VA, every veteran who's ever had a hepatitis C test, we can see. So we have a dashboard now, and if any veteran touches our healthcare system who has a hepatitis C, evidence of hepatitis C infection, we get an email. And it tells us this patient just walked into the ED. This patient just is admitted on the 9th floor in the mental health suite. This patient's on service or is in the ICU right now for DKA or whatever, right? And so what we do is we approach them. And we monitor them and talk to them throughout their hospitalization. And then we, at a minimum, have them walking out the door with a DAA treatment. And so we've started doing this in the past year. So these are pretty small numbers. I hope when I see you again next year, we can actually share more of this, or maybe it'll be published. But what you can see is that of 22 people, there are a couple things that I would summarize. One is we thought that these would mostly be young people who are injecting drugs. They're not. These are mostly people, as you can see, who are in their 60s. They are largely men. 50% of them actually have severe liver disease. That is surprising, right? And you can see that about 10% have HIV infection. Almost 20%, a little over 20%. This was a new diagnosis for Hep C for them when they walked into the hospital and got a positive test and then got flagged for us. And the majority were candidates for DAAs. And the only definition for us of not being a candidate is that you have a terminal illness where you will not likely survive the next year. And you can see that we managed to prescribe 12 patients with treatment. And so far, we have achieved an SVR rate, interestingly, very similar to Opportunity right now, which is 64%, with very, very small numbers. We have a number of people who are still on treatment that we hope to have results from. And I'm happy to share more about how we've managed this, but also what some of the challenges have been in getting people access to treatment. So that is my last slide. I won't summarize this since I'm out of time, but happy to talk more about this in the cases or on the panel.
Thank you so much, Mark, for that very kind introduction. You all should know that both Dr. Slawkowski and Nagy are also past chairs of the Hepatitis Transformative Science Group. So first I wanted to just start by saying thank you to Susanna for a really wonderful talk. It's always hard to follow her, but we will certainly do our due diligence. And also thank Mark and the other organizers for inviting me. So I'm really excited to talk to you today about hepatitis B. I think a question that has really come up a lot more lately, especially as we've moved to long-acting injectables for the treatment of HIV. And so we'll come to discuss those as well. So here are my disclosures quickly. And then let's go ahead and get started. You know, one of the things that I like to remind folks is really how important the global burden of hepatitis B disease really is. So if you think about it, we think about 35 to 40 million individuals living with HIV in the world. What about hepatitis B? And so it turns out that if you think about hepatitis B, it's 254 million individuals living with hepatitis B globally. 250 million individuals. On top of that, there are 2 billion exposed, 2 billion people in the world exposed, and that means at risk of reactivation. And that's in comparison to 50 million people with hepatitis C and the 35 that we talked about for HIV. And so, again, just a reminder of the true global burden of this disease. And despite having good diagnostics and very effective antivirals, only 13% of all individuals globally with hepatitis B have been diagnosed and less than 3% treated. So if you think about that cascade of care that we're so used to seeing in HIV and hepatitis C, and really realizing that that is not the case for hepatitis B. And many of you are aware that the global burden of disease really does lie ex-US. And so the largest proportions of individuals with hepatitis B are in areas of Southeast Asia and also Sub-Saharan Africa. But a reminder, though, that in foreign-born individuals here in the US, there is a high prevalence of hepatitis B. And so a really important, again, a really important reason to think about hepatitis B. A reminder again that viral hepatitis is the second leading cause of infectious diseases death, and about 83% of them comes from hepatitis B itself. And liver cancer deaths, as we were just looking at, are really on the rise. So 40% of those liver cancer deaths are from hepatocellular carcinoma globally. And so we really need to get to significant scale up and of testing and care to reach those WHO elimination goals that you saw Susanna present, really, by 2030. So now let's shift gears a little bit and talk about HIV and Hep B co-infection. So I should have mentioned as we started, we are going to be shifting gears a little bit as well, and that we're going to be a case-based discussion. So before I forget, you do have QR codes on your tables. We'll talk about some cases. Oh, wow, that happened quickly. Okay. They're right on top of it. All right. So for HBV and HIV co-infection, a reminder that this is also a prevalent disease in persons living with HIV. So 5 to 10% of individuals globally have hepatitis B with HIV, and that's higher, particularly in Sub-Saharan Africa, where it's about 10 to 15%. Persons living with HIV and hepatitis B have higher levels of HBV viremia, higher levels of HBV replication. They have higher mortality, at least in earlier data, compared to persons with HIV or Hep B monoinfection alone, higher rate of chronicity. And then the risk increases of developing hepatitis B with a lower CD4 at the time of acquisition. Despite having a greater progression to disease, persons living with HIV and Hep B have lower ALT levels overall, but they still have a faster progression to cirrhosis, and they do have a higher incidence of lamivudine resistance. Now remember, we don't use lamivudine as much anymore, certainly not in hepatitis B monoinfection, but it is noteworthy that resistance does occur at a higher rate in those living with HIV and hepatitis B. All right, so here's one of my favorite slides. I'm going to take you back to medical school, and I really want to review some of these important points about the hepatitis B life cycle. So what you see here is a little pictorial of the hepatitis B life cycle and different areas where novel drugs are really being targeted for hepatitis B cure that Mark had kind of talked about. Let's see if I can figure out my pointer here. Oh, okay, all right. So here's the virus coming in through the various stages of the life cycle. This is the hepatocyte. This is the cytosol. Here's the nucleus. So the virus comes in, kind of uncoats, and then comes into the hepatocyte where it establishes the latent reservoir of hepatitis B. And this is called cccDNA. And what I like to tell people, what I like to teach trainees, is that this cccDNA is, one, the reservoir of hepatitis B disease. It's why there is always a risk of hepatitis B reactivation in individuals who've been infected with hepatitis B, because, again, this is the reservoir and always remains. And this reservoir, I like to think about it like HIV in the lymphoid tissues, and I also like to think about it as latent TB. So much in the same way that we think about TB when you get infected or exposed to TB, I want you to now think about hepatitis B in terms of latent hepatitis B. So after coming into the nucleus, it's then transcribed into multiple RNA products, and then those RNA products then come out to be translated into various proteins, including the surface antigen molecules, and surface antigen that goes on top of the virus. But there is also a parallel pathway which is impacted by the reverse transcriptase, where the actual virus is made and then is transported out as the mature HBV virion. So the first question that I always get asked on rounds is, so if you have hepatitis B and if you have treatment for hepatitis B, right, and you are impacting this stage, the reverse transcriptase stage, this is where the nucleotide analogs work, you can get suppression of HBV viremia, but why don't you lose hepatitis B surface antigen? And that's because there is a parallel pathway. And so the pathway that's making the virus is suppressed with the nucleotide analogs, but there is still another pathway that's producing the surface antigen molecules. So that, I think, is a really important concept, especially as you're trying to educate patients as to why their surface antigen is still present despite the fact that their HBV DNA is suppressed. Let's backtrack a little bit and talk about why it's so difficult to cure hepatitis B. Well, it's much in the same way that it's difficult to cure HIV. So remember, you've got this latent reservoir of hepatitis B that's sitting there in the cccDNA. It also integrates into the host genome, and so between the integrated DNA and the cccDNA, it is, again, very hard to eradicate, in fact, impossible to eradicate with current antiviral therapies. In addition to that, just like HIV, there is immune exhaustion that happens, and that also is a deficit. In particular, we think about the CD8 response as being the most important deficit, but I think increasingly we're realizing the importance of the B-cell response and also some innate immunity. I do want to make a point about these surface antigen molecules, because I think that'll become important, in the future when we start talking about hepatitis B cure therapies. But these hepatitis B surface antigen molecules that are being made, there are ones that go onto the actual virion, but there are also others that are kind of produced in showers, really. And I like to think about it, because I'm a parent of an 11 and a 6-year-old, I like to think about it as, how does one get exhausted, right? So if you think about hepatitis, no, it's true. If you think about hepatitis B as kind of a soccer ball, which is the mature virion, and then you think about the surface antigen as kind of confetti, and if you think about the volume of the virus and the volume of the surface antigen that's being produced, the volume, if you think about the size of a soccer ball and how easy that might be to clean up, if you will, by the immune system, and you contrast that with the confetti of these surface antigen subviral particles that's really produced almost in the volume of that same soccer ball, you can see why the immune system is going to get exhausted. And so what we now understand is that it's actually part of what drives immune exhaustion, which is a hallmark of chronic Hep B, much like it's a hallmark of chronic HIV, is this volume of the confetti of these surface antigen molecules. So think about how exhausting it is to clean up the surface antigen, the confetti that might be showered, right, after a birthday party compared to the soccer balls that you're picking up. And that's really, I think, a nice analogy for the immune exhaustion, and another one of the reasons it's very difficult to clear hepatitis B. All right, now that I've taken you back from medical school, let's come on back. So what I do want to start by also doing is reminding you about some of the changing guidelines and the importance really of universal hepatitis B screening. So in 2023, the CDC recommended universal hepatitis B screening. We had recommended that for a while, since 2020 for hepatitis C. That was updated in 2023 for hepatitis B. So just a reminder that for all adults age 18 years and older, that they deserve at least a once in a lifetime screening for hepatitis B, of course, and of course, anyone who requests it. And in addition to screening, the CDC has recommended the 3-test panel, and that's going to be surface antigen, surface antibody, which is anti-HBs, and then also core antibody or total anti-core. Unchanged screening is what we've had in the past, which is recommended for all pregnant people during each pregnancy, regardless of vaccination status or history of testing. Anyone with a history of risk, which is very well defined in the CDC guidelines, but certainly, of course, men who have sex with men, individuals living with HIV, and injection drug use, I think, are some of the primary ones. And then periodic testing for susceptible persons with ongoing risk, which was expanded to include incarcerated individuals, persons with a history of sexually transmitted infection, or multiple sex partners. So again, just a reminder about the revised hepatitis B screening guidelines. And so now that they're having us all do a triple screen test, I think it's also important to review what these serologies mean. So I'll just, again, walk you through, maybe this isn't medical school anymore, maybe we're in residency now, but talking about the interpretation of the HBV serologic results. So a reminder that if the surface antigen is negative, the total core is negative, and the surface antibody is negative, those individuals are susceptible to hepatitis B infection and need vaccination. For those individuals who are core positive and surface antibody positive, those individuals have what we call resolved infection, but because they have core antibody positivity, remember, I think about the core as a quick and dirty for CCC DNA, the C in the C, and that is a signal that they can reactivate. And then if someone is just surface antibody positive, those individuals are immune due to hepatitis B vaccination. Of course, if you're surface antigen positive with core positivity, those individuals have chronic hepatitis B. And then the last row are those individuals who are core positive but surface antigen negative and surface antibody negative. This is a serologic profile that we call the isolated core profile, and that could really represent one of a number of of situations, but it really most likely represents resolved infection, but with just waning surface antibody titers. But it could also represent what we call occult hepatitis B, which means there's a defect in the way the surface antigen is being produced, that it's not being recognized by our assays, and you actually have low-level viremia. It could be resolving acute infection, and very rarely it can be false positive. I mention isolated core because it's actually more common in persons living with HIV, and also very common in persons living with HIV and hepatitis C, and it's something that comes up often in terms of vaccination and treatment. All right, so let's go to our first case. You ready for your QR codes? All right, so this is to vaccinate or not to vaccinate. So this is a 41-year-old person with HIV infection who's on Biktarvy with a CD4 count of 190. His HIV viral load is undetectable. Has had multiple male partners in the last 2 months. You've done your due diligence, and you've realized that his surface antibody is negative in addition to surface antigen and anticore. His HCV is negative. So what would you do next? Would you wait for his CD4 count to go above 200 to immunize? Would you immunize with a single dose of recombinant hepatitis B vaccine? You'd say, we don't have to worry about immunization because he's on a tenofovir agent, or would you immunize with the CpG adjuvanted HBV vaccine or Heplisav-V? All right. Okay. All right. I think most of you got the correct answer. There's nothing to teach you. So immunize with the CpG adjuvanted HBV vaccine, which is Heplisav. That's great. I'm really glad that these are out now in the I'm really glad that people have really taken this on and understood this. So talking about the hepatitis B vaccines, there are many that are available to us. So there are the traditional vaccines, the Recombavax and the Engerix. And what's important to remember about those is that they do have to be delivered on a 3-dose schedule, 0, 1, and 6 months. And then, of course, there is the Twinrix, which is a combination hepatitis A and hepatitis B vaccine that also has to be delivered on that older hepatitis B vaccine schedule of 0, 1, and 6 months. But then there is the new kid on the block, not so new anymore, that was FDA approved in 2017, and that is the adjuvanted hepatitis B vaccine with an immune adjuvant that really heightens its response. And the other important thing about this agent is that you only have to give it twice, so 0 and 1 months, which has been wonderful for uptake. So here are the current guidelines on HBV vaccine dosage for persons with HIV. So the primary vaccines, you do have a choice of any of these vaccines. The reason the question was erroneous was because we talked about 1 dose, but you really could choose any of these. But I'm going to make a case for why we think Heplisav might be better at this point. And so any of these are doable with Heplisav also added in the last year or two. Sometimes people don't respond, and so there is a second series recommended, including double dose of Engerix, but also Heplisav is recommended there. And then a reminder that we now also recommend periodic testing of surface antibody to see if there is waning, and then for a booster if individuals fall below the 10 threshold. So I want to talk again about another ACTG study. You heard about MinMon, which was focused on hepatitis C. This was a large study that was co-led by Dr. Sherman, who's in the room here, called the Beehive study. And this study looked at this novel adjuvanted hepatitis B vaccine, the Heplisav product, and looked at 2 different groups. One, the group B on the bottom, who had no prior hepatitis B vaccination, so similar to the person that we were just talking about. And in this group, those individuals got 3 doses of Heplisav, not 2, but 3 at 0, 4, and 24 weeks. And then there was a group that we'll talk about a little bit later, and that was the group A, who had a non-response to conventional vaccine. And they were randomized to 3 different arms, either 2 doses of the adjuvanted vaccine, 3 doses of the adjuvanted vaccine, or the standard vaccine schedule. And the seroprotection response, or SPR, was defined as a surface antibody level of greater than 10, which is of course, the outcome for all vaccine studies. And so what I wanted to show here is data that was published now a couple of years ago, but really looking at, in the vaccine-naive group, which is the patient that we just talked about, the incredible response to this vaccine. So if you remember again that in this group, they were given a vaccine at entry at week 4 and at week 24, and then were assessed for seroprotective responses 4 weeks after the 24 week, you can see here that 100% of individuals had a seroprotective response. 100% of individuals with HIV had a seroprotective response, which is frankly was not seen in other studies of hepatitis B vaccine. The other thing that I want to point out is that this was 3 doses that were given as part of this study, but even if you looked after 2 doses, you can see here at the point that you would measure at week 8 that it was 87%. And then if you waited another month after that, the seroprotection response was 94%. So this is the data that led the guidelines to be changed to include Heplisav as one of the primary recommendations. And then at CROI this year, we had some updated data about the durability of these responses. So I show this slide again so you can remember we had 2 different arms, vaccine naive and also the non-responders, and they were evaluated kind of en masse in terms of the durability of the seroprotection response. And so if you look here at this slide, you're looking at the 3 alum, the 2-dose and the 3-dose of the adjuvanted vaccine, and then the vaccine-naive group, because remember, we didn't have a comparator arm for the vaccine-naive group. And what you can see here on the very blue bar graphs, if you will, of the primary and end of study for each of these different arms, I think the thing that is most impressive to see is that everybody in blue had a seroprotection response that was greater than 10%, And so if you look first at the 3 alum dose, you can see that by end of study, only about 58% of those individuals still had surface antibody titers at the greater than 10 range. Whereas if you looked across all of the Heplisav groups, there were very few in that less than 10 range. But also, what was very interesting was the height of those titers. So if you see in kind of the very blue, greater than 1,000, right, that we're talking about of surface antibody levels, IUs per ml, that is represented in the group B and 3 dose series of anywhere from 33 to 40% afterwards, in addition to levels from 100 to 1,000 in 43 to 47% of individuals. So really high levels and that persist end of study in these individuals who received this vaccine. And I think that has real implications for how we'll talk about durability of response and how we might address those individuals who are on long-acting therapy. All right. So this gives me a chance to talk about CDC updates and universal vaccination. So in addition to universal screening, we now recommend universal vaccination. So all adults 19 to 59, greater than 60 with risk factors or if requesting. And then, of course, we've talked about the vaccine options. All right. So let's talk now about isolated anticore and a medication switch. So this is an individual who's 41, again on Biktarvy, surface antigen negative, but now this person has the core antibody positivity. So remember, core cccDNA, and he wants to switch to a long-acting injectable that does not include tenofovir, right? So it's not going to include Hep B active therapy. How would you counsel him? Continue the current ART regimens. Because you can't switch off of HPV active ART regimen, so he should not get long-acting therapy. Discontinue HPV active ART but initiate entecavir, another hepatitis B agent. Discontinue HPV active ART, vaccinate for hepatitis B and start entecavir, or discontinue HPV active ART, vaccinate for hepatitis B and monitor for ALT elevation. All right, okay, we have a good spread. And so I think that's indicative, of how we're all approaching this in clinical practice. So the answer the answer that I would have chosen is discontinue HPV active ART. Go ahead and start long-acting injectable therapy, vaccinate for hepatitis B, and monitor for ALT elevation. And the reason that I recommend that, and the guidelines recommend that, I think there's evolving data, and so I think we will continue to see data that's going to inform this practice. But I think an important study was one that was done presented in ID Week at 2023 that evaluated, again, in the VA system, HPV reactivation in individuals with the isolated anticore pattern who were then switched off of HPV active therapy. And in this group of almost 6,000 veterans, there was only a 0.7% incidence of either new surface antigen positivity or HPV DNA positivity. So really less than a 1% chance risk of hepatitis B reactivation as defined by the surface antigen positivity or HPV DNA positivity. But what I thought was really interesting about this data was that the median time to reactivation was long. It was 292 days, which really makes you wonder about whether this was really reactivation or was this incident hepatitis B. And this is where the data from the durability of the response from the novel hepatitis B vaccines, I think, really comes into play. And so is there a role of doing either Heplisav in general or the 3-dose series, particularly in individuals who are going to be coming off of hepatitis B active therapy in this space? And I think that's an unanswered question. All right, so we mentioned this briefly, but these are indeed the DHHS ARV guidelines, and we want to ensure that you have labs within the last 6 months. You want to vaccinate, and if they're surface antigen positive, you're not going to stop therapy. You're going to make sure that you continue, but if they're core positive, you can do LFT monitoring. All right. Let's go to our next case. This is somebody with core antibody positivity who is immunosuppressed. This is a 50-year-old woman about to receive Rituxan who's core positive, surface antibody positive. What would you do next? Would you check HBV DNA and, if undetectable, monitor carefully? Would you initiate antiviral therapy with tenofovir until completion of chemotherapy? Would you initiate antiviral therapy with entecavir until at least 12 months after completion? Or would you monitor labs and if only then start treatment? Oh, all right. Another nice spread. Okay. So again, I think reflecting really kind of how we're approaching this, how there are some differences. So, we're still voting. We can, yeah, thanks. Okay. So if we go back to the slide, so I would initiate antiviral therapy with entecavir until at least 12 months after completion. And that is because these individuals are at risk for reactivation. And we've seen that particularly with rituximab, where there is a black box warning for reactivation. These are some newly released AGA guidelines that I won't go over in detail, but just to let you know that they exist. They do have a flow chart for how to manage individuals with Hep B, stratified by surface antigen positive or surface antigen negative, and then stratified by low, moderate, or high risk reactivation risks. And it's a very helpful guidance document, so I provide it here. And so let's go to our last case, and this is an individual who, upon routine screening, we've shifted now. We're not going to be talking about persons with HIV anymore. No HIV, a 43-year-old gentleman who's born in Ghana, and you heard that maybe his grandfather died young of cancer, maybe stomach or liver. He's surface antigen positive, E antigen negative, his ALT is 40, his HBV DNA is 8,000. What would you do here? Would you assure him he's just a Hep B carrier, no follow-up is needed? Would you tell him to see a hepatologist because HBV is a liver issue? Would you offer him treatment with entecavir or tenofovir? Would you tell him to return in a year for repeat testing? All right. Okay. Let me go back and see. It's hard to see for me what those are. So excellent. You can tell that we're ID physicians in this room, because that is exactly what I would do, is offer treatment with entecavir. And if we go to the next slide. Thank you. I think it's important to at least briefly review the various different stages of chronic hepatitis B, right? We are going to be thinking about this more, I think, in the ID space. And a reminder that those who were infected in infancy go through multiple stages. It's a very dynamic disease. There's the immune tolerant phase, the immune clearance phase, the low replicative phase, and then for some, about 30% of individuals, the immune escape phase. And right now, we have, by AASLD guidance, we actually, first of all, we don't treat everybody. That's not the recommendation. We wait until there is liver damage or evidence of liver inflammation and elevated viremia to treat. And so this individual is kind of in the immune escape phase, where he has lost his E antigen, he still has HBV viremia, and he's just on the cusp of having elevated ALT. And actually, under current HBV treatment guidelines, the 2018 AASLD guidance, he would not meet criteria for treatment because his ALT is not greater than twice the upper limit of normal. There are various guidelines here represented by both, including AASLD, but EASL, APASL, and the WHO. Those are the older guidelines. And as you can see, there's a lot of nuance and a lot of discrepancy between these guidelines. Now, EASL is going to be updated. AASLD is going to be updated. But I think perhaps most important to note is that there really is an evolving treatment approach. There is emerging evidence that early integration of HBV DNA leads to oncogenesis. We know that antivirals are safe and can be generic. And the previous guidelines, frankly, have been complex, and there is a real need for simplification. So in that vein, many have simplified. And I think the most important one to point out here are the WHO guidelines, which were released in 2024. And here we do recommend treatment if the HBV DNA is greater than 2,000 and the ALT is any elevation above the upper limit of normal. So by WHO guidance, this gentleman would meet threshold for criteria. But again, this is a dynamic space. There are going to be evolving updates. But I think, one thing, and I want to credit Susanna for this on a different panel, one thing that I think it's important to note is that you don't need, we think about the guidelines as these restrictive, sometimes restrictive and proscriptive guidelines, but really you have permission to treat somebody with hepatitis B, and particularly if they ask for treatment, even if they don't fall into kind of the neat guideline strategies. So these are the FDA-approved hepatitis B therapies. I am looking at the time. I know I'm over. And so I think the last thing I want to say, we can skip the case here, but I do want to make a point about TAF versus TDF. This is an HIV and person with HIV and hepatitis B on in which you're choosing the therapy. And here, I want to point out the Alliance study. This was a randomized, placebo-controlled study with HIV and Hep B co-infection. They were randomized to either tenofovir alafenamide-containing regimen or TDF. And in this study, there was a difference in both HBV DNA undetectability as well as surface antigen loss. And I think the question is that, was there something in the baseline data? Did they have more individuals who were on TAF who actually had low quantitative hepatitis B surface antigen levels, which does allow you to have a higher incidence of surface antigen loss. But what's interesting about this data in CROI, they showed follow-up data where individuals who were initially randomized to the TDF arm were allowed to switch over, and in those individuals, they did indeed have resolution of their ALT elevation. So in the interest of time, I'll end here with the summary, which I won't repeat here, but want to thank you for your time and attention.
Well, great. We've got some time for some questions and answers, so we'll ask Susanna to come up, and we'll. If you have a question, please come to the mic in the room. I'm looking on the iPad here to see if there's any questions. So maybe I'll start with a couple. Oh, go ahead.
Both great talks. Doug Russ from Florida. I'm almost chased out of Florida because of the hurricanes, and I was really strongly considering joining Carolyn Wester's group of eliminating hepatitis C. So I want to just I didn't because of the funding. So I want to just ask some questions. HIV, I've been in this a long time. HIV, we're looking to end the epidemic. And yet we're trying to eliminate hepatitis C. And it's philosophically very different. And I was just wondering if that's aspirational. Along those lines, even if Francis Collin is advocating for funding of this program, where do we stand with funding with the CDC? And a major issue in our offices with elimination of this disease is that our pharmaceutical partners give us samples for HIV meds so that we can immediately start the same day treatment. And it's also then easier to go to the insurance company because the patient is already on. So where do we stand with getting DAAs in our office? And then finally, since there's no vaccine, and since there's no, once you're infected, there's no sterilizing immunity you can get reinfected. I know it sounds ridiculous, but where do we stand with PrEP for hepatitis C, especially long-acting PrEP? What was the thought before, at least in the community, it's so easy to treat that, let them get infected, then treat them. But while they're infected, they're infecting others.
Yeah.
Well, let me tack on another question that came in through the online. Acute hep C, which I think relates to Doug's question about PrEP. So if someone at risk for reinfection, would you just wait for the acute hep C, then would you treat that? Or would you is there a role for PrEP? And the question is, the specific question is, would you observe acute hep C or would you treat immediately? Yeah. So I'll give that one to Susanna.
Okay, you can hear us all. Great. Okay, I made a list. That was a really excellent questions and comments. I might just maybe work through it, and I'm sure that Debica and Mark will have other comments. So to get to the eliminate versus ending, again, my opinion is, as you mentioned, those are very different words. But these are very different viruses, right? Because we can eradicate hepatitis C from the host, and right now we cannot eradicate HIV from the host. So to me, that is, in my very linear thinking, is that is the difference in many ways between the ability to eliminate an infection from the planet versus the ability to control, right? Ultimately, I'm sure we would love to get to a time where there is no HIV, but think of the large population globally with that infection to which we currently have no ability to cure. But we can cure hepatitis C. Now, I think many people would argue, can you truly eliminate an infection from the planet if you do not have a preventative strategy? And so I do think that folks believe that whether it is a vaccine or an approach to prevention, that is critical, right? Right now, what are the tools that we have? We have the ability to, again, we think about treatment as prevention in HIV. I think we all believe that treatment as prevention in hepatitis C should make sense too, right? These are viruses that are spread from person to person through blood and other contact. If you have less people with the infection to transmit, then you should have less transmission and therefore the ability to continue to drop these. But without a vaccine, and I think without PrEP, we have, as I mentioned, harm reduction strategies, which are critical. But as you know, those are state-based. Those are for reasons I can't explain political, and so we are not able to get access for many of our patients depending on where you are. I might let Mark talk to the concept of PrEP. I think there is a big push to develop long-acting agents for hepatitis C, presentations and discussions at CROI. And so if we can get to that, then I do think there is a potential for prevention. Mark and Dave Thomas and I wrote an article a long time ago that was focused on healthcare providers and whether or not you should even do post-exposure prophylaxis. And, there was a great debate about this, but because we can actually eliminate the infection, it was a very different approach, right? But I do think if you're thinking about truly elimination, you have to think very differently than the individual person. So, I hope we have long-acting injectables. I hope we can get to the point of thinking about prevention. I think we have an ability to make impact even in decreased transmission now if we can get more people cured, right? Because the less people we have who can transmit, the better chance we have of getting to elimination. And then for acute hepatitis C, I think the guidelines moved on this a long time ago, which is you should treat acute just like you do chronic, and I would argue you should treat them the minute you find them, right? Because again, those are folks who likely are, if they're recently infected or newly infected, they are at risk of transmitting. The key is don't let them walk around with virus that they can transmit. Get them on treatment. That is the best opportunity. And frankly, the majority of people, right, this is very different than hepatitis B. The majority of adults who get infected with hep C will go on to develop chronic infection. So you shouldn't wait around.
Great. Well, I think maybe what we'll do is we've got a lot of questions coming online. If you have some on the mic, please come. We'll go to the mic, and then we'll do a couple online ones.
Thank you. The first question has to do with point of care testing for hep C. What's available? What do you use? I remember a saliva-based one. Do we have antibody and DNA? And then my other questions have to do with follow-up with, in hep C, adequately treated patients, but maybe if we have access to FibroScans, some fibrosis, maybe not cirrhosis. Do you repeat hep C viral loads? The frequency, I know what the GI people recommend about ultrasound. Do you have an actual schedule that you do that? And hep B as well, the longer-term follow-up for some of the hep B patients, once you know they're undetectable on their tenofovir-based regimen. Thank you.
Great question. Do we go hep B first?
Sure, we'll do the hep B first. So, in terms of hepatitis B, so what we recommend in terms of monitoring is that once you get them to undetectable, we still assess HBV DNA every 6 months. And I still recommend that we do the full serology, so surface antigen, surface antibody, E antigen, E antibody. That's a Devika Bhattacharya recommendation, just so we can see how people are transitioning. Somebody was laughing there. No, it is a... Yes. So that's how we assess for hepatitis B. I think the other thing that's really important for both hep B and hep C is don't forget the HCC surveillance. HCC in hep C for those individuals who have cirrhosis, once with cirrhosis, always with cirrhosis, at least until we have further data. And then I'll turn it over to Susanna.
Yeah, I think that's the same branch point, right? And again, I would emphasize what are the resources and what's nice to have and what do we not have to have. And so, but I think the question about hepatitis C is if someone does not have severe liver disease, so cirrhosis, right? If you're using a FIB4 or elastography, you're really determining whether or not someone has cirrhosis, yes or no. That's how those non-invasive markers work best. If they have cirrhosis after treatment, they need to go into a long-term follow-up program for their liver disease, for HCC screening, and that can be done either by you or you can refer to a hepatologist and or a clinic to do that, which I think many folks do because we have a lot of other folks to take care of. But our hepatologists are also overwhelmed with lots of steatotic liver disease these days. So those patients definitely need to go into a long-term liver disease follow-up program. And people who come into a DAA treatment who do not have significant liver disease, those people do not need to go into a liver disease program. Now, look, if they have ongoing abnormal liver transaminases, if they have heavy alcohol use, if they have steatotic liver disease, that is different. They then do need to transition into care for those underlying liver diseases that are continuing to cause inflammation of their liver or put them at risk of having liver complications. But to make it simple, they don't have any of that. They have healthy, normal liver transaminases now. They did not have a FIB4 elastography or APRI that suggested they had severe liver disease. Those people should have, what do I do in my clinic? I usually do an SVR12, and I usually do one more test for hepatitis C about a year later to make sure they don't have a late 1 in 1,000, right, person. I've had that once of a late relapse that we saw in the registration program for these DAA drugs. But then they're done. I refer them back to their primary care unless they have ongoing risk for hepatitis C, because those people do need continued hepatitis C testing depending on their risk, right? So I don't want to forget about those folks. And again, what is cure, right? So in my clinic where I can bring people back and I know they'll show up, I do an SVR12 and then one more a year later. But if they're high risk and you're worried they're not going to show up, I mean, I think we all know SVR4 is greater than 99% predictive of SVR12. And so, I think that's great if you can get them back. And if you can't, the key is, again, making sure if they have liver disease, that they're aware they have liver disease and making sure that they know that you're going to recommend that when they're done. So at least they have that knowledge. At some point, they can decide to show up again for clinical care if needed.
And did I hear you say earlier that if they have significant fibrosis, that to date we don't really think there's much improvement despite adequate treatment?
There is regression in hepatitis C, hepatitis B even more so. But hepatitis C, there is regression. We definitely have, they're small, but paired liver biopsy studies that show that hepatitis C fibrosis can regress. What I was saying is once you get to the point of cirrhosis, that regression does happen. I think it's slower than in hepatitis B. But it also shows that the risk of HCC continues. Even that regression is happening, whatever drives that HCC seems to be changing, less slowly than maybe we had hoped.
Okay. Do you think the degree of fat in the liver makes a difference in terms of response to the therapies?
Oh, that's a really interesting question. I mean, historically, people thought that steatosis may be a predictor. I think that may have been more driven by the fact that they were largely genotype 3. But in this day and age with DAAs, I wouldn't worry much about that. Frankly, I'd treat them.
Hep B as well? If they have fat and Hep B, a lot of fat in the liver, and chronic hepatitis B, do you think they respond similarly to your efforts to suppress virus?
Yeah, I mean, I think there isn't as much data with, MASLD and hepatitis B, and I know we've got some online questions. But yes, I mean, I do think, and that often actually will push me in the gray zone, if you will, of persons living with hepatitis B to treat. If I think that there is MASLD, but they don't meet true treatment criteria for hepatitis B, I will go ahead and treat because at least knock out one part of the inflammation.
Thank you.
Okay, so we'll try to do some quick questions, quick answers for some of these online questions, a lot from hepatitis B. So if the CpG vaccine, hepatitis B, is not available for a vaccine non-responder, let's say someone's clinic doesn't have it on formulary, how would you approach that? There's several options, right? You can refer them to a pharmacy, maybe get it, or could you use one of the older double dose? Because one of the things that came up yesterday is the Beehive study didn't use double dose Engerix B, used the standard. So question for you, Debica, how would you approach, can't get hepatitis B, how would you approach a vaccine non-responder?
Yeah, I mean, I would advocate for trying to get hepatitis B, no matter, in whichever way you can. So trying to refer maybe to another pharmacy, I think is a great suggestion there. But if you don't have that option, then I think using double dose, either Engerix or Recombavax, is an option. And it's double dose at, again, the same series, so 0, 1, and 6 months. And then there are some that may also, you can also think about 4 doses. Double dose 4 doses instead of the 3 doses. Short answer.
Okay, another quick question. It came up. So some questions about selecting between TDF, TAF, and entecavir for Hep B. So we'll start with monoinfection. And we do know that some payers push back on the branded tenofovir formulation. How do you select which one of those 3 for, let's say, a mono-infected person first, and then we'll go to co-infected?
Yeah. So in mono-infection, again, the reminder about GFR. So if there's a GFR reason, a low GFR, then I would, of course, pick either the TAF or entecavir. If we had access, like we do with the VA, to all drugs, I will pick either, quite honestly, TAF or entecavir because of, at least for now, the reduced risk of other complications related to TDF, i.e. Bone mineral density, as well as GFR. So either TAF or entecavir preferred.
Great. Now, You talked about the study that there was some suggestions in people with HIV that TAF may lead to better virologic suppression than TDF. So this question for both of you, do you think they are the same for people with HIV? Or how would you interpret that study?
I just think it's too early to tell, to be honest. I mean, it's one study, and I think there has been some discussion that maybe those individuals who got TAF may have had lower quantitative hepatitis B surface antigen levels, at the get-go that wasn't available at the time of initial analysis. But I mean, we have seen, so I would say my short answer is right now, I think they're probably still equivalent. I don't choose one over the other unless there is a reason, from a renal function standpoint to pick TAF over TDF. But I think the data is still out. And I think, what Anjali reported at CROI, where you saw with the transition a decrease, the 50% of individuals who were on the TDF arm, who then went to the TAF arm in their ALT, was some pretty intriguing data. So jury's still out.
Suzanne, your comment?
I do have a comment about this one. I think if you look at the study, even though it was randomized, there was a clear imbalance in the TAF arm in people who at baseline had higher liver transaminases. And if you look at the curve of the virologic outcome, those curves split initially and then they come together, right? So it's the later time point, their virologic outcomes are the same. And the fact that there were higher liver transaminases in one arm versus the other, I'm not going to call it failed randomization, but we all know that if you have a true randomization in a large enough trial, you should see the same differences at baseline. And the fact that that was clearly a difference, and you see that in the first, I think it was 6 to 12 months, when that split is happening, more people in TAF clear their infection and clear their surface antigen. Maybe they were lower. I would argue that maybe they had more recent infection and were more likely to clear anyway. And so you have to take those clearances out. Here's my question is, do you really think TAF increases the chances of natural or clearance of surface antigen or not? This is the question to me, and I don't think we've seen any data in Hep B monoinfected that is true, and I doubt it is true in HIV, but that to me is the actual question to ask.
Yeah, I'll just add to that comment. In monoinfected people, the head-to-head trial of TAF monotherapy versus TDF monotherapy for Hep B, they were essentially equivalent. There was no daylight between the lines of viral suppression in those studies. So the jury's still out. People with HIV are interested in that they actually seroconvert and clear a little bit more often than people without HIV. We can get into that maybe a bit later. A couple other things just real quick that came in online. Pregnancy. What are the recommendations for managing Hep B during pregnancy?
I thought we were going to ask for Hep C, yes.
Well,
hepatitis B in pregnancy. So that also is something that had been updated recently. So now if we're talking about HIV and Hep B with pregnancy, obviously that answer is easy. They're on TDF-containing therapy, but you want to make sure that is a perfect opportunity in those who may have become pregnant on long-acting injectable therapy, that you have assessed for hepatitis B and make sure that their status. Those individuals who are HIV, Hep B, and pregnant, they should be on a tenofovir or TAF containing regimen. That's HIV, Hep B. Hep B monoinfections, we wait. Current guidelines are that you can test in the second trimester and evaluate for HBV DNA. And if they don't already meet criteria for hepatitis B treatment by WSLD guidance, there is a treatment indication to prevent perinatal transmission if your HBV DNA is greater than 200,000 IUs per ml. Now, I would argue that, and do in my practice, will treat individuals earlier on in pregnancy, because I think that, at least in the HIV Hep B space, we have data that demonstrates that individuals with HIV and Hep B co-infection, their infants have worse perinatal outcomes that are related to the HBV DNA at the time of treatment initiation. But again, I think we need more data to suggest earlier treatment than just in the second or third trimester. But second and third trimester, HBV DNA of greater than 200,000 IUs is the current WSLD guidance.
I'm going to squeeze in one more question from online. For Susanna, treatment experienced people. So we know the treatment response rates are high, but people do come in who have failed. Sometimes they didn't get the full treatment course. What's your approach? Do they need longer therapy, different drugs? How do you approach that person that was not cured with first-line therapy?
Yeah, no, that's a great question. So, getting in 30 minutes, it's hard to get to retreatment. But so retreatment is, as I think I mentioned just in talking about the drugs, one is you have to ask, is it someone who has previously failed treatment and is a true retreatment, or are they newly infected and just need treatment again, right? So obviously anyone who was previously cured and now just reinfected, that's you're treating the virus, right? Not the person. So that virus has never seen DAAs, so you're going to treat them as an initial treatment. If it's someone who's actually been treated with DAAs and has failed that therapy and now they're coming in, generally, to make it easy, we would say that you would treat them with a retreatment regimen, which is, as I mentioned, initial treatment is 2 drugs, right? So we either have protease inhibitor and NS5A combinations, or we have nuke NS5A combinations, and you would just go with a triple therapy. That, we have approved drugs for that. We have combinations that you can make up on your own to do that. If you can't do that, there is plenty of evidence that you can actually treat someone who has failed, right, soft bell with just soft bell for longer. So that is a strategy that is presented in the guidelines, but the recommendation is to go with a triple.
All right, I'm going to try to squeeze one more in, because this came up yesterday. I don't think we answered it. Someone, person with HIV, they're S antibody positive. When do you repeat that, or do you never repeat it? So I'm going to put both of you on the spot. You're in your standard practice, person with HIV, you do the triple panel, they're core negative, S antigen negative, but S antibody positive, they were vaccinated. Yeah. When would you repeat that? These are going to be 1-sentence answers, no waffling. Just give us a number.
I can't do 1-sentence answers. So just a couple of points. So one, the guidance now says that before you're going to be starting folks on long-acting injectable therapy, you should have that surface antibody data within 6 months of that switch. So that's answer 1. And then answer 2, I think, is waffling. We don't have guidance yet. I would say annually, because I think that's helpful, and that also allows you to have some wiggle room if you're going to change over to long-acting injectable. So 6 months before long-acting injectables, and then annually.
So S antibody repeated annually in vaccine responders with HIV?
Yes.
Annually, okay.
I check titers, and then based on the titer, I decide when to repeat.
Let's say the titer is 12.
I'm probably gonna. I have that, and so I'm probably gonna. I may well go ahead and register that person, and then I'm gonna, maybe repeat it a year later.
All right,
I use titers. So.
With that difficult question, I think we've got somewhere. We landed somewhere around annually, which is so. We'll stick with that, and I want to thank Susanna and Devika for really outstanding presentations and discussion of a very complicated topic.
Thanks. I appreciate the opportunity to come back to this great meeting and share this information with you. The topic is daunting because each one of these, I think, is worth a session, not 10 minutes. But I will do my best to give you a brief overview of this. I have no disclosures relevant to this. Okay, so rather than show you a lot of life cycles, I want to give you a one-slide comparison of these 3 different viruses, things they have in common, ways that they differ. So they're all RNA viruses. Humans are a potential host, though particularly for Hep E, many mammalian species, as we'll look at in more detail, are the primary hosts, and humans are a secondary host. For Hep A, fecal oral transmission, and some types of Hep E, but not all, are spread by fecal oral transmission, whereas Hep D is generally parenteral, sexual, and possibly vertical. Acute versus chronic, so they all can present as an acute illness. There's a rare relapsing form of Hep A, a few more words about that shortly. For D, it depends on how you get it with Hep B. In the setting of superinfection, you're likely to become chronic if you're exposed to Hep D. In the setting of co-infection, you're much, much less likely to develop chronic D because you're less likely to develop chronic Hep B. And in Hep E, immunocompromised persons, including those with HIV, are at higher risk of chronic disease. The mortality varies for all three. We'll take a look at that. And in terms of prevention, Hep A is clearly vaccine preventable. D is vaccine preventable by using a vaccine for B. And E is also vaccine preventable, at least some forms, but those vaccines are not available to us. So let's look at the broad picture of viral hepatitis in the U.S. by serologic footprint. You just heard about Hep B and Hep C and how important they are, but when you actually look at the numbers, the frequency of disease in the U.S., they're dwarfed by hepatitis A, and believe it or not, hepatitis E, which many people still persist in thinking doesn't exist in the U.S. So let's start with hepatitis A. Epidemiologically, there are three distinct patterns of hepatitis A infection in populations. The most common worldwide is in lower socioeconomic status countries with generally poor sanitation systems. And the rule is acquisition of Hep A by age 5, high seroprevalence of antibody in the population, and for the reasons I'll show you momentarily, a mild clinical course. There's a unique pattern that exists in a number of Pacific islands where every other generation has major hepatitis A outbreaks, and then there's a high prevalence of antibody and protection. There's little use of vaccine, and then the generation after that is exposed again, and it typically spreads rapidly through various island settings. The third is what we see in the United States, higher socioeconomic status countries, low rates of childhood exposure because generally good sanitation systems, but significant risk from foodborne outbreaks. The classic go to McDonald's or Arby's or wherever, and someone there is handling food that presents a source of infection to dozens, hundreds, thousands of people. And we see this reflected in the news headlines. The U.S. has been in a period of severe Hep A sporadic epidemic since 2016, starting in California, spreading to Arizona, jumping to the Midwest, and now isolated pockets still appearing in various places in the country. Most recent was in Boulder, Colorado in January 25. And you could see that by just looking at pooled data over a period of time from the CDC, where you see the higher risk areas. And in the highest prevalence, I was in, as Mark mentioned previously, in Cincinnati. Cincinnati and northern Kentucky were hit by this around 2017, 2018, and we were seeing 1 to 2 fulminant hepatic failures a week, a number of them leading to liver transplantation. The sources of Hep A, interestingly, for the majority, we don't know. You can't find it even with epidemiologic investigation. Household contacts, sexual contacts are thought to play a major role. Daycare centers in some outbreaks are important. International travel does account for a measurable percentage. So the at-risk populations are shown here, though recently the CDC downgraded the persons with clotting disorders as lower risk because of very high uptake of vaccine in that population. Of note in my practice is the persons with chronic liver disease who get acute on chronic disease with very severe outcomes. So what's the clinical presentation? Well, many are asymptomatic without jaundice and become a continuing source of infection to others. There's symptomatic self-limiting disease with jaundice that generally lasts less than 8 weeks. There is a form of cholestatic jaundice that lasts more than 10 weeks, and by more than 10, many of these actually persist up to 6 months or longer. There's also a relapsing acute hepatitis with 2 or more instances over a 10-week period. Essentially, the virus appears to go away and then comes back again. And as I mentioned, there are significant, though luckily relatively small number of acute hepatic failures. The frequency of jaundice is highly tied to age. In those less than 6 years old, jaundice is very uncommon. Hence, we have children, for example, in daycare centers spreading through diaper changing from one to another and to parents. But they are not sick, they are not jaundiced, they may have what looks to be a typical gastroenteritis that little kids get all the time. In the 6 to 14-year-old group, we begin to see much higher frequency of jaundice. And once we get over 14, jaundice actually becomes the rule rather than the exception with those infections. And the jaundice is clearly associated with the risk of increased levels of liver injury and ultimately can parallel what we see in age-dependent case fatality rates, which can be relatively significant in those over 40 years old, though probably in part driven by the presence of some underlying liver disease where acute on chronic disease makes it that much worse. Prevention of Hep A, there are 3 vaccines available, Havrix, Vactra, Twinrix, and we can use immunoglobulin. The vaccines work very well and should prevent this from being a problem. But the problem is, I think, still in the area of who should get vaccinated. So this is the current CDC guidelines, and they say children 12 to 23 months old as part of routine childhood vaccination, and all other children and adolescents 2 to 18 years old who have not previously received hepatitis A vaccine. And then the CDC cites some of the groups at increased risk: international travelers, men who have sex with men, people who use or inject drugs, people whose jobs increase the risk of exposure, but that's considered mainly people working in sewage facilities and people working in waste disposal who might be exposed to needles and other things. They just get sort of thrown into that group. People who anticipate personal contact with an international adoptee, people experiencing homelessness, or people at risk for serious disease, people with chronic liver disease, including Hep B and C, those with HIV infection, and pregnant people because of increased risk. Yet, there's not always very good uptake in the use in pregnant people. So I find when talking to our fellows that they think pretty much everyone's been vaccinated, but that's not the truth. We're up to under 80% for newborns receiving 2 doses. Little better, newborns getting at least 1 dose. Adolescents, not bad, approaching 70% nationally. Adults, dismal, 10% overall. Travelers, people who tell their healthcare provider that they're going overseas to higher risk places, the uptake is less than 20%. And even in chronic liver disease, where we know that this is a big deal, we always screen these new patients coming into the transplant clinic, and very few have evidence of antibody or a history of prior vaccination, and we provide vaccinations at that time. Common issues: vaccine for healthcare workers is not recommended by the CDC. At least some healthcare workers, like hepatologists that manage patients with a fulminant failure associated with Hep A, probably should be vaccinated, and I have pushed for that within the Cincinnati healthcare system previously because it's not covered by insurance based upon the CDC recommendations. Post-exposure prophylaxis, it has to be given within 2 weeks. 1 dose of vaccine is generally sufficient. Immunoglobulin can be used, though immunoglobulin is derived from the general population, and the prevalence of natural infections overall in the U.S. is slowly declining, so the availability of good antibody is less than it was even a decade ago. Boosters are not recommended, but good data are lacking, and there is some suggestion that when antibody fades, and not surprisingly, like other viruses, that people are at risk, and not everyone mounts a great anamnestic response. So perhaps we should be thinking about it. But my guess, my personal feeling is that universal vaccination would be a better starting place than worrying about the boosting side of things. Okay, hepatitis E. It's an enterically transmitted zoonotic RNA virus. There are more than 8 genotypes capable of human infection, and the genotype matters quite a bit. So for genotype 1 and 2, man is the only host, and this is the fecally orally transmitted form of disease. It's very common in Asia and Africa and much of Central and South America, and is not endemic in the US. Genotype 3 is present worldwide in a variety of animal species, but is the most common genotype affecting people in Western countries, where it's being spread primarily, though not exclusively, through exposure to undercooked pork products, and particularly pork liver-based products. However, there's many cases of case reports of things like in France eating rabbits and a variety of other species that have been implicated. And I at least want to throw out mention of a slightly different form of Hep E called, it's in a different class, that's rat hepatitis E, which has recently proven to be a significant player in transplant patients in Hong Kong and some other parts of China. Appears to probably exist worldwide, but its overall risk within US and Europe appears to be highly, highly variable, and probably depends upon the proximity and concentration of rat exposure and rat excrement exposure. So what are the clinical outcomes of hepatitis E? For immunocompetent patients, they get acute disease, they do not get chronic disease, and the overall mortality is low, with a clinical picture very similar to hepatitis A. In pregnancy, acute disease occurs, chronic disease does not. Mortality is variable. It depends on where you're at in the world, and there's a number of issues that may actually affect that that's still considered quite controversial in the field as to what's the most important factor affecting mortality in pregnancy. In immunosuppressed populations, which include those living with HIV, post-transplant, and patients receiving cancer chemotherapies, particularly deeply immunosuppressive therapies, we do see development of chronic disease with variable rates of mortality due to rapidly progressive liver disease. In addition, it appears that there are some other non-hepatic processes that can be involved with Hep E. It seems pretty likely that Guillain-Barré is triggered by hepatitis E infection. And in the last couple of years, there's been a growing number of both case reports and animal studies suggesting that there is a Hep E associated pancreatitis. Potential sources of HEV infection could be from a donor organ in solid organ transplant patients, blood and blood products, direct exposure to HEV contaminated food or water, and epidemiology in some populations does suggest that sexual exposure is a risk as well, but it's not very well documented. So what about blood donors? These are prevalence of virus in blood donors across a number of countries. And you can see that there's some variation, but for example, in England, where it's between around 1 in 2,800 to 7,000 blood donors, NAT testing for HEV is part of regular testing of donor blood. In the US, where it is 1 in about 9,500, there is not testing for hepatitis E because of concerns about relative cost versus risk. The clinical course, usually between 2 and 4 weeks after infection, the virus begins to appear in both serum, can be detected by RNA assays in both serum and stool. There's no clinical laboratory in the United States that will test stool, though it lasts longer in stool and you're more likely to actually get an accurate diagnosis from stool. Shortly after that, we see ALT start to rise, peaks kind of in the middle with the appearance of symptoms, and then we begin to see first an IgM antibody followed by an IgG antibody that tends to persist for a long time. In the chronic disease, we see continued or at least intermittent viremia, and the IgM disappears, but IgG may indeed be present in the face of ongoing infection, and liver enzymes tend to be elevated. Testing, so up front you need to know there is no FDA approved test for Hep E in the United States. There is assays that are available for IgG and IgM. Some of the large national companies like Quest and LabCorp do run those. You don't know what you're getting. They don't usually tell you which specific test it is, and there's about 5 or 6 on the market worldwide made by various testing companies. Serotyping has never been fully developed. but is a research tool, and as is HEV ELISpot, which is probably the most sensitive method to diagnose an infection, but is not in routine practice. Virologic testing, nested PCR, real-time PCR, and there is in Europe HEV antigen testing available. Several years ago, I worked on diagnostic criteria, and we're actually beginning to see some uptake of organizations' guidance suggesting using some variation of this that generally requires at least 2 tests be done because of problems with the individual assays and their sensitivity and specificity. Chronic HEV is diagnosed, we generally say 6 months in either stool or blood. European definition is 3 months in stool or blood. We do treat chronic Hep E, not acute Hep E. There is some evidence that there can be suppressive effects or clearance with pegylated interferon, but that is not generally used. The drug of choice is ribavirin, generally for initially 12 weeks, and if it doesn't work in a first course, up to 24 weeks. In addition, in immunosuppressed patients or cancer patients, the withdrawal of the source of immunosuppression is generally recommended, and in one study led to clearance of about a quarter of the patients by reducing the levels of immunosuppression that they were being given. Pregnancy. So I referred to this already. Maternal mortality has been reported to be as high as 25% in some locations. Recent outbreak in Niger and Nigeria, in refugee camps, reported those types of rates, though it was suggested that that mortality was in part due to the absence of really good medical care. However, low mortality is seen in other places, and most notably in Egypt, where exposure to Hep E tends to occur waterborne very early in life because most of the wells along the Nile River Valley are contaminated with hepatitis E. And so you end up with high levels of antibody, and that may be a factor in low mortality in places like Egypt. There is a Hep E vaccine for genotype 1, which is available in China. It's called the Heckelin vaccine. It is protective. It does confer relatively long-term immunity. It is not available in the United States. And it has never been formally tested in the transplant setting against the type of Hep E that we see in Western countries. Okay, we'll finish up in the last 5 minutes with Hep D. So Hep D, this is from a NIH US cohort looking at, they said risk factors, but I would really tend to define it as associations because not all are risk factors. But clearly, injection drug use is a leading factor in the populations that they've seen, which are referred in from a relatively large area for evaluation. Low associations with low titer HBV, so patients with chronic infection who are still producing that surface antigen that Dr. Bhattacharya talked about, that the virus needs for its own replication scheme. Not surprisingly associated with elevated ALT levels, and you could see that they identified HIV as at least a measurable associated factor. In Europe, Hep D, Hep B co-infection in the setting of HIV is quite prevalent and is a significant enhancer to progressive liver disease. There are 8 genotypes, both US and Europe, primarily genotype 1. I do like to at least mention genotype 3, known as La Brea fever in the Amazon River Valley, because this is a very acute, rapidly progressive disease with mortality rates that exceed 50%. The prevalence is actually hard to determine because of a series of factors that go into that. Insufficient testing, inaccurate or incomplete testing, with failure to obtain HDV RNA. When you screen by antibody, and you don't follow up, you may be dealing with a resolved infection. Wide regional differences with center and population bias in the testing. A tertiary referral center seeing patients with advanced liver disease or liver cancer would present a very different picture than a center, or a community-based center in that they're seeing chronic Hep B commonly in. And inclusion of older studies that don't reflect major population shifts. So even in places like China, studies have suggested huge variation from city to city in hepatitis D risk. The clinical outcomes in North America were recently described. This is from the last AASLD back in November, in taking a look at patients again followed at the NIH and showing that the curves suggest relatively rapid mortality with rapid progression of disease in North America, similar to what's been well described in other places in the world. Hep D is a very bad player when combined with Hep B. Treatment. So there is a medication called bulevirtide. It appears effective at viral suppression. It is approved in Europe by the EMEA, at least for provisional use in Europe. It has been studied in Europe in kind of pooled data analysis studies across a number of centers in persons with HIV, where it appears very effective, particularly when used with PEG interferon in combination. This is recent, again, from the liver meetings, 96-week follow-up analyses showing very good effects on ALT suppression, very good viral suppression over that period of time. This is not approved in the US, not because of efficacy, but the FDA cited in a letter that there are manufacturing issues that they felt had to be resolved before this drug could be approved in the US. So we're still anxiously waiting for it here. Looking forward, there are potential new therapies that are also being looked at for Hep B treatment. This is an siRNA combined with a hepatitis B monoclonal antibody for Hep D-V, the Solstice trial. The numbers are small looking at this combination therapy, but really, really excellent outcomes in terms of both HDV clearance and ALT normalization. I know the numbers are small, but the percentages in 11 patients was 100% of undetectable HDV RNA. This is a combination that has been under study for patients with Hep B as well. So again, treating the Hep B becomes a treatment for Hep D, but we need to see these studies move along into phase 3, and things have maybe slowed down a little bit of late in this arena. So in conclusion, Hep A and Hep E remain public health threats and are often we don't pay as much attention to them, unfortunately. Hep A, the vaccines are not fully deployed, even in those that fall under the CDC guidance for use. Hep E, there's no vaccine outside of China, and we don't know if the vaccine will be effective on the type of Hep E we have here. Diagnostic capabilities for Hep D and HEV limit accurate diagnosis. There are efforts to change that in some of the major labs with reflex testing, but we're still in the early stages of that. New treatments for HDV do appear very promising. I hope we get bulevirtide soon available to us. And there's little on the horizon for treatment of either acute Hep A or Hep E. Thank you.
Good morning, everyone. So I'm absolutely delighted to be here today as part of such a wonderful program. Thank you to the organizers. So listed here are our learning objectives. So we'll first start by understanding weight gain in HIV, and then we will turn to understanding weight management strategies. We'll be focusing primarily on the GLP-1RAs, and for purposes of this talk, we'll be really speaking about these medications in terms of their use for obesity, not diabetes, as that is a whole nother talk in itself. And really the goal here is for you, similar to the other speakers, to gain practical advice that you can take back to your clinic in the care of your patients. All right, so we are in the midst of a global obesity epidemic, as you're all aware. BMI greater than 30 defines obesity, and to put it in simplistic terms, weight gain occurs when there is an imbalance between energy intake and energy expenditure. For example, when calories consumed exceed calories burned by physical activity or metabolism, this is what creates an imbalance and leads to weight gain. So there are multiple factors affecting weight gain. Those include genetic, physiologic, behavioral, and environmental, and that is what makes obesity so complex to manage and treat. So there are traditional risk factors for weight gain, those being lifestyle factors, so reduced physical activity and consumption of calorie-dense foods, which are so accessible in our society. We do need to be aware of other risk factors that are specific to HIV as well. Those include demographics, such as female sex and Black race, virus-related factors, such as lower CD4 counts. We also think about ART-associated weight gain, namely INSTI or TAF-associated weight gain, and also the withdrawal of ART suppressive regimens such as TDF and efavirenz. And also, there is unique physiology in HIV that we need to be aware of related to low testosterone, alterations in growth hormone, as well as early menopause. So the important point here is that weight gain is not just associated to ART, but there are also viral and host risk factors that you need to be aware of. All right, so weight gain has been associated with ART initiation and generally does not improve with switching ART regimens. So on average, persons with HIV will gain about 2 kilograms during their first 2 years of treatment, and typically much of that happens in the first year. And on the upper right here, you'll see data from the Cascade study in which they studied weight gain soon after ART initiation, after HIV seroconversion. And what you see is that weight gain occurs on all ART regimens. However, it generally seems to be greater among those started on INSTI or TAF-containing regimens. And we do know that weight gain occurs across all BMI categories. So, for example, among those with a BMI less than 30 who are not obese, those newly initiated on INSTI and TAF-containing regimens gained about 5 kilograms at 3 years. And about 40% of these individuals who were normal weight gained 10% of their body weight. So while it may seem that there is small amounts of body weight with initial treatment, you can see that there are a huge portion of individuals that are being affected, and this is quite concerning as this can lead to metabolic risk. And we do know from other studies that about a fifth of individuals will transition BMI categories from normal to overweight and overweight to obese. And with regards to ART switch, we do know that those switched off of efavirenz or TDF do have great weight gain as well. And in this regard, these regimens are thought to be weight suppressive. Now, we're really still trying to disentangle the mechanisms behind ART-associated weight gain. Initially, we thought there were just weight-promoting agents. And now we know that there are weight suppressive agents, and these may predominate. But it may be, in fact, that it's really a combination of both of these weight suppressive and weight promoting agents. All right, so just to get into a little more detail about proposed mechanisms for TAF and INSTI-mediated weight gain. So as I just mentioned, it may just be an indirect effect that we're seeing, that when we are removing ART suppressive regimens, that is why we're seeing weight gain with these individuals. On the other hand, there may be more direct effects, that being alterations in gut microbiota. In addition, there has been data suggesting that the INSTIs may affect adipocyte differentiation, estrogen-mediated pathways, as well as have effects on lipid and glucose metabolism. And these INSTIs may also suppress the melanocortin-4 receptor, which may increase appetite, which we'll touch upon later as well, and have effects on insulin sensitivity. All right. Of course, we do know there are consequences to weight gain. So in this study, they evaluated individuals on various ART regimens, and what they saw was that these individuals gained about 3.6 kilograms over 48 weeks. And of those individuals who gained about 10% of their body weight, there was a twofold increased risk of diabetes or metabolic syndrome in these individuals, and about a 1.5-fold increased risk of a cardiometabolic event. And complementary to this, individuals that lost 5% of their weight gain actually had a lower risk of incident metabolic syndrome. So this really points to the benefit of weight loss. And we do know from the general population that greater weight loss leads to increased metabolic benefits. So we see here that with just 5% weight loss, that can lead to improvements in blood pressure and sugars. With 5 to 10% weight loss, that can lead to preventing diabetes, improvements of fatty liver, now termed MASLD, as well as dyslipidemia. When you have 10 to 15% weight loss, that can lead to reduced CVD risk, as well as reduced risk of steatohepatitis, now termed MASH. And when you achieve greater than 15% of weight loss, you're starting to get into looking at the remission of diabetes, as well as reducing cardiovascular mortality. Now, not to complicate things, but a global commission just met and proposed a new definition for obesity, which we should start thinking about. So it may be that BMI as a measure may actually under or over predict metabolic risk. And for example, you may have an athlete that has a very high BMI because of increased lean muscle mass, but may not be at risk for increased metabolic disease. On the other hand, you may have an individual who has a lower BMI, but tends to deposit all of their weight in their abdominal area. And that individual is someone that you want to be aware of who may be at risk for metabolic disease. So we really need to start thinking about excess adiposity versus BMI. And we're really limited in how we can do that in our clinical setting, but some things that you can do are looking at the waist circumference or the waist to hip ratio. Now, if those are elevated, regardless of BMI, these individuals would then be characterized as obesity, and then these individuals would further be stratified into preclinical or clinical obesity based on the presence of organ dysfunction and or the inability to perform daily activities. So this is not in clinical practice yet, but is really starting to shift how we're going to think about adiposity and obesity. I will say this concept is not new to the field of HIV. We've been thinking about weight gain this way for a long time now because of the excess adiposity and fat redistribution we are familiar with in HIV-associated lipodystrophy. All right, so the first step in managing obesity is to always counsel on diet and exercise. The goal here is to aim for a calorie deficit of about 500 to 1,000 kilocalories, with the goal of losing about 1 to 2 pounds per week for healthy weight loss. You also want to encourage activity, so moderate intensity aerobic activity, about 150 minutes per week. And in addition, muscle strengthening activities that involves all muscle groups more than 2 times a week. Now, we know know that diet and exercise may not be entirely effective for weight loss in HIV, but it's still important to promote these habits amongst your patients because there can be benefits to things like weight stability even, and also to cardiorespiratory fitness, bone health, muscle strength, as well as even mental health. All right, so in a recent breakthrough, the GLP-1s have come onto the scene as the new anti-obesity medications. Now, to understand these medications, we do need to get a lesson in physiology here. So the incretin hormones are GLP-1 as well as GIP. These are secreted from the small intestine in response to food. They then act on the pancreas to increase insulin secretion as well as decrease glucagon secretion, thereby causing glucose-lowering effects, and it does this by essentially increasing glucose uptake in the peripheral tissues, such as the muscle, as well as decreasing hepatic gluconeogenesis. So you may have heard of these incretin-based therapies, semaglutide and liraglutide, which are single GLP-1 receptor agonists, as well as tirzepatide, which is a dual GIP-GLP-1 receptor agonist. Now, these medications are essentially mimicking the endogenous function of these hormones. However, they do have a structural modification that allows them to have a longer half-life in the body for more efficacy. Now, these drugs were initially studied for their use in diabetes, and they unexpectedly showed weight loss. Apologies. So then these medications were more directly assessed for weight management in further studies. Now, these medications may act on the brain to decrease appetite, as well as on the gut to slow gastric emptying. This together leads to increased satiety, a mechanism of which accounts for their utility in obesity. Now, we can understand the physiology further by thinking about these hormones. So multiple key hormones in appetite regulation are listed here. You can see that the majority of these are satiety hormones, meaning that when your body is in a state of energy sufficiency, these satiety hormones are secreted and they tell your body to decrease caloric intake. On the other hand, ghrelin is a hunger hormone. So when your body is in a state of energy insufficiency, this sends a signal telling us to increase caloric intake. Now, these hormones are secreted in the periphery. They travel to the hypothalamus. You can see the circuitry is quite complex here, but essentially they're working on the melanocortin-4 receptor. And GLP-1 eventually acts to stimulate this receptor, thereby giving a satiety signal, versus ghrelin acts on this receptor to inhibit it, giving a hunger signal. And any dysregulation of this pathway leads to weight gain. All right, so what do we know about the efficacy of these medications? So the STEP 8 trial helped us answer this. So you can see here they compared semaglutide and liraglutide versus placebo, and there was about a 2 to 2.5 fold decrease in weight loss with semaglutide compared to liraglutide. So about 16% with semaglutide versus 6% with liraglutide. And greater proportions of individuals lost greater weight with semaglutide. So in this regard, we think of semaglutide as the more robust GLP-1RA. The SELECT trial went on to help us understand cardiovascular outcomes in obesity. So in this study, they recruited individuals with a BMI above 27. These were individuals that had a known history of cardiovascular disease. Those with diabetes were excluded, so we're really understanding these medications and obesity alone. The primary endpoint that they looked at was a composite from death from cardiovascular causes, non-fatal MI, as well as non-fatal stroke. And what you can see here, the key finding was that there was a 20% risk reduction with semaglutide. So this is quite impressive here that you have a medication that not only offers weight loss, but gives you cardio protection as well. I do want to highlight again that this data, we do not know how it extends to individuals without known heart disease. And that could really have far-reaching implications to individuals with HIV, whom we know to have subclinical heart disease and a twofold higher risk of heart disease. So more to come on that. All right, so the combination GLP-1s, I mentioned one, tirzepatide, are rapidly evolving. There are so many more in the pipeline that are going to be coming out, and it's really thought by combining the actions of multiple GI hormones that you will get synergistic actions of these from these medications. So data from the SURMOUNT trial recently came out in which they compared tirzepatide and semaglutide head-to-head for the first time. And the key finding here was that there was about a 47% relative weight loss with tirzepatide versus semaglutide. And on the bottom right here, you'll see the absolute as well as average amount of weight loss, and it's really not insignificant for either medication here. All right, and so we do know that semaglutide and tirzepatide offer greater amounts of weight loss than other medications that we may have used in the past for weight loss. And in addition, the weight loss achieved with tirzepatide really is starting to approach that of which could be achieved with bariatric surgery. So you can see here with sleeve gastrectomy, you get about 25% weight loss. In terms of clinical indications and using these medications, so they are all sub-Q preparations. Semaglutide and tirzepatide are given weekly, liraglutide daily. You can see here that they're marketed under different names based on the indication for obesity or diabetes, so you want to prescribe accordingly. They're also given at higher doses for obesity with the single agonist. Now, these medications are indicated when an individual has a BMI above 30 or when an individual has a BMI above 27 with the addition of a weight-related comorbidity. In addition, the individual must have failed lifestyle intervention. And based on the data that I just showed you from the SELECT trial, the FDA now approves semaglutide for use in overweight and obesity among those with known cardiovascular disease. And it's really important that we start, expanding indications for use so we can get these medications out to more individuals. So, insurance approval is quite difficult, so some tips include making sure in your note that you're documenting that lifestyle modification for 3 to 6 months has not been successful. What do we use as a measure of success? So it is 5% weight loss, and that really comes from the data that I showed you that we start to see metabolic benefits at 5%. You want to document any metabolic comorbidities, that including heart disease, cholesterol issues, blood pressure, sleep apnea, diabetes. And you may also choose to evaluate for other metabolic issues that may be of concern or relevance to HIV, being insulin resistance, MASLD, and maybe even coronary artery calcification. You may try to choose an alternative GLP-1 RA, such as liraglutide, as that may be on formulary. Now, that is approved for weight loss, but it may not be as robust. But even so, any medication in this class may be useful. There are newer self-pay options. Of course, we know this is not ideal for our patients. So potential side effects to be aware of. There are injection site reactions just because this is a subcutaneous preparation. Because these are anti-hyperglycemic medications, we do think about hypoglycemia, but that risk is quite rare and really only occurs when used with certain other diabetes medications, namely insulin. Unfortunately, the gastrointestinal symptoms are the most common with these medications and oftentimes preclude patients from being able to tolerate them. We did exercise caution in the past in using these medications in patients with pancreatitis, but I think newer data is starting to suggest that this may not be the case. These medications can be associated with biliary disease. In addition, there are rare reports of renal insufficiency, but this may really just happen in the setting of hypovolemia that occurs with the gastrointestinal symptoms. And there is a black box warning to be aware of specifically to medullary thyroid carcinoma, either a personal or family history, and that is really stemmed from animal data of these medications, but we still observe caution with human use. So there are suggested periods over which to titrate these medications. However, you may choose to delay dose escalation if your patient cannot tolerate due to side effects. And the ideal clinical strategy really is to start low, go slow. It may be that if you use a low dose over time, that the individual will tolerate the medication and side effects may subside, and you're giving the patient the benefit of being able to use the medication. If there are several missed doses or preparations are being switched, you may need to restart at the lowest dose or to avoid side effects. Keep in mind that the maintenance dose for individuals may be submaximal. Again, your goal is really to achieve greater than 5% weight loss without any side effects. And these medications may need to be held in the peri-op period if the individual is undergoing anesthesia, and that's to avoid aspiration events. Again, as I mentioned, these medications do slow gastric emptying, so they have been associated with increased gastric contents, and you may be advised to hold the weekly preparation for a week prior to the procedure and the daily preparation on the day of. So these medications are not expected to pose any significant drug interactions via their metabolism. They're degraded by endopeptidases. They are known, as I mentioned, to inhibit gastric acid secretion as well as delay gastric emptying. So this may be of relevance to medications such as atazanavir or oral ripivirine, which, as you know, may be affected by elevated gastric pH. However, it's thought that this effect of these medications is really thought to be minimal. However, it may be suggested that perhaps you separate the orally administered GLP-1, which we did not even touch upon today because the oral version of this medication is only indicated for diabetes, but nonetheless, you may choose to give this medication 4 hours prior to the ART. All right, so one question that comes up over and over again is what happens when you stop these medications? So in this study with individuals who were on tirzepatide, they were then randomized to either continue tirzepatide or be withdrawn for the tirzepatide and continue on placebo. And what we saw was that almost immediately individuals start to gain weight who were switched to placebo. They gained about 14% weight gain. So this is quite concerning. And we think about these medications like as chronic medications, similar to as we would treat hypertension and the need for chronic medications. Okay, so just to switch gears a little bit, we do need to consider lean body mass when we're thinking about weight loss with these medications. And just to highlight that muscle is an important component of the lean body mass compartment. So any weight loss intervention is really going to lead to both fat and lean mass. For example, caloric restriction on its own, which is non-pharmacological, will actually result in about 10 to 30% lean body mass. And the ideal clinical strategy may be to actually preserve lean body mass, especially amongst those individuals that are aging, who you worry about the risk of frailty. And you can see data here from semaglutide, tirzepatide. There was about 25 to 45% loss of lean muscle or lean mass. And these numbers sound really large, but I will say we're not quite sure whether these changes are detrimental yet. That being said, because the lean body to total body mass ratio actually increases with these medications, meaning that there's more fat versus lean mass lost. And in addition, you could ask the question, could this reduction in muscle quantity, could there be actually improvements in muscle composition, thereby enhancing muscle quality? So it's this idea that these, changes there may be actually changes that are metabolically protective. So we don't understand this completely, and further studies are really needed. What can you do for your patients now in terms of muscle mass? So typically it's recommended that individuals get about 0.8 grams of protein per body weight. With these medications, you may increase that mildly to advise 1 to 1.2 grams. You want to encourage resistance exercises 2 to 3 times per week, and that can maybe be done at home with a resistance band. You can also advise strengthening exercises like yoga. As of this time, other interventions are actively being investigated. So bimagrumab is one of those. It is a human monoclonal antibody that stimulates muscle skeleton growth. And this is actively being studied right now with semaglutide to see if when used in combination, there might be benefit. And there are other medications that are being leveraged really from the field of muscular dystrophies to understand their use in obesity. All right, so back to fat. So we do need to discern different phenotypes with excess adiposity in HIV. So subcutaneous fat, or adipose tissue, or SAT, is the pinchable type of fat on your body. We do need some subcutaneous fat. It stores your triglycerides. However, in the absence of SAT, as in lipoatrophy, or when there is excess SAT and it's dysfunctional, as in obesity, you can no longer store your triglycerides properly. These then flow into the visceral adipose tissue, or VAT, which accumulates in the abdomen and in and around the organs. And the VAT depot is highly inflamed. It's associated with metabolic dysfunction, and we worry about that. So in a extreme phenotype or presentation of lipodystrophy, you may see a low SAT, high VAT phenotype. And in this scenario, the ideal clinical strategy would be to reduce VAT while preserving SAT. And that can be achieved by using tesamorelin, which is FDA approved for the use of HIV-associated lipodystrophy. And it does just that. It preserves the SAT. However, in obesity, the ideal clinical strategy may be to reduce fat and SAT, and this may be achieved with the GLP-1RAs such as semaglutide. All right, so now what do we know about these medications in HIV? So this was the first randomized double-blinded placebo-controlled trial of semaglutide. It was really exciting to see these results. So they included individuals with HIV with a BMI above 25 and an increased waist circumference to select for those with lipohypertrophy. They were randomized to receive semaglutide low dose at 1 milligram versus placebo for about 24 weeks. And there was, on average, weight gain reduction of 10%. And to the right here, you'll see in terms of body composition that there was a loss of both VAT and SAT of 13% with these medications. And in addition, on the bottom here, you'll see that they also looked at the lean and fat mass compartments, and there was reductions in both. And not surprisingly, there was more relative fat versus lean mass lost. Overall, the medication was tolerated well. And more recently at CROI, this group presented extension data where they looked at the discontinuation of semaglutide from weeks 32 to 56. And of those individuals who lost 5% of their weight, keeping in mind that that's our measure of success, 50% of those individuals regained half to all of their weight. And in addition, improvements in glucose were no longer evident. And this really closely resembles the data that I showed you earlier, that upon stopping these medications, there is risk of weight regain. They also looked at these medications on inflammation and immune activation and saw, again, across the board, there were decreases in these markers. These decreases happen to be independent of changes in weight and VAT. So that really brings up an interesting point here that there might be some anti-inflammatory potential to these medications. And now this is the SLIM liver study, which was an ACTG study evaluating semaglutide for the use of metabolic dysfunction-associated steatotic liver disease. These individuals went on open-label semaglutide. I'm not going to go into all the details here because you'll hear more about this, I'm sure, in the upcoming lecture. But the key finding being that a third of individuals had resolution of MASLD, and an extension phase data, again, to highlight that from CROI, this group showed that when semaglutide was discontinued from weeks 24 to 48, among those who lost weight, 75% of individuals regained that weight, really emphasizing that at this time, these medications seem to be more chronic in nature. This group also went on, importantly, to touch upon muscle structure and function. They focused on the psoas muscle here, which is important to posture as well as movement of the upper legs and hips. What they saw was that semaglutide decreased overall psoas muscle volume, and the greatest decline occurred in those that were over 60 years of age. This is really quite concerning. However, there were no changes in fat. And then with regards to function, it appeared that chair raise time and gait speed were preserved. So this is quite interesting here that even though you have changes in structure, there is actually preservation of function. So again, we don't know whether these changes in lean muscle mass are detrimental, or maybe perhaps there is some protection from these medications. And we ask this question, does quantity equal quality? All right, and so there's really limited data in HIV at this time. We need to learn a lot more, I will say. There was so much more new data presented at CROI. I will touch upon a few more kernels from there. So in the Scenics cohort, they evaluated differences in semaglutide receipt by race and ethnicity, and they saw that there were lower initiation rates in eligible Black persons with HIV despite more frequent indication. And the similar trend was seen among Hispanic persons with HIV, though it was non-significant. Which really speaks to the point of access of these medications. Secondary studies from the semaglutide lipohypertrophy RCT that I showed you show that there were potential improvements of cognitive parameters as well as potential attenuation of accelerated epigenetic aging. And secondary studies from the slim liver showed us that there might be alterations with these medications in the gut microbiota. Again, some of this data is starting to help us understand the mechanism of these medications. All right, so there's also other potential roles of these medications that I just want to touch upon because they may have relevance to individuals with HIV. So it's thought that they have a potential role in addiction disorders, and that's because there are GLP-1 receptors in the mesolimbic system. Now, the mesolimbic system in the brain is involved in rewarding properties. So there may be some overlap in food and substances based on reward pathways that may make these medications useful in both scenarios. There is preclinical research that has identified potent reductions in substance use and the attenuation of drug-seeking behaviors with these medications. Now, this has mainly been done in rodent studies. With regards to human studies, this is really still in its infancy, but is an active area of research. And this extends really to nicotine, opioids, cocaine, and amphetamines. There was one study, this is in diabetes, again, not in those with obesity, where they did show that semaglutide was associated with reduced opioid overdose among those that had a prior history of OUD. And again, we really need more rigorous studies to understand this. These medications have also been studied for their use in alcohol use disorder. And again, very limited data at this time, but one RCT showed recently that once weekly semaglutide versus placebo among those with alcohol use disorder over 9 weeks showed that there was a significantly reduced amount of drinks per drinking day as well as weekly alcohol cravings, and there were greater reductions in heavy drinking over time. So, again, we're still starting to learn more about this. And so just the last thing to touch upon is really, again, that there are metabolic benefits that just really continue to be explored in these medications. And these are from studies all derived from obesity. We can see that, in obesity, individuals may be at risk for heart failure with preserved ejection fraction or HFpEF, and that's of clinical relevance to HIV. Again, just speaking about heart disease, these individuals are also at increased risk for myocardial dysfunction, and they may be prone to a HFpEF phenotype. So we've seen that semaglutide can reduce symptoms and improve exercise function in individuals with heart failure. In addition, tirzepatide has been shown to lower the risk of a composite endpoint from death from cardiovascular causes or worsening heart failure. The SELECT trial went on to look at kidney disease as well. This is data that I showed you earlier from the cardiovascular study. So this wasn't designed to look at kidney disease specifically, but they did show that there was a 22% risk reduction in a composite endpoint that included things like mortality as well as GFR and microalbumin. The SURMOUNT OSA study looked at tirzepatide and placebo, and they saw that tirzepatide led to significant reductions in the apnea-hypopnea index as well as hypoxic burden and reduced sleep, patient-reported sleep outcomes. And because of this, the FDA just recently approved the use of tirzepatide in obesity for those who have moderate to severe sleep apnea. And finally here, we see that these medications also have some benefit in MASH resolution, which I won't go into detail about. Okay, so I'll end there with our take-home points. So we know that individuals with HIV are at risk for weight gain. Some of these risk factors include INSTI and TAF-containing regimens, as well as the withdrawal of TDF or efavirenz-containing regimens. Women are at risk, as well as those with Black race. These are effective therapies, the GLP-1s for weight loss. We do know that semaglutide and tirzepatide have the most robust effects, so we try to prescribe those first. It's important to note that the GLP-1s have an effect on all body compartments, so they will reduce visceral fat, subcutaneous fat, as well as lean body mass. I showed you data that semaglutide reduces adverse cardiovascular outcomes in diabetes, especially those with known cardiovascular disease. We also know that tirzepatide benefits extend to those with sleep apnea. There are so many other potential benefits that continue to be explored, but we need more rigorous data until we can actually make suggestions about those. And among individuals with HIV, I showed you an RCT in which semaglutide had a significant effect on body composition. Studies also suggest there's an effect on liver fat and inflammation, which is quite exciting. And of course, there are clinical concerns to these medications, that being the chronic use of these medications, the immediate weight gain after withdrawal, assessing for fat redistribution, the loss of muscle mass, aspiration risk, and of course, access to these medications. So thank you.
Well, great. Fantastic set of lectures. I'll ask Ken to come up, and we are going to try to shorten our panel discussion and finish up at around 11, because I know that folks are due for a break, and then we'll try to start up again at 11:15 and make up some time. But let me start. I wanted to ask a question regarding the decreased muscle mass. Has there been studies to link increased frailty in some populations with that lean muscle mass decline?
Yeah, so that is what we would be worrying about, is with the loss of this lean muscle mass, are we seeing sarcopenia and that leading to frailty, which is more of a clinical diagnosis. And so I think we haven't teased out sort of the long-term effects of like the loss of lean muscle mass. So you would, I think, clinically assume that when you lose lean muscle mass, that would lead to detrimental effects. Now, I want to state that we all lose lean muscle mass. So this is a physiologic process that actually happens after the age of 40. It is. So we've accumulated all of our muscle mass, and really it may be the rapidity and the amount at which this lean muscle mass loss is occurring that is detrimental. But like I said, the counterpoint to that are that, that we're losing lean muscle mass. So there just needs some adjustment of body composition. And in addition, you might be actually improving inflammation or the quality of the muscle, reducing fat in the muscle, even though we didn't see the data for that, ultimately may be beneficial. I think we still need a lot more information.
No, that's great. But it certainly makes sense to recommend strength training along when provided these. Ken, a question for you. You went through a complicated recommendation for adults with hepatitis A vaccine. Why not shift to universal vaccine, as was done with Hep B recently? In other words, it's complicated, and I think that is perhaps one of the reasons for that. You showed low uptake in adults.
Do I need this mic, or I'm good? Okay. So when you do modeling, pharmacoeconomic modeling of this, you have nationally a baseline rate in older adults of about 35% from natural exposure. And so part of the feeling is that at least a third of the population is already protected from natural infection, and therefore why bother to catch up with them? My personal feeling is that that's short-sighted, and I think we should be doing it. But again, it's a healthcare cost, because you would, particularly in those that need, that you would try to determine if they need it by doing the antibody testing, then doing the vaccination, not just vaccinate everyone.
Great. So that's an evolving area. Maybe we'll see that recommendations change. Doug, a question at the microphone?
Yeah, never in my wildest dreams over the decades of coming here would I thought we were going to be hearing from an endocrinologist. So thank you. Question. You mentioned people switching off of efavirenz and off of TDF, Black race and women. But when you look at all the studies, the variance in weight gain is enormous. So when we're in the clinic, the question is, do we avoid TAF and integrase inhibitors? And, have we teased that apart? Because the recommendations are still to use those drugs. And yet, it looks like we're creating a disaster not only for cardiovascular disease, but also for liver disease and for everything else as far as our patient's health, metabolic syndrome.
Yeah, so there have been a lot of studies that are trying to tease us apart with regards to TAF and INSTI, but I will say, because we don't know exactly what to do, the goal of treatment is always immunological. So you always want to treat the patient first with the best regimen for ART and not worry necessarily about these effects with weight. That is sort of the primary goal. And then we worry about these secondary issues with metabolic disease and weight gain. And we can treat those with underlying things. We're like the GLP-1 RAs and such. But I think you do not want to make sort of your suggestions for ART based on weight gain alone.
Great, thanks for the question. I'm going to jump to one online, then we'll go back to the microphone. There was a question about the oral version of semaglutide and where you would use that as opposed to the sub-Q, or? Yeah,
so as of right now, the oral form, which can be easier for patients to take, is only indicated for diabetes. It is given at a highest dose of 14 milligrams. Now, I will say that there may be some weight loss benefit with these medications. However, from the studies of the oral medication, there was the OASIS trial in which they actually noticed that a dose of 50 milligrams orally was needed to achieve the same weight loss as these subcutaneous medications. So the subcutaneous form is more robust for weight loss. However, it may be because of these upcoming trials and this formulation with the 50 milligrams that in the future we will have access to this 50 milligram formulation for weight loss. I will say that when I've had insurance difficulty getting approval for medications, I try different ones. And so I have tried if I can't get the subcutaneous form, to use the oral form. And some patients do have some weight loss. Again, it may not be as robust, but again, even just 5 percentage points is beneficial.
Great, thank you. Go to the microphone.
Yes, I had a question for Dr. Sherman. If you have a patient with chronic Hep B who's co-infected with D, how much benefit do you get on the D, if any, if you suppress the hepatitis B with your treatment? And should we be measuring that routinely? And is there a recommendation out there for if we should simultaneously assess that? Thank you.
So the answer is, to the first part, the suppression of B without achieving a functional cure does not affect the Hep D, because the Hep D is using that surface antigen. If you remember Dr. Bhattacharya's picture, surface antigen continues to be produced, and that allows Hep D to continue to replicate. So in fact, one of the clues that you could be dealing with Hep D is a patient that is fully suppressed, but continues to have liver enzyme abnormalities. Now, of course, we think about muscle mesh as well, but Hep D is part of that picture. Both the Asian Pacific and the European liver societies recommend that every patient with Hep B should be screened for Hep D. In the US, the AASLD uses a risk-based recommendation for screening, saying only if you come from a part of the world where Hep D is more prevalent, or history of injection drug use, particularly in areas where there were thought to be relative outbreaks, would you do it? I could tell you that in our hepatology clinics, whenever we see B, we screen for D.
Another place where guidelines seem to be overly complicated in the United States, but so there are a couple of questions related to the GLP-1s, and one of the two people had asked about reports of optic neuropathy and vision loss. I wonder if you could comment on that.
Yeah, so there were some recent reports on what is termed NAON, so non-arteritic anterior ischemic optic neuropathy. And those studies recently came out really from a retrospective study in which they assessed a combination of individuals with diabetes and obesity that were on these medications. And they did perhaps think that there was an increased risk. Now, there were some flaws with this study in that this was done at an institution where there was a referral bias. So there might have just been an increase in cases of this medication. Now there have been, one or two other studies that have come out suggesting that there may be increased risk, there may not be. I don't think we have enough information to say. So at this time, the sort of advice is just to advise your patients that this is a potential risk, and it may be more that it's seen in those with diabetes versus in obesity, because those individuals are maybe more at risk for sort of eye diseases.
Great, thank you. We'll go to the microphone.
I've had one case so far of semaglutide with a neuroendocrine tumor and carcinomatosis. I know it's in the warning labels, but can you comment on that?
Sure, absolutely. So I did mention the black box warning for the medullary thyroid cancer, which is of the thyroid cancers very quite rare. So there are more common, thyroid cancers. However, medullary thyroid cancer is part of what we call MEN2, or multiple endocrine neoplasia. And along with that, there is an increased risk of things like parathyroid tumors, as well as adrenal tumors or other neuroendocrine tumors, I believe, such as the case in your patients. So we do see it, but I think it's so rare that, it's hard to say which patients may be at risk for this. But you just want to be aware of potential other things when you're thinking about using these medications in patients. And if someone does have maybe a thyroid nodule, it may be something that you work up, send to an endocrinologist to make sure, but more often than not, it's probably not medullary thyroid cancer.
Great. Thank you. Maybe one more question. It came in on Hep E, Ken, which is interesting. I wasn't aware of this, but Noreen Hines, who was here yesterday in person, asked online about the USDA apparently changed in 2018 the recommendations for how we handle pork. There used to be an inactivation of trichinella, and now there's not. So the question was whether these USDA changes a few years ago have led to more Hep E in the U.S. Are we seeing a change in the epidemiology?
That's a great question. Overall, compared to Europe, Hep E transmission is less common, and we don't have a good reason for why that is. The suspicion is, while in Europe, one often goes to the local charcuterie where they have basically handmade products. In the U.S., and like at your breakfast this morning, there are pre-cooked sausages, and those tend to have achieved a temperature 65 degrees at least for 3 minutes that inactivates hepatitis E. Whether we will see with, also the growth of a more farm-to-table natural food movement increase again in that, it's very possible, because studies in a number of places looking at pork products in grocery stores finds Hep E almost universally in those pork products, in fresh pork.
Well, there you go. It's a vote for chicken, I think. It's sort of a reminder to cook chicken and pork to the appropriate temperatures to kill these pathogens. I'm going to squeeze in one more question. So the weight gain after stopping seems pretty clear from the series of studies you share with us today. How are you managing that? Are you simply not stopping? Or what are you advising people who do stop to keep that weight off?
Yeah, so this is sort of a golden question right now. What do we do with these medications? So generally when I'm starting these medications, I do, counsel patients that these are more long-term so that they know what they're getting into and that there may be potential weight gain when they restop. So I think it's just sort of a conversation that we have right now, just as you would with anything, discussing risk and benefits, and ultimately is up to the patient, sort of as to whether they'd like to go on the medication. There are, sort of case reports right now in terms of after sort of achieving sort of a good weight loss with these medications and plateauing, potentially starting one of the older weight loss regimens that we have, like phentermine, topiramate. But we don't have enough data to make suggestions on that. But there are potential things that could be done as we, begin to gain more data on this.
Great. Well, thank you for that. And we're going to take a break now. I want to thank our morning speakers for the great presentations. We're going to shift gears again and really focus on things that cause steatotic liver disease. Dr. Treisman, who will follow Dr. Sterling, will talk about alcohol use disorder and substance use disorder. But now we're going to really connect to that conversation we just had about obesity and now drill in on the liver manifestation of metabolic disease, what is now termed MASLD. And we're really thrilled to have Richard Sterling, who is professor of medicine and director of hepatology at VCU, Virginia Commonwealth University, join us today to talk about MASLD in people with HIV. Richard?
All right, thank you. All right, so anyway, it's a pleasure to be here. Hopefully I can see my slides without my glasses. So anyway, I'm going to focus on the next 30 minutes or so, just about first half would be more on the epidemiology of fatty liver, or what we used to call non-alcoholic fatty liver. Now, as we know, it's called MASLD in those living with HIV. And then I'll spend the rest of the time just talking about general principles of treatment. We've heard a few unique things today, and I'll talk about some of the unique aspects of HIV. But I suspect, as with other diseases, once we get into the treatments of MASLD, that whatever is working in those without HIV will work in a similar way. So this is some of my research support, but none related to this talk. And so what I'm going to talk then about is how common is the MASLD in people with HIV, what are the factors associated with MASLD in those with HIV. I'll focus some time on how do you evaluate it, particularly looking at non-invasive tests, which is an area of my research focus. But again, most of the data on MASLD and non-invasive testing were done using the definition of NAFLD, or non-alcoholic fatty liver disease, but they're about 98 or 99% the same thing, so I think we can apply it. And then we'll spend a lot of time talking about the management. I'll go over a little bit about the only approved FDA medication for MASLD, and then what are some unique opportunities. So this was a slide back from 2005, a study, and it looked at how common is liver disease in those with HIV. And if you look first to hepatitis C, which was the big disease that we were worried about for so long, as you can see that the majority of patients with hep C and HIV did have an increased AST, which is in the yellow bar, or ALT, which is in the blue bar, which was not unsurprising. But what sparked my interest in this study was this very large group of those who did not have hepatitis C. The majority did not have hepatitis B. And you can see that increased liver enzymes were also common in that group. And this was sort of, I think, lost from this trial, but it tells us that there are other liver diseases besides things like hepatitis B and hepatitis C in those with HIV. So this was a study that looked at the burden of non-viral liver disease in people living with HIV. So they looked at about 3,800 patients seen between 2005 and 2012, and about 43% had an increase in ALT on at least 2 different occasions over at least 6 months. And when you excluded those who either had hep B or C, or those who had less than 6 months of follow-up, or just an isolated single ALT, that ended up with about 1,000 patients. And of those, about a quarter underwent for further investigation. Of the 222 that ended up with chronic liver disease, you can see that 2/3 of them, had a problem. And in the majority of those, it was fatty liver disease. As you can see, it was 47% by imaging. And in the few patients that underwent liver biopsy, you can see, now we're getting kind of small. So I put my glasses back on. There's everything. It's the age in me. You can see that 5%, at least 5% of steatosis, which is how we define fatty liver disease, was seen in about 2/3, and in those that underwent the biopsy, 2/3 had at least some amount of scarring, and interestingly, 21% had at least F3 or F4, which is bridging fibrosis or cirrhosis, which we call advanced fibrosis. And not unpredictable were the predictors of liver disease were increased BMI and elevated triglycerides, two of the components that we know are part of the metabolic syndrome. But what also concerned me and was sort of lost about this paper was that most patients didn't even go any other evaluation at all, telling us that this was really an understudied disease. So when you look at those with HIV, why might they be at risk for increased fatty liver disease? And here I'm just defining steatotic liver disease. So when you have alcohol, that's alcohol-related steatotic liver disease and not non-alcohol. But some people can certainly have both, as we'll talk about. Metabolic syndrome, as we'll talk about, is very common, and we've just heard about some of the risk factors in our prior talk. Remember, to have the metabolic syndrome, one of the risk factors now for MASLD is just being overweight. You don't have to have obesity to have a metabolic risk factor, and that BMI threshold may actually be lower in HIV patients than non-HIV. There's certainly some HIV medications that we've talked about earlier. Lipodystrophy, which we don't see much anymore, but I still see it occasionally, particularly in patients who have been on some of the older ARTs a long time ago. We talked a little bit about gut translocation in the prior talk, and then, of course, the systemic inflammation you see with HIV may also be a driver of a MASLD. And then there is the genetic predisposition. There's the one that we all know is the PNPLA3, but that's not the only genetic polymorphism. There are others that are almost as likely to have a predictive risk. And so if your patient is negative for this, if you happen to do the test, it doesn't mean they don't potentially have one of the others. So this was a nice study that basically looked at an HIV group. There was about 1,200 patients, and they looked at an HIV negative control group. And you can see here the metabolic syndrome was more common in the HIV positive patients in sort of that light bar compared to the dark blue bar, with about a twofold risk. And you can see, if you look at the individual components, you can see that, again, while elevated blood pressure was more common in the non-HIV patients, particularly looking at dyslipidemia was more common in the HIV patients. And so certainly the different components of the metabolic syndrome may differentially impact HIV positive patients compared to other patients. This is then looking at a table of just how common the metabolic syndrome is in those living with HIV. And you can see here, first, that these are international studies from sort of all over the world. And again, you can see, I want you to focus on the sample size here, because as we sort of drill down who actually has a metabolic associated fatty liver disease by liver biopsy, those numbers become significantly smaller. So here we're talking often in the numbers of hundreds or thousands of patients, and you can see the standard sort of metabolic syndrome criteria, but you can see here the rates kind of really vary depending on the population. So they could be in 20% in some groups and as high as 75% in others. And so the prevalence really kind of depends on where you live and how you define it. This then is an interesting study that looked at the increasing prevalence in the metabolic syndrome over time in patients with HIV. So they looked at the prevalence was about 20% in this group. A cohort is a very large cohort, almost 25,000 patients. And they looked in between 2000 and 2001. And then they followed those patients to see who developed it over time. And over that time period of maybe over 5 to 6 years, you could see that almost doubled. It went from 20% to about a little over 40%. And then you can see the individual components of the metabolic syndrome, many of them also increase over time. So this is clearly a growing problem in people living with HIV. It's important, though, to remember that when someone has metabolic dysfunction, it's not just the liver. I'm a hepatologist, so I think everyone has liver disease, but I have to keep in mind that there are other organs in the body. And you can see here, again, we've talked about common conditions that have associations with developing metabolic associated liver disease, or MASH, or MASLD. And you can see, again, we've talked about those features in the metabolic syndrome there. And again, when you go looking for metabolic syndrome, if you go for example, to a diabetes clinic, you're likely to find a lot of it. Or if you go to obesity clinic. So it's kind of like, why are banks being robbed? Because that's where the money is. And so if you go to those clinics that have high rates of metabolic dysfunction, you're going to have really high rates of metabolic liver disease. But there are other organs that we have to keep in mind. And I think it's important, at least as hepatologists or others, when you care for these patients, you have to sort of assess the patient more globally, because they can develop kidney disease. Many patients can have reproductive issues, particularly those with polycystic ovary. As we'll talk about, cardiovascular disease is one of the main causes of mortality, particularly in patients who don't have advanced fibrosis, which is most of the patients. And it's very important then to evaluate those patients. And then again, there are other conditions that are highly associated with having metabolic dysfunction, including sleep apnea, and thyroid disorders. And so when you're evaluating patients, it's important to ask whether they have those particular questions. And perhaps the fatigue in someone who's got chronic liver disease may not be due to their liver disease. It might actually be due to sleep apnea. I don't think we do a very good job of sort of holistically evaluating our patients for all these conditions. So again, there are some unique reasons that people with HIV get the MASLD. And again, we've heard a little bit earlier from our talks about the direct HIV effects or some of the antiretrovirals, particularly those that might be associated with weight gain. We know that even when you have CD4 a restoration in the blood, you may still have abnormalities within the gut, and that can lead to bacterial translocation. Of course, those who develop lipodystrophy. But ultimately, the pathogenesis sort of all comes down to the single increase in insulin resistance, which then leads to an influx of free fatty acids in the liver, and that ultimately leads to the dysregulation of glucose and fat in the liver, and that ultimately leads to MASLD. So when you look then at how common then is NAFLD or MASLD in the HIV population, you can see here again a list of studies and again from international sites, but now you can see the number of patients looking for a NAFLD is now much smaller. We're not going into the thousands anymore. Now we're into the tens, into the hundreds. And you can see that most often in these studies, many of them use non-invasive assessments such as MR or CT ultrasound, with very few actually having done liver biopsies. And again, the prevalence of NAFLD here can vary. And it just, again, depends on whether you're looking at a cohort of patients that are highly likely to have a fatty liver, for example, someone who has elevated liver enzymes, and so they're more likely to have the problem, or just sort of the general population. Some of the studies, though, for this also included patients with viral hepatitis, because at the time, those were the patients that were being evaluated for liver disease. So when you look, though, at who can develop steatotic liver disease over time, so you have a patient, they don't have liver disease now, what's the likelihood that they may develop it over time? So this was a nice study that was published by Jenny Price and colleagues in the American Journal of Gastro last year, and she looked at the MAX cohort, and they used non-contrasted CT, and they looked at patients who didn't have steatotic liver disease, and then they repeated that at about 4.5 years later. They looked at, this was 268 men, about 2/3 were with HIV, and the ages and the gender, the gender distributions and sex distributions are seen. And you can see overall the incidence of developing steatotic liver disease over a relatively short time of 4 or 5 years was 11.1%. And you can see that the incident rate was 2.5 per 100 person years. And it was really similar in this group, whether they had HIV or not. But overall, they found that if you develop a fatty liver disease, you are more likely to have higher visceral adipose tissue, which we heard about a little bit earlier, but it really wasn't specifically related to a genetic, and they looked at PNPLA3, race, or HIV status. But in those with HIV, when they looked at it, it was the duration of ART was not significant, but they did find the use of etravirine, history of hepatitis B, or the HOMA-IR, which we know is part of the pathogenesis, were increased risks for developing fatty liver disease over time. Now here we look at who actually has fatty liver disease by liver biopsy, which is still considered the gold standard for evaluating patients. And here you can see a bunch of studies, again, mostly from US, but from other sites. But now we're talking in the numbers usually less than 100. So we're really much smaller patients because it's really hard to get many of these patients to undergo a liver biopsy. And you can see here again, depending, the prevalence is there of NAFLD, which is just having a fatty liver, not necessarily having inflammation or fibrosis, is fairly common, but it's really the NASH or the MASH, which is the patients that might be at risk for going on to developing liver complications and cirrhosis. Again, the average is somewhere between 20 and 63%, and having significant fibrosis, which we define as having at least F2, or is anywhere between 14 and 63%. And again, if you look at the studies, it kind of depends on how they selected their patients. In the studies where you had to have an abnormal ALT to get a liver biopsy, the histologic presence of MASH or MASLD was much higher than if you're just any comer kind of walking in. So this was a study then that looked at using non-invasive testing, which we'll talk about in a second, to try to assess their patients, since it's much easier to do a non-invasive test than it is to do a liver biopsy. This was a study of 282 patients with HIV. 70% were men. Mean age was 51. And here they used liver stiffness by a vibration-controlled transient elastography, or what we call FibroScan. And here they define significant fibrosis of having a stiffness of at least 8.2. To measure steatosis, they used another tool that we can often usually get when we do the FibroScan, called the controlled attenuated parameter, or CAP, and here they used a threshold of 275. And really to define who really has NASH or MASH, which is steatosis, along with the at-risk features of certain inflammation, cytologic ballooning, and fibrosis. They then combined the FibroScan or the elastography score with an AST with something called the FAST score. And when you look at this cohort, about a third had steatosis, with 27% with NAFLD, but they did have some patients who, with by history, had excess alcohol, so they called them alcohol-related fatty liver. Only 6.7% had significant fibrosis. 32 patients had the FAST score above the threshold of 0.35, and the majority of those had NASH. And when they looked at predictors of these outcomes, increased waist circumference, which we heard a little bit earlier, was a predictor of steatosis. And so BMI, again, might not be the best metric to assess for steatosis. And maybe waist circumference, which is not something that is routinely done in clinic, but should be. It's essentially free. Should be done, and we should be able to track that. Type 2 diabetes predicted fibrosis, and the combination of type 2 diabetes and an increased ALT predicted NASH, at least by the FAST score. So this was a study that was published in Hepatology in 2023, and this looked at the burden of fatty liver disease, again, looking at non-invasive testing. And here you can see that nothing was seen. This was sort of an all-comers of people without viral hepatitis. And you can see, again, almost half really didn't have much. But looking at the CAP score, almost half did have some evidence of steatosis as defined by a CAP score of 263. And there was some small percentage, about 1 out of 20, that also had alcohol-related liver disease. And when you look at, of this group, who had some liver damage as evidenced by increased liver stiffness, you can see again about 80% had a low stiffness, less than 8, when about 14% had a stiffness between 8 and 12, and only 6% had a stiffness of greater than 12, which we would define as probably having cirrhosis. So then the question comes up is, can you really use these non-invasive tests to look at whether or not your patient has it? And this was a study by Karen Morse, who was at the NIH at the time, and she looked at 66 HIV-positive patients without viral hepatitis, and they had an increased ALT. So these were patients who were more likely to have liver disease. And here you can see on biopsy, 21% had bridging fibrosis and 58% had NASH. as defined at the time. And you can see here that using liver elastography, VCTE had the highest AUC of 93% for predicting at least F2 fibrosis, using that cutoff of 7.1, with a pretty good sensitivity of 93 and a very high negative predictive value of 97%. And it outperformed the blood-based tests, which was the AST to platelet ratio index, the FIB4, and the NAFLD fibrosis score. So this is another study that then in the same population was able to compare different serologic markers, but here their standard was looking at elastography. This is not a liver biopsy, so you have to take that in mind. But here you want to know, does my patient even likely to have an increased liver stiffness? And you can see here, using APRI, FIB4, and the NAFLD fibrosis score at different thresholds, you can see overall that the FIB4 and the NAFLD fibrosis score AUC was about the same. So it was moderate, not great, but above 0.7, with, again, pretty good specificity and pretty good negative predictive value. So at least in practice, some of these serum scores are very good at telling you who probably does not have liver disease, but then you probably have to go on and do another type of test, and we can talk about what those might be to know if your patient does. So this is what we published in the American Journal of Gastro last year, and this basically looked at how accurate are these tests. And so we looked at the FIB4 and the NFS, and here we defined significant fibrosis as a liver stiffness of at least 8. And you can see that was present in about 15% of the cohort. And you can see we looked at FIB4 and the NFS. You can see the upper and lower thresholds. And so, of course, there were lots of people who were in between. And you can see the true positive and a true negative values. But I just want to bring your attention that at least for any disease, you can see here that using the FIB4, you had a negative predictive value of 90%, and the confidence intervals are in parentheses, and at the specificity of 97%, and that was at least as good as the NFS, but I think it's much more easier to calculate it. And at least for us, we have that automatically in Epic, and so we don't really have to go to an online calculator. At least in my Epic notes, it's already given to me as long as I have the components. But these non-invasive tests were really designed to detect advanced fibrosis, which is F3 or F4. And so you can see here that was only present in 6% of our cohort as defined by a liver stiffness of at least 11. And you can see here they do work really, really well with specificities of 97% and very high negative predictive values. So I think if your question is, does my patient have advanced fibrosis? Is this a patient who might need treatment even if they, as long as they have compensated disease? Is this a cohort that might need HCC surveillance? These simple blood tests can work very well, particularly to tell you who doesn't need HCC surveillance. So this was a nice meta-analysis published in Clinical Gastroenterology from 2023, and they looked at 43 studies, 8,000 patients, and again, on imaging, looking at prevalence of steatosis, it was around 34%, and prevalence of at least some stiffness was present in about 12%. And when you looked at the fewer studies that had liver biopsy as the outcome, you can see that 23% had at least F2 fibrosis, and half of the patients who had biopsy had NASH. Again, probably selection bias of who was getting the biopsy. But their main outcome and conclusion was that the traditional risk factors, things that we see in all of our patients, probably outweigh the unique HIV factors. So again, Mark had mentioned about the name change, I guess to keep hepatologists busy. And for job security, they decided that people wanted to change the name from NASH to metabolic dysfunction associated. So this was a study that was published now in APT. And this looked at 1,000 patients with HIV and NASH. You can see, again, the demographics. And overall, you can see there was a tremendous overlap. And so it really didn't make a difference between MASLD and NAFLD. And you can see the black race was protective of steatotic liver disease. It's something we've seen in many other studies, that despite having maybe more risk of obesity and type 2 diabetes, they somehow are less likely to have steatotic liver disease on biopsy and maybe less severe disease. This was also seen, I'll note, in the Hep C population when we tried to compare liver histology back in the day when we were doing biopsies on our Hep C patients. But we know that obesity and increased liver enzymes and ALT were associated with advanced fibrosis. But here, only a small portion of patients actually had alcohol with their metabolic liver disease. And in the old days, it was like, well, do we classify them as alcohol? Do we classify them as NAFLD? And so they came up with this combination of MET ALD. So this is, again, looking at the fibrosis by phenotype. So the blue bars are the MASL, the red bars are the MET ALD, and the green bars are no steatotic liver disease. And you can see, looking at least by advanced or significant fibrosis, no real difference between the MASL and the MET ALD. But you can see even 8% of those with no steatotic liver disease had some degree of starring. Now, maybe those were previously treated Hep C patients that were long-term SVR and they just didn't resolve their stiffness. But overall, though, you can see that the advanced fibrosis patients, which is a stiffness of at least 12, was more common in those with both alcohol and metabolic disease. And as we'll hear about the next talk, I think, about alcohol, is that clearly anyone with fatty liver disease should really minimize their alcohol intake. So when you look then at what happens to these patients, it really kind of depends on where they are in their spectrum of liver disease. And shown on the top is sort of the natural history progression from normal to steatosis to MASH, and then to cirrhosis and potentially liver cancer. But if you're in the group on the left, you can see that the major cause of mortality in this group is really cardiovascular disease. And as you get more towards advanced fibrosis and cirrhosis is when liver disease-related complications can begin to be more of a problem. So when we assess these patients, and I think what happens in our MASL clinic should also apply to HIV clinic, where I know a lot of HIV providers are the primary care providers for their patients. And so whether they come in through your clinic and obesity, diabetes, whether they come from cardiology or the hepatologist, the basic workup that we recommend is, of course, a metabolic assessment looking at BMI, and I think waist circumference should be part of that. Do your AHA scores for cardiovascular risk, check a hemoglobin A1C. You can even check a fasting insulin. We know that insulin levels go up before hemoglobin A1C can go up. And so that may be an earlier predictor, but insulin is not something we normally check. Again, make sure they don't have hypertension, and then we do our basic studies, and at least at VCU, we calculate a FIB4 on everybody. Again, the core principles of management they are with anyone with metabolic dysfunction, and here are the AHA sort of life essentials, and these are things that we all know, but we probably don't do a great job about implementing because we're all busy or we don't have the resources. So low carbohydrate diet. There was some talk already about the physical activity, either at least 150 minutes a week or 75 minutes a week if it's intense. Stop smoking, try to have healthy sleep habits, manage your weight, which we've already heard about, and control your lipids and high blood pressure and your glucose. So nothing really unique here. Again, when we evaluate patients, we then do our lifestyle interventions, which again are easier said than done, and we've already heard a lot about that at the last talk. And I think again, we really have to decide what is the metabolic disease that we're treating. Are we treating the obesity, which in case some of the medications we might use will also have secondary benefits on some of the other organs like we've talked about. It'll improve the fatty liver disease, particularly if you can lose a certain amount of weight. And you can see, again, you need about more than 5% to actually improve your NASH and at least 10% weight to improve your fibrosis. If you have type 2 diabetes and you need to use one of these agents, then that would be great because it may also have significant effects on the liver. And then, of course, work on your dyslipidemia and hypertension. So again, I think what drug you choose to use depends on what's sort of your major goal. What are you targeting as a primary effect, and what are you using as a secondary effect? And again, we've heard about some of these drugs in the prior talk, and there's a lot of green things, and so a lot of the GLP-1s and the dual drugs have a lot of beneficial effects across both liver and cardiovascular and other clinical effects. Again, I think that as we'll talk about, with some of these drugs, you have to know, where your patient is in their spectrum, because there might be a certain threshold of liver damage that you might need if that's your main goal, or there might be a patient who is sort of too much liver disease where you might not want to treat. And I think here, this is really where a multidisciplinary clinic of having endocrinologists, even a cardiologist, working with the hepatologist, and even obesity medicine to try to optimize the care for your patient. So this is, again, we sort of have a holistic approach, at least in our center. And again, we sort of look at all of these things and look at what do we need to treat and what are the combinations of drugs that we can use that might sort of help multiple things. Again, in those with MASLD with minimal disease, again, I think that if you want to treat obesity, then that's great. And I think, again, there's some different treatments. But again, you might be able to improve the fatty liver if they have it, but you're not really using them to treat MASH because there's a threshold of liver damage or fibrosis that are indicated for those. If they do have that sort of F2 to F3, or it's what we call at-risk MASH, then again, that's where there's only one FDA-approved drug, and we'll talk about that in a minute, called resmetirom. But if you have to use one of the other medications, you can probably get some effect with that, and we're waiting for FDA approval for those. It's coming along, and the data looks really good that it probably works better than resmetirom. But once you develop compensated cirrhosis, then I think you need to, again, those patients are in HCC surveillance, but again, most of the liver-related drugs are not going to be approved for that. And once they develop decompensation, that's when you really need to think more about liver transplant. So again, I think this has now been published in the American Journal of Gastroenterology this year. So everybody gets lifestyle interventions, and we assess those comorbidities. But I think where your patient is on the pyramid of their liver disease depends on whether you're going to do a bottom-up approach or whether you're going to do a top-down approach, kind of depending on where they are. So that's why I think assessment of where they are is very, very important. So again, the only drug that's FDA approved is resmetirom, and again, when you decide who you're going to start the therapy on, they have to have supposedly F2 to F3, and depending on your guideline of what liver stiffness value, that's what's written in how to choose what to start. So hopefully you have that available, and some guidelines use 10 as the threshold because there's a 20% variation within it. So if you have a value of 10, you're most likely to capture people with between 8 and 12. If you use threshold of 8, you might be treating people potentially who really, truly, if you repeated their stiffness in a few days or a few weeks, might have a stiffness that's lower. But in general, 8 to 10 is the starting, and it goes up to 15 because once you get to that point, then the patients definitely have cirrhosis, which it's not indicated for. If you want to start the medicine, we assess them at 3 months to make sure we're not causing any problems. There's no hepatotoxicity. And then at 6 months, you can do a non-invasive test like a PDR, a PDFF on MRI or VCTE to see if your steatosis has gone down. And then again, you sort of the go, no-go moment is after 12 months where you like to see normalization of your ALT and significant improvements on your non-invasive testing because that's when you can decide, are you going to continue or not? So when we respond, we like to see, again, a cap that's well under 280, which was sort of one of the thresholds for having at least 5% steatosis. If you can get an MRI, it's probably more accurate. And you'd like to see your liver enzymes to be normal, which remember is under 30. You like to see liver stiffness of at least a decline of at least 30%. And we didn't really the ELF score, which is the enhanced liver fibrosis score, but that's another non-invasive test you can use to assess patients' response. Then we have partial responders. They have some reduction in their CAP score, some improvement in their liver enzymes, but not quite to a normal. And then I think the non-responder that you're going to want to stop then is someone who doesn't meet those thresholds. So this might not be a medicine you're going to continue forever. So again, just to finish up here is when you see a patient who you suspect has MASLD, you definitely want to establish severity and the presence of fibrosis. And I think you can rule it out with non-invasive tests like a FIB4. Often then, if that's above a threshold, you probably want to send those patients for liver stiffness. Definitely want to manage the metabolic syndrome, and we've heard a lot about that, and obesity. Again, exercise is easier said than done. You guys are already controlling the HIV. There's some discussion about whether to switch your ART, particularly if they're on an older regimen. But again, you can consider it if they're on a regimen that might be associated with weight increase. We heard a lot about that yesterday. Look at what therapies are available to you. And then if you don't have anything, see if they're eligible for a clinical trial. So just to finish up here, MASLD is now the most common liver disease in people living with HIV, and I've heard discussions that how common it is in your population. It can present as a wide range of disorders from simple steatosis to steatohepatitis, and then to MASH, fibrosis and cirrhosis. It's strongly associated with the metabolic syndrome, particularly obesity, diabetes, hypertension, and increased triglycerides. But there is this condition called lean NAFLD, or what we call skinny MASH, which are patients who seem to have it, but they don't really have any of the features of the metabolic syndrome. Again, to have MASLD, you really have to have minimal alcohol. So if they're drinking more than you'd like, they may have actually met ALD. And keep in mind that there is an increased risk of cardiovascular disease in this population. And I think we probably don't do a really good job about trying to look at that. So just remember, discovery comes to the prepared mind. Okay. He's 25 now and getting his PhD in astrophysics, but this is the way I see him. I'll always see him looking like this, and I appreciate the time.
So we're going to shift gears, but not really. I think a lot of the things that we've talked about over the course of today and yesterday, that we know one of the overlying themes for patients with HIV that we often struggle with is addictions. The interesting part about the MASLD definition, prior to the new definitions, the assumption was you either drank alcohol or had non-alcoholic fatty liver disease, but none of these people drank alcohol. So what this did, it gave a space to look at people that use alcohol as well, which I think was really important to acknowledge that. But we're going to shift gears and talk about how we deal with patients a bit more holistically, and we're thrilled to welcome back my friend and colleague at Johns Hopkins, Glenn Treisman. I no longer share a clinic afternoon with him, but I did for many years. And Glenn will share with us some of his thoughts on addiction for HIV clinicians and really how we holistically treat patients from that perspective. Glenn, stage forward.
I'm still here. So Mark, I used to take patients with Hep C, and I would just walk them down to Mark's office and say, this needs to be treated. And he would treat them. And you talk about starting right away. We really started right away. It was great. I want to talk to you about addiction today. As all of you know who've heard me talk before, I think that HIV and hepatitis C are psychiatric epidemics. I think that the vectors for infection require behavior, and the behaviors require some psychiatric component. It's not 100% true, but it's why we haven't stopped this epidemic. And if we want to stop this epidemic, we have to consider the whole patient. Because as soon as you just say, well, I'm just going to treat hepatitis C, a subset of those patients are going to reinfect. And when they reinfect, they will infect other people, because the behavior of getting infected is the same as the behavior that leads to infecting other people. So I want to talk to you a little bit about addictions, but I'm going to try to talk to you about addictions in the kind of holistic view that psychiatric disorders are like any medical disorder. Some of them are diseases of your brain, and they're just a disease, like an infection is a disease. Some of them are problems of the kind of person somebody is, sort of their operating system. Some of the problems are problems that people get because they encounter adverse circumstances. We all think about the psychological aspects. All of those impinge on behavior. And behavioral problems can exist by themselves. That is, you can get addicted to drugs without any psychiatric comorbidity, but it helps to have psychiatric comorbidity. So as you think about our patients, you have to think about those elements a little bit. I'm going to talk about the definition of addiction, describe the core features of addiction treatment, and we describe some fundamental comorbid barriers to success. If you look in the DSM now, addiction isn't in there anymore. Substance use disorders and substance abuse and substance dependence and all these other things. If you talk to patients, they say addiction. And so I'm going to try to tell you the difference between using substances and being addicted to them a little bit. I have no financial disclosures because no one will let me talk unless I use my own slides. They all want me to talk about other slides. And so our patients are fairly afflicted with their behaviors. And when they come to talk to you, if you ask them about their behaviors, they're usually surprisingly forthcoming. I haven't had a lot of trouble getting patients to tell me what's really going on. I said to one patient 2 weeks ago, "Have you been drinking?" And she said, "Shit, I've been treatment. I'm drinking right now." And she had one of those cups, and it had alcoholic beverage in it. This is comparing deaths from HIV versus deaths from drug overdoses. One of the great problems in medicine is that we've tried to oversimplify things. Attributed to Einstein is this idea that everything should be as simple as possible, but not simpler. And to say, if you have pain, we're going to give you a pain drug, that was simpler. It wasn't true. If you have chronic pain, that's very different than you have acute pain. And we gave tons of people narcotics, and we addicted them to narcotics. And then in 2012, when we realized, after screaming about it, HIV providers and other clinicians screaming about it for years, someone said, "Hey, we're giving too many narcotics." And then instead of going to experts, they said, "Okay, we're just going to stop giving everybody narcotics." And as a result, we had the opiate epidemic, which is now killing more people than it was killing in 2012 by a huge margin. The odds ratio of getting an unsuppressed viral load is pretty much dependent on substance use and psychiatric pathology. So the patients in the Johns Hopkins HIV clinic in general have about a 95% undetectable rate, and the patients seen by HIV psychiatry have about a 94% undetectable rate. And what that tells you is these problems are treatable. This is overdose deaths involving opiates, 1999 to 2022, and you can see that things have just gotten completely out of control, and those bars are not coming down yet. They're staying up. So when you go to take whatever exam you take every so many years, they ask you if addiction is a disease. The answer on the test is yes. But there are problems with the idea of addiction as a disease because there's a volitional component to addiction that's absent from other disease states. Nobody with schizophrenia goes to a 12-step program and gets rid of their schizophrenia, but there are thousands of alcoholics who go to 12-step programs and do not drink. And you can't, by any test except asking them, tell the difference between a recovering alcoholic and a person who's never had an alcohol problem. They look the same. So whatever produces, and I'm going to talk a little bit about the complex set of behaviors that lead to calling someone an addict, it's much more complicated than a disease. Lesion models don't produce addictive behavior, but lesion models produce other kinds of psychiatric disorders. There's no clear pathological mechanism present in recovering addicts, although I'm going to tell you what I think the pathology is. And recovery is dependent on successful behavioral change, not just medicine. So I was at a meeting where somebody said, the treatment of opiate addiction is buprenorphine. It's just like penicillin and pneumonia. And one of the people in the audience stood up and said, we heard that back when I got addicted to opiates when I had pain. And it is not enough to give people buprenorphine. They need a more comprehensive kind of treatment. What all addictive disorders have in common is an increasing, continued, repetitive stereotype behavior that, despite mounting consequences, disrupts all function. So what you see is people who drink a little too much, and then they drink more than a little too much, and then suddenly they develop this very stereotype behavior where they drink in the same place, the same alcoholic beverage every day, starting at such and such a time until they're unconscious. It has to be out of the blue glass. If they can't find the blue glass, it's very distressing. It's very stereotyped. And in your brain, there's this pathway that you heard about a little bit today called the ascending mesolimbic dopamine pathway. It's the yeah pathway that you all have. So if you like watching, I won't mention SAG's weakness, watching girls basketball on TV or women's basketball, he gets a yeah when his team scores. And everybody gets a yeah from something, and that yeah is produced by a drug called dopamine, a chemical called dopamine in your brain. And you can iontophoresis dopamine right onto that nucleus accumbens, which is where that big arrow is pointing at. And animals will press the lever all day to get that. They will stop eating. They will stop sleeping. They will just sit there and hit that lever. And it's the reward pathway and behavioral driving center of your brain. Now, it's more complicated than I made it, but all addictive drugs act at that pathway. That's how they work. There's when we talk about behavior, there's this thing called the law of effect. This is 1913, a guy named Thorndike who played with cats in little boxes. He said the probability of behavior can be increased or decreased depending on its immediate consequences. So today I wore this tie with this shirt, and if you say, wow, that looks good together, I'll probably wear it more. And if you say to me, who dressed you this morning, Stevie Wonder? I'll probably wear it less. And that's behavior 101. That's how we all learn. It's primary learning. And for most things, that's how it works. But for some behaviors, for some things that we do every day, there's another component. So for some behaviors, there's an opportunity to do the behavior, and then you do it. And there's both the environmental response, where someone complains about your clothes or compliments you on them, and then there's an internal release of dopamine just from the behavior. It happens with eating, sleeping, and sex. So the baby cries, that's a behavior, and he gets milk, milk, and he gets a little yeah from his milk, and then he's satiated, and then he gets hungry, and he cries again, and he gets more milk. It's a positive feedback loop. It will amplify behaviors. After a while, you say, now you have to say please, and you have to use table manners, and you have to ask for things, and you have to taste your peas, and whatever else. And that behavioral loop will amplify those behaviors as well. And one of the questions is, you can see where this could be very dangerous, right? Because if you eat and you get rewarded, and the satiation's inadequate, that cycle can amplify eating behaviors to the point where you're chubby. I know this better than most. That positive reinforcement loop is puzzling, right? Because why is that in your brain? Because it can make you chubby and give you any number of liver diseases. It's there because probably, who's been food poisoned here? Raise your hand. When did you say you'd eat again? Somebody always says never in 37 years. And when they said never, they meant never. They didn't mean tomorrow or the next day. At the time that you're sick, you say, I'm never eating again. If somebody said, what are you going to do? TPN. I'm not eating food ever again. And then, after a couple of days, you say, well, maybe some plain dry toast. Toast. Maybe some plain pasta. Pasta. And pretty soon you're eating again, because that's a behavior that's necessary for survival. And if it got extinguished by a bad experience, you would die. And those of you who didn't have this loop in your brain 100,000 years ago, when there were no Zaggett's guides or refrigerators, and we got food poisoned a lot, ate the wrong mushroom because we didn't have a picture book of mushrooms, you couldn't join us here today because you got selected against after you never ate again. So this is a thing that amplifies behaviors necessary for survival. If the same thing can happen if you are, in terms of sleep, if you have your house catch fire while you're sleeping, I'm not going to recommend it. At first, you don't sleep very well for days. And then you start taking naps in the afternoon. Pretty soon you're sleeping. Probably none of you dated my ex-wife, but I want to show you it can go really wrong, and you can say never again with absolute conviction. But then maybe some plain toast, you know. And now I'm married to the most wonderful person in the world. Most of you know my wife, Dr. King, but without that loop, no chance. So when you have an aversive experience, this loop amplifies behaviors necessary for survival. However, there's no turnoff. That satiation arm is not there for addictive drugs. So you drink alcohol, and if you're genetically appropriate, you get a huge release of dopamine, and then you get an interest in kind of feeling that way again, and you get a craving after a while for alcohol, and you drink, and you get a big release of dopamine, and that cycle gets out of control pretty easily. So some of the things that affect this are what kind of person you are, your temperament, whether you're a risk-taking person or not, what kind of life experiences you have, do people use alcohol or drugs around you, and whether or not you have psychiatric diseases that interfere with dopaminergic reward, like depression or bipolar disorder or schizophrenia. And those things all influence whether you try the behavior or whether the behavior is particularly reinforcing. So there are genes that control risk-taking behavior are associated with cocaine use. There are genes that control how much of a response you get, of a reward you get from alcohol, and they're more involved in alcoholism behavior. So there are genes that affect this. There are psychiatric disorders that affect this. There are social connections, religious commitments, occupation, class, geography, social conventions that affect this. So they all compete for that cycle, right? The work, hobbies, exercise, eating, sleeping, sex cycles that drive our lives. After a while, these drugs interfere, and you have to pick whether you're going to get intoxicated and get fired or whether you're going to hold off. And for some people, the competing cycles of work, hobbies, exercise, sleep, sex, and eating are outcompeted by the desire for the drug. And as you can immediately see, the less of those things I have in the middle you have, the more vulnerable you are, right? So if you're a risk-taking person who has a depression and nothing is giving you a yeah, you're much more vulnerable. But if you're a risk-taking person who has depression and not getting much yeah, but also invested 14 years in school to get your current job, it might hold you off from drinking too much. And so that cycle gets out of control mostly when there's a breakdown of the other things. And you often see it go out of control very quickly when people lose the last thing that's holding them back. So for instance, you'll see patients, tends to happen in people transitioning from their teens to young adulthood, where there's no home structure anymore, and all of a sudden you're at the college dorm and you can do whatever you want. And there's not as much consequence. Or when you go out and take a job at McDonald's, and if you are late and they fire you, you can go work at Burger King. And again, there's not much structure holding you back. Or when people finally lose their job or their partner in their 50s, and suddenly there's a big uptick of alcoholism or drug use, when the only thing that keeps people from drinking is no longer in the picture. And people will say to me, I drank because I had a bad marriage. I said, well, you don't have a marriage anymore. And what starts the behavior doesn't continue the behavior. What starts the behavior is very different than the cycle of the behavior being out of control. So here's a little rat, and he's in a cage, and you can see there's wires on the bottom, a little metallic grid that can give him an electric shock, and there's a lever and two lights. And there's also a speaker. And when the green light comes on, if he presses that lever, he gets food. And when the red light comes on, if he presses that lever, he gets an electric shock. And after he's gotten used to the thing and eating regularly, whenever the green light comes on, he'll hit the bar if he's hungry. You change the food to drug. And cocaine, heroin, alcohol, benzodiazepines, cannabinoids, the rat will press the lever to get those. And When the red light comes on, he won't press the lever. Now, what happens if you put on both lights? You take this rat, you train him that the green light's going to give him cocaine, the red light's going to give him electric shock, and then you turn on both lights. What do you think happens? Most rats will not press that lever when both lights are on, because that's crazy. You get a shock. About 15% of rats will press the lever regardless. If you looked at people in Vietnam, this was done by Robbins at Iowa and St. Louis. If you look at people in Vietnam who by every measure we have were addicted to drugs, when they came back to the United States, only about 15% of them continue to use drugs. The others stop. Now, you can get this rat to press the lever when both lights are on by giving him higher and higher doses of drugs, and then more and more rats will press the lever, or keeping him in the cage longer and longer, or doing other things. And so you can eventually get every rat addicted. But there's about a subset of rats that are easy to addict, and they get addicted fairly quickly. And then you say, okay, I'm turning the machine off, and you can't have any drugs. And the rat will go press the lever for a while, then he'll stop, and you ignore the lever. Take him out of that cage and put him back in it. If you wait a week and put him back in it, he'll go over there and try the lever a few times. Take him out for a month and put him back in it, he'll try the lever more times. The longer he's been out of the cage, the more he'll try the lever, up to about 6 months. That's what we have data for. And the rat that's a quarter of a lifetime. So relapse becomes more likely the longer you're out of the cage. If you stress the rat when you put him in the cage, the pressing the lever, now the machine's off, it's not giving him any drug. If you stress the rat, responses go up tenfold. If you cue the rat, that is, if you play some music that the rat was listening to when he used to use drugs, it will trigger a relapse. And if you give the rat a tiny bit of the drug, not enough to get him to press the lever, but just to remind him about the drug, it'll increase responding 10 times. So it's a pretty good model. It's exactly what people do. When you stress them, when you expose them to environmental cues, or when you show them their drug, they will often relapse. Patients will tell you, that's what made me relapse. I went in, I had surgery, they gave me two Percocets. I wouldn't have cared anything about Percocet when I was using, but all of a sudden, I found myself back in Cherry Hill, which is one of the places my patients go to get high. And I don't even know how I got there, just was there and picked right back up. So this is a pretty good model, and it tells you what we're up against. That's what I just showed you. I won't go through it. So what do we do? Well, unlike other things in medicine, changing behavior is very complicated. And the first thing you have to do is get people to want to change. They have to recognize that they have a problem. So I call this a conversion. Other people use other terms. It's not important that you use the right term. What's important is to understand that people have to suddenly say, yes, I'm addicted to drugs. Yes, I have a problem. Yes, this has taken everything from me. Some people get that conversion to happen by something called motivational interviewing, where you say, how's it going? I'm living in a refrigerator box. You like it? No, not really. Huh. Have you ever lived anywhere else besides a refrigerator box? Yeah. Were you using drugs back then? No. And now you are using drugs, you live in a refrigerator box. Huh. It's really interesting. That kind of interviewing in which you try to get people to recognize the consequences of their behavior is an effective technique. And everybody has to use their style as a physician to do this or a clinician to do this. I'm more of a confrontation with a smile person. I found it very effective for me. But I usually will say to somebody, well, what are we going to do about your drug addiction? I don't really like that word addiction. Oh, what word would you like? So the conversion experience where people go from where they are to where they need to be in terms of getting to the next step, they need to be detoxified. If they're in that box and they're never going to stop using. You have to get the person out of the box. And we call that detoxification, but essentially you have to get the person into an environment where the drugs are not present. And that can be very difficult for addictions that aren't life-threatening. So alcohol is considered life-threatening, and you can often admit people. Cocaine is not considered life-threatening, even though it's 50 times more life-threatening than alcohol in terms of long-term outcome. People don't want to, they say, well, he's not going to die if he stops, if he doesn't go in the hospital. He is going to die. He's not going to die that day. He's not going to get DTs and die, but he's going to die of something else. So detoxifying people is a key. And then you have to rehabilitate people. You have to get those other things in that cycle, eating, sleeping, sex, work, hobbies, or exercise, back in. And that rehabilitation is difficult, but it turns out that the most powerful effect for it is group therapy. Behavioral change works best with groups. That's why AA has been so effective and NA has been so effective. They're free and they work. And they work because it's a group of people all talking to each other about how to make changes. And a group that can catch you when you get into the pattern of thinking that has kept you drug addicted. Treatment of comorbid psychiatric conditions is essential. You have to treat depression or people will relapse. You have to treat their personality problems or they'll relapse. You have to help treat their, I will call it software problems in which they've been conditioned to see themselves in a particular way. And then lastly, you have to keep them in treatment because as soon as treatment stops, those patterns of behavior tend to come back. They're habits, and you'll end up at the same old bar that you used to go to. So I mentioned confrontation with a smile and motivational interviewing. I talk to patients about my goals versus their goals and what goals we're going to use in treatment. Because the patients often want to be made comfortable. And I think they should be made better. When I had kidney cancer, I didn't want to be made comfortable. I wanted the cancer removed. And patients often get confused about what the goal of treatment is because they're in the zeitgeist. And the zeitgeist often says, the most important thing is how you feel. No, the most important thing is what you do. How you feel can be connected to what you do. But if you do what you feel like doing, often you'll feel worse over time. And so talking to patients about quality of life, longevity, and function, my goals for treatment, can be very helpful to them in illuminating what we're going to do. And then the role induction. And the most important thing in the role induction is to get people say, it's really hard to quit drinking. They're not quitting drinking. They're not giving something up. They're getting something. And it is very powerful because as a group, patients, and particularly addicted patients, are driven by drive, by reward. We as a group are consequence averse, and therefore we're less vulnerable to addiction. Reward-seeking people are more vulnerable to addiction. So you see it more often in people who want to become presidents or senators or rock stars or whatever else. These are people who are very driven by reward, and they're more vulnerable. However, once someone's addicted, even if they're an introvert and they're consequence averse, they will become more and more reward sensitive with time. It programs you that way. And you have to tell them they're getting something. They're getting a reward for what they're going to do with you. And that reward is a better place to live. That reward is less consequences. That reward is better health. You're not giving up drugs. You're getting sober. I describe my role as their doctor. I explain diagnosis and treatment of addictions. I use firm limits combined with advocacy. If you come to my clinic drunk, you have to wait and come back when you're sober. No, I'm not going to talk to you while you're drunk. Focus on problems in the patient's life and away from feelings, on behavior, rehabilitations, and problems, and away from how you feel, because I can't make anybody feel good. And that's what drugs make you do. They make you feel good. I can get you better, and then you'll feel better. But I can't make you feel better about getting better. I have to make you often feel worse. Like you're going to go through detoxification. It's going to be uncomfortable. Confront behavior. Can't means won't, need means want, and think means feel. Those are the things I say to patients all the time. One of my patients has a bronze plaque on her desk of that little thing. She said it's the most useful thing she's ever heard from anybody in her life. Can't get out of bed today. What if the bed was on fire? Well, then I could. So you don't mean can't. You mean won't. I won't go to group. Got to stop the behavior. Got to prevent withdrawal with pharmacological support. And you have to treat any potential accompanying disorders. I treat the detoxification step with active tapers. Some people do not believe in active tapers. There's no benefit that's been demonstrated in any study of going cold turkey. People are not more likely to stay sober. There's no benefit of doing it in a more uncomfortable way. Active tapers have not been shown to have poorer outcomes than just support. So if people are addicted to opiates, I give them opiates. If people are addicted to benzos, I give them benzos, and I taper them. There are suppression of specific withdrawal symptoms. Clonidine can be very helpful for patients with either benzodiazepines, alcohol, or opiates, and some people with stimulants. It's an interesting thing. Rats will pull the lever to get clonidine if they've been exposed to opiates, but they won't pull the lever if they've never been exposed to opiates. Clonidine failed as an antihypertensive because people wouldn't take it. My patients never miss a dose. If you give them 90 clonidines, they will be back when they've taken the 89th one. And then methocarbamol and other things, IV fluids. I use a lot of IV fluids on people in withdrawal. It makes it so much more comfortable. No one wants to do it. If you have somebody in the hospital and you're giving them IV fluids and they can't be discharged because they have IV fluids, nobody will hassle you. So if a patient's in my service and they're coming off of heroin and they're in withdrawal and they're miserable, I'm giving them clonidine, some reviewer will say, that person doesn't need to be in the hospital. I need to give them IV fluids. Oh. Not that I'm lying. By the way, we get to decide what's important. Like IV fluids, we get to decide if the person needs IV fluids because there's no objective measure. How much does your blood pressure have to drop to give you IV fluids? For me, it just has to be uncomfortable. Damage control and environmental change and changing people, places, and things are all part of the rehabilitation. And then medication-assisted therapy, methadone and buprenorphine. There's very good evidence that methadone will keep people off opiates the longest of any drug. Buprenorphine isn't as good, but buprenorphine doesn't disrupt behavior as much as methadone. And methadone used this way is very safe, although methadone caused the most deaths during the opiate epidemic of any opiate per person on it. If you take it PRN, it's very dangerous because of its complex pharmacokinetics. But if you take it every day, it's very safe. And if people take enough of it, they're relatively protected from fentanyl overdose. So buprenorphine and methadone, excellent things. There's an increasing interest in bupropion, an antidepressant, for suppressing drive for certain drugs, alcohol and nicotine. There's an increasing interest in a drug called Topamax, topiramate sodium, good for weight loss, an anticonvulsant drug, maybe suppressing drive for amphetamine. And then you already heard something about GLP-1 drugs, maybe suppressing drive for some of these drugs. I don't know if that's true or not because the data is not good enough yet. But certainly, I have a lot of patients on GLP-1 drugs for other reasons, and it doesn't seem to make their addiction any worse. Doesn't seem to make them relapse. I don't know if it makes them better. And then substituted dependence on Chantix for nicotine replacement, blockade of reinforcement with naltrexone, opiate. If you give opiate patients naltrexone, they have no drive to use opiates. They won't come in positive because there's no drive, there's no reward. However, getting them to take naltrexone is nearly impossible unless you pay them. If you pay people to stop using cocaine, I'm part of a big study that looked at this. If you pay people to stop using cocaine, they stop using cocaine. So the way you pay them is you say, your first negative urine, you get $20. Second negative urine, you get $40. Third negative urine, you get $100. Fourth negative urine, you get $150. Your fifth negative urine, $200. For every negative urine, you get $200 unless you get a positive, and then you go back to $20. But you'll still get $20 if you have a negative urine. And the change is dramatic in patients. As long as they're in that program, they will use, at least 40% will not use at all. And the rest will use way less. And if you look at 1 year, their soft plaque has regressed enough to pay for the whole program. And so why aren't we doing that? Because people who aren't addicted to drugs and who are introverts hate the idea of paying somebody to do what they're supposed to do anyway. They hate it. So when I'm working with kids and I give them a behavior plan, the parents will say, you want us to pay him to do what he's supposed to anyway? I say, think of it as putting him on commission. Half the world works on commission, half the world works on salary. You guys are on salary because Johns Hopkins could get more work out of me and Mark on salary than they could on commission. However, the administrators, they are on commission. They get a bonus system because Johns Hopkins figured out that you can get more work out of them, in which they torture me and Mark. They get more out of them by paying them on a bonus system. And extroverts tend to be bonus related and driven by commission, and introverts tend to be on salary. And as clinicians, we are introverts. We are consequence averse. So we tend to go with salaries, and we are upset about the idea of paying somebody to do what they're supposed to do anyway. Get over it, because it works. You want to treat comorbid disorders, particularly major depression, which is a high comorbidity for all your patients. Major depression uncouples the reward system. So normally, I showed you this, we give you a behavior to get a reward. Depression will turn off your ascending mesolimbic dopamine system. You get no yeah from anything, except cocaine, heroin, alcohol will still give you some dopamine. I won't talk about that comorbidity. We're not doing very well in combating the addiction epidemic, particularly the opiate epidemic in this country. We're willing to spend lots of money on prison. If you want to get into prison and you commit a crime, you're in prison. If you want to get into a detox program, it can take 3 weeks. Doesn't that seem backwards? There should be a waiting list to go to jail and no waiting list to get treated so that you don't commit crimes, so you don't go to jail. And jail's way more expensive than my treatment programs. Way more. I could treat 4 patients with inpatient detox for every cent spent to keep 1 person in jail. We are the front lines for these patients. We are the people who meet them. I would like you to be able to have a substance use person in every clinic, but you can't have one. You have to learn to at least get these patients started yourself. You have to become good substance abuse treaters. I treat lots of people for things that are not psychiatric because they're not going to go get it. If I find somebody has risk for a sexually transmitted disease, I test them and I treat them. We need to step it up if we want to stop HIV and hepatitis C. We can, but you have to look at the whole patient. We have to become whole patient clinicians. You've heard it from everybody this meeting. Everybody talks about the comorbidities of other things and how it impinges on their patient. We have to become holistic. Multidisciplinary, interdisciplinary clinics, great. But if you can't get one, you have to become multidisciplinary, interdisciplinary yourself. We, the unwilling, led by the unknowing, are doing the impossible for the ungrateful and have done so much for so long with so little. We are now qualified to do anything with nothing. That is the theme of our work as HIV providers for the last 37 years. People want you to do it all for free. These patients are in the discard pile, and yet it's costing society zillions of dollars because we won't invest in their treatment. And we are the people who know how to do it. So thank you for inviting me back. I hope that's useful to you.
So I recognize we are now officially standing between you all and lunch, and we do want to take a break for lunch, and we'll gather back and have a working lunch and do some case discussion. But we'll do a couple of questions. I've got a few online. Of course, the microphone is in the middle of the room. A couple of them that we're going to try to tackle. One of the online questions was about methamphetamines as being particularly difficult to treat. And what's your thoughts on how to approach that? And the question specifically asked about prescribing stimulants as a way to get someone tapered off.
Yeah. So it isn't very effective to prescribe stimulants to get people off. The studies of that have not been as good. But the more amphetamine-esque you are as a patient, the more extroverted you are as a patient. So amphetamine patients particularly are sensitive to rewards. So if you want to treat methamphetamine, incentivized treatment is very powerful. We don't do it, but it works. And methamphetamine is the most rewarding drug per kind of exposure there is, but the rewards kind of fade fairly quickly. So if you can get people off amphetamine for a period of time, they often will stay off if you can get them in a program that is rehabilitative. The problem is it's so rewarding that getting people out of the cycle of use and pressing the lever essentially is extremely difficult, and the drug is dirt cheap. So it's a big problem. But it tends to be a problem of people who are very extroverted, and that can be an asset for us because extroverts respond to rewards and they respond to incentivized programs better than, let's say, so you can demonstrate that amphetamine and cocaine patients do really well in incentivized treatment. Opiates do pretty well in incentivized treatment. Alcohol, less so, because alcohol is more of a, there's more introverted alcoholics than there are introverted stimulant addicts.
Great. We'll go to the microphone. Doug?
In the community, there's a major difference between the community and academic practice. And it's, for example, being able to either find or the quality of elastography in the community. I mean, I've sent a patient in the same place twice with completely different results within a couple of weeks. The question is we all have a large number of patients that have a little bit of an elevated ALT and no change in their platelets. What do we do? How do we follow these patients? Because they have fatty liver disease, but how should we follow these patients?
So the question is how to monitor patients. And so we, at least in our practice, we do baseline testing. And so we'll do our FIB4 and I'll do our elastography. And if we're fortunate enough to be in an academic place where we can potentially get them into clinical trials. And so right now, there is an upcoming trial which will look at resmetirom in HIV patients to show that it works probably just as well as, or not as well, as HIV negative patients. But we will then, we keep monitoring them. So for my fatty liver patients, I see them every 6 months or every year. I repeat their elastography every couple of years. But I understand that elastography is not perfect, and the more I do, I guess I won't say the less confident I am, but I'm appreciative of the variations. I've had some where my nurse will go in and do the procedure, particularly as part of a study, and the result that she says, it doesn't make any sense to me, so I'll say, here, let me do it. And then I'll go in and I might get a different result. I have one particular HIV patient that had an elastography done and it was super low, but I didn't believe it. And I said, well, and it turned out to be my boss had done it. And I said, well, he obviously doesn't know what he's talking about, but he does. And so I repeated it. I got the same number. And I said, well, this still doesn't make any sense. So we went ahead and did a liver biopsy. And he's got MASH, So very clearly the elastography was wrong. So I think you have to take it all sort of with a grain and continue to monitor them. And ultimately, you'll know the truth.
A couple comments. One is fasting for at least 3 hours before elastography is done, unless you want the score to be high, in which case having a Big Mac before the elastography is a good way to get that score up. The other is that we looked at training people to do elastography. You need to do about 80 of them before you're really good at it, and the variability starts to decline. So we actually train our CMAs in our clinic. And they go through a program where before we let them start to do clinical elastography. And some places don't have that rigorous training. It's not required to do the elastography, but it's about 80 tests. Right. So getting someone up to speed. So Richard, let me ask you, you mentioned resmetirom as a drug that's approved, and this is a selective beta thyroid agonist. What exactly is this drug?
So it definitely is, when you look at the mechanism of action, and it does help reduce the steatosis within the liver through that mechanism. But to me, it's not exactly clear why it does that. When you look at some of the other drugs that potentially have been looking at reduction of fatty liver disease, for example, the drug that was used to treat PBC and PSC, or particularly PBC, was used, thinking that OCA, obeticholic acid, was thought to be a good drug to use in fatty liver disease, but it turns out it's not the right drug for that, and it's even hard to get that drug anymore because of the FDA kind of woke up and saw that. So its mechanism of action is not as clear as what you'd expect with the GLP-1s, and that's probably why you only get about a 30% response, whereas the GLP-1s, it seems to be the response is much, much greater, and I've seen data with up to 80% with the dual agonists. And so it may end up being, again, sort of a combination, but I'm sort of surprised the drug works as well as it does.
Okay, maybe we'll come back to that during the panel discussion. I'm still not entirely sure why the liver has thyroid receptors in it, but we can talk through that, and maybe we'll ask Sumang to come through that. So maybe one last question before I let everyone break for lunch. Glenn, it's a question about how high would you go with a dose on buprenorphine? The question, it talks about someone who's got a fairly high amount of narcotics they take, and the insurance company is actually pushing back. I don't want to get you started on insurance companies because that could take a while. But
well, opiates are medically incredibly safe drugs. So there are people who have been on very, very high doses of opiates for very, very long times, and it doesn't look like there's much morbidity. If you manage the constipation, high dose opiates are not a problem. Inadequate doses of opiates, it's very easy to overdose with fentanyl. High doses of opiate agonist therapy, you're much less likely to overdose, and it doesn't hurt anybody. So it is a question of how hard are you willing to push the insurance company to give you what you think is right for your patient. I don't think that there's a ceiling. The 12 3 times a day dose, which is considered high, is what it takes to maintain a lot of patients. And so I don't hesitate. Going higher than that, you're going to have to fight a war. But again, if the patient's failing, you can say, and I say to patients, if you only had a positive tox screen, I could probably get your buprenorphine dose higher. And then they'll come in with a positive tox screen. Isn't that weird? And sure enough, and I'll be able to fight with the drug company, so the insurance company. So I don't think there's a bad thing about going higher. There is an issue for buprenorphine of the mixed antagonist-agonist thing. And so you have to watch for that. But even so, most patients do well on much higher doses than we use. Methadone, we used to standardly use 250 to 350. Now you're lucky if you can get people in methadone programs to be on 80 or 100. With fentanyl, that's not nearly enough. And so I will push programs to increase the methadone dose. Again, methadone is very complex pharmacokinetics, but if you're taking it once a day or twice a day at the same dose, it's incredibly safe. And if you take an overdose of fentanyl and you're very tolerant because you've been on a high dose of methadone, you're less likely to die. So, and methadone will keep people in treatment longer than buprenorphine. So,
great. Well, thanks for that. Okay, well, we're going to go ahead. It's about 5 after. We do want to finish at around 1:15 so we can get people to their roundtable discussions. The roundtables are really a great opportunity for folks to interact with our faculty sort of in a much smaller session, no PowerPoint slides. So we'll try to walk through some of these cases. I suspect we won't get to all of them, but the idea is here to touch on some points we talked about today and to really just have some really good discussion between the group. We'll give you a chance to vote. Now, this has been a topic that's come up on Saturday and again today, so we'll drill into it just a little bit more. This is a 6-year-old woman, well-controlled on a regimen that includes stophenylphenamide and emtricitabine, considering switching to cabrelpivirine, and had a vaccination about 15 years ago. It's in the old records. Current serologies, negative for antigen, negative for antibody, but positive for core. So this is that person who's got core antibody positivity, but no antigen, no antibody for surface. So the question is, what would you recommend before switching to a tenofovir-sparing regimen? And the choices are nothing, proceed with proposed change, nothing, but you would continue current antiretrovirals. 3 is vaccination, do the full series. And 4 is vaccination with 1 dose and check titers. You'll recall that we talked about that a little bit in the vaccine lecture yesterday. And 5 is check Hep B DNA. So go ahead and vote, and we'll see if we can maybe once and for all put this issue to rest about what to do with these core antibody positivities. So go ahead and vote. So the vaccination, the whole series. So nobody wanted to do the what's that?
The booster.
Yeah, I don't know. I think we may have got this one a little bit off. So let's talk through this. We'll see if we can't. I'm not entirely sure. I guess that would have been vaccination. So I wanted to get through, one of the things that's a little bit interesting is this recommendation that's still in the OI guidelines that says give 1 shot, measure titers a month later. Or you could use Heplisave B, give 1 shot now, 1 in another month, and skip the titers and just complete the series. So, Ken, you were involved in Beehive studies. So let me ask you, what would you do of these choices for this person who's core antibody positive, had previously been vaccinated, but doesn't appear to have S antibody now?
Yeah, thank you. So my choice on this is actually 5. I do HBV DNA testing to rule out the presence of occult disease, because occult disease is associated with increased risk of flares over time, especially in the setting of use of any immunosuppressive medication, and is independently associated with the development of hepatocellular carcinoma. So even if the risk of that being positive is relatively low, I'd like to know that on the front end. And
so if it's negative, you would vaccinate.
And then I would do 4. I would do a single dose, with the assumption this patient has previously been infected, and see if I get a booster response.
Well, let me push you on that, though. If you're using the CpG vaccine, and the threshold we talked about yesterday was 100. Aren't a lot of people going to get to 100, whether they're naive or previously infected? Because it's so good that you might have a lot of people with 1 dose hitting that amnestic.
Yep.
So is it still useful? Because that study that you're talking, that's referenced was, I think it was in Jarek's B, not quite as good.
Which reference? I'm sorry.
So that apparently the 100 comes from a 2016 study done in France that suggested 100 is amnestic response, less than 100 is not.
Yeah, that's simply based on the fact that the higher your titer, the greater the durability you have, and when you're barely over the mark, you lose it very quickly, which is something we saw in the Heplisave vaccine durability data as well.
So, Debica, let me go to you. Ken was a DNA test, then vaccine to measure response. What would you do?
So very rarely, can you all hear me? I'm going to disagree with Ken. And so I'm going to say a couple of things. One, kudos to this team for checking the serologies, right? And I think that was what we were getting at where we were talking about annual serologies. But certainly, before you are starting a long-acting regimen, check serologies. The second issue that comes up here is the core antibody situation, the isolated core antibody situation. And even if this person was not going to go on a long-acting regimen that did not have Hep B activity, that person needs vaccination. And that's different than if they didn't have HIV, right? So those 2 points. The third point is, I would say guidelines are just guidelines, right? And so in particular to Mark's point, the guidelines do recommend, in this person, isolated core, giving 1 dose of vaccine and then checking the titer. But my point, and in my practice, is that you invite loss to follow-up, and you also invite, more testing for perhaps diminished returns. And so in this case, I would actually go ahead with the full series of the HBV vaccine. I don't think HBV DNA is a wrong answer. And I think you certainly can do it. But I think the likelihood of having occult Hep B is somewhere on the order of 1 to 10%, but probably on the lower end. And I think not enough that I would do the HPV DNA testing, but I think you could.
So I think Doug's making the point that this person is currently on tenofovir. So if I check a DNA, it's going to be not detected, presumably because of tenofovir. So I know Susanna is eager to say something. I did say we would settle this question of core antibody positivity. So I think we're slowly, maybe, I don't know. But Susanna, go ahead. We have to settle this debate.
Yeah, I'm not gonna repeat. I think I just wanted to emphasize a couple things. One is, at least to my knowledge, right, this isolated core group of people, particularly for HIV. I mean, what are the studies in understanding what their response is? We know from a study that, right, Raj Gandhi, published many, many years ago, that the majority of those people will not have an adequate response. So we were just trying to convince Ken that, you can't assume, even with the conjugate or the adjuvant vaccine, that you're going to boost people, because they're a very unique patient population. They're not going to respond the same way as someone who has failed a vaccine but never been exposed to the virus, which we assume these isolated core people are. And I think the other thing that I worry about a little bit, although I think the argument that DNA test is going to be undetectable anyway if they're on treatment, is just to say, I would probably ask what would Ken do differently if he got a DNA that was 100 in a person like this. I think the key is the recognition that people with isolated core may have a very low risk of reactivation. These people are in care, right? They're coming in every couple of months. Now, this will be different when you're talking about giving one or two a year, but they're engaged in care. And so I would argue they're very low risk. They are in a monitored situation. And what you don't want to do is withhold highly effective preventative therapies or antiretroviral therapies in this case. So I just think we have to be careful about, doing a test that will impact few and may not necessarily impact your actual clinical.
So am I correct in that you're a full vaccine series person?
No, I'm not, because I think most of those people aren't going to respond.
So you're, what exactly, Dr. Nagy, are you saying?
So my take is I will give people a booster to see what happens, but I don't expect the majority of them to respond. I move forward with making a switch and I monitor them. That's my answer.
Well, why wouldn't you just vaccinate?
Because I think doing an entire vaccine series is less likely to respond. So I give one dose, I'll check them down the road to see if they responded, and I move forward assuming that they still will do well in a monitored situation. Yeah.
So Richard, as a hepatologist, your thoughts?
Yeah. So as a hepatologist, again, if I look at my non-HIV population, we do not recommend vaccinating the isolated core antibody person. We know that if you do vaccinate them, they will most likely over time lose the S antibody again. So we just assume we've just sort of wasted it. And I have this, I won't say argument, or I have this discussion with my HIV colleagues where I co-manage a lot of these patients, is that I thought I saw yesterday there was data that the reactivation rate was 0.7%. So I guess you'd have to vaccinate 100 people and to prevent one. Seems like,
so I think the vaccine.
Is that what I saw?
It was lower if they were S antibody positive, higher if they were antibody negative.
Right.
So all right, just to move this discussion along, Richard, what would you do one of those on there? So Susanna was a 4, I think. Right?
I don't. So I think, again, occult DNA is a possibility, but I'm not really sure what to do with that information either. So I don't recommend it. I recommend just, monitoring them. And I think if you're going to monitor them, you can monitor them with the DNA 3 months off and see what happens, but not before you make the switch, because as pointed out, they're going to be negative. So that's not very helpful. So I'm not vaccinated.
So let me try to summarize this isolated core antibody where you're not using tenofovir. I think a couple things. One is that person, before you make an antiretroviral change, does need a triple panel, surface antibody, core antibody, and S antigen. their risk of reactivation with dropping tenofovir is actually relatively low, and probably pretty low if you're using 3TC dolutegravir, because 3TC does have some activity. I think you really could, you've heard across the board among experts that any one of a number of strategies is potentially okay. I think the guidelines, as they're written, do recommend at least one dose of vaccine. I tend to favor the sort of just finishing the series out because it's just easier to do. But I think what you're hearing is that the most important thing is testing for isolated core, understanding which patients may be at risk, and then monitoring them with at least ALT levels every 3 to 6 months. And then once they get settled in, every 6 months, checking ALT. It's being aware of the risk of flare and then monitoring for the possibility. If ALT goes up, think Hep B. The vaccine piece, I think you've heard from some of us. Many would do at least one shot. A lot of us would do the series. But the most important thing is to think about it. So I'm going to actually skip through these because I think I'm going to leave that. I'm just going to leave it be. Okay, this was a patient I saw recently, 49-year-old man, well-controlled HIV, presents with fatigue, abdominal pain, jaundice, nausea, and vomiting, admitted to a local hospital, had an extensive workup for liver disease, saw a liver specialist. ALT level was in excess of 2,000. Bilirubin was 11.6, had an MRCP and a lot of other tests. He was Hep C antibody non-reactive. Surface antibody for B was positive. Hepatitis A total was negative. He had a couple of, about 2 months ago, treated for primary syphilis and had a hemorrhoid surgery about 2 weeks ago. Medications include a bictegravir, TAF, FTC. He also takes doxy-pep. So what additional testing would you recommend? STI panel, Hep B DNA, HDV RNA, Hep C RNA, or both 1 and 4? Now, hopefully we'll have 5 choices here. Yeah, so a lot of people want to do both STI testing and HCV RNA testing. Dr. Nagy, I'll start with you. What would you do?
You should always test for hepatitis C. No. So, I mean, you should test for things that can cause elevated liver enzymes, and what could you be missing? And so I didn't see a Hep C test on there. That's for sure. Although those numbers are awfully high for acute. Antibody was negative. Yeah. So, I mean, right. So like I said, there's not a Hep C test on there for, recent acute Hep C. That's exactly right. And then the only other question was whether or not for his surgery, had he actually, the other test that you would be missing is acute hepatitis B. He was obviously, this patient was obviously on, I think, a TDF containing regimen, but if they had stopped it and were in a period of not being on drug, they could be at risk. Yeah.
So he was you think S antigen testing was sufficient? He was S antigen negative.
No, I'm saying if this was acute hepatitis B in the setting of being a high-risk person who has come off their medications. Yeah.
Or in the window phase.
In the window phase. So a little bit of.
Right. I didn't see Hep E on there.
Yeah, I did not put Hep E on there.
Because that clearly.
So, right. Ken, if you were asked to see this person on consult, as one of our hepatology colleagues was, what would you be thinking of? Would it be Hep C and potential, or any other things that come in your mind that should be in the differential?
Yeah, I would be focusing on Hep C, and with liver enzymes that high, I would be also going back and looking at the surgical records for evidence of a period of hypotension with ischemic injury.
Great. Let me jump forward. So he did have hepatitis C. His RNA was positive at 296,000. His syphilis testing actually had come down from his previous titer of 1 to 32, and then he'd been treated in the ambulatory setting about 2 months ago. So it didn't look like he had acquired syphilis again, although that's certainly something we were concerned about. Richard and Ken, I'll ask you, syphilitic hepatitis, what's that look like?
I've seen it, but it's the one that I saw. It was more cholestatic picture than hepatocellular, and that's also, sort of surprised, but it was somebody who they thought it was an older patient, HIV negative, and they thought patient had biliary tract disease and was sent to us from another hospital. And I went in to say hello to him. And when I went to shake his hand, I said, "How long have you had those spots?" Again, I don't think it really takes rocket scientists to figure that out, but that's how I made the diagnosis that was missed by.
So
by everyone else until then. So, but
yeah, so it's worth noting that I think it was Osler. One of the many Osler quotes was, "If you know syphilis, you know disease," and it does cause hepatitis. It's this cholestatic, elk phos up, bilirubin up kind of pattern. Definitely think about it. So a month later, he comes in actually for an appointment. Labs look fantastic. He feels fine. His RNA is down to 596. So we'll go to our next voting opportunity. What would you recommend? One is start treatment with oral GP for 8 weeks. 2 is start treatment with GP intramuscular injection, 1 injection. 3, start treatment with Sofl for 12 weeks. 4, repeat Hep C testing in 2 months. Or 5, treat with penicillin G IV for 14 days. Go ahead and vote. Let's see. So we've got, I think there were 5 choices, and we've got 4 here. So maybe we'll have to... There's 4. Okay, perfect.
Maybe the NIH cut one if you want.
Great. So it's sort of a mix. I think, I guess one question I wanted to ask, his viral load is coming down. And I'll jump ahead. I actually ordered treatment for him. And the next time I tested, it was even lower. It was at about 50. So what to do? Susanna, you're eager to weigh in.
I mean, his Billy was, I think you said his Billy was like 11. I mean, we do know that for those people who will naturally clear, which to be clear, for an adult exposed to hepatitis C, the response, I mean, the clearance rate is very low, right? I mean, we would argue that 80% of these people will go on to chronic infection, which is why it really is a recognition that these people should be treated. But seldom do you, I mean, when we talk about treating acute hepatitis C, you also think about the population and wanting to get people access to drug who may not come back. But if you now have data and a Billy of 11, that is one of those markers that says that he is much more likely to clear, right? So you don't want to ignore information that might actually help you do something slightly different, because that is a predictor that he may actually clear, and he's in a very early period of the infection. So in that case, and I've had a couple of these, I probably, depending on the patient, would have said, let's repeat and make sure you're not going to naturally do this on your own, because you've presented a case that is selectively likely to clear as opposed to one who's less likely. Yeah.
So a couple of factors to add. One, he does have a regular partner who, that's why he's on doxy-pep, and that's probably where his hepatitis C came. And then the second point is I repeated another one. It went to 28,000. So it popped back up. So would you treat now?
Yeah.
Okay.
And I would treat his partner. I'm big on bringing the partners in and trying to get them treatment, and depending on where they're getting care, trying to get them in. Yeah.
So maybe one thing to touch on, there is no long-acting GP, although those of you who may have been at CROI, Charlie Flexer didn't mention this yesterday, but a group of pharmacologists in Liverpool have taken glecaprevir, and they've worked on a formulation that it looks like, at least in the rat model, can give exposures with a single IM injection that lasts for about 8 weeks. Now, obviously, rats aren't people, and there's hope that they could transition this to people and maybe get to what we'd think of as a one-shot cure. So get to a test and treat with a single injection, adherence, all those things taken care of. So there is work on it, but it's just not here yet. Well, let me jump ahead because I know we're a little bit short on time. So this is a 58-year-old man with HIV and Hep B treated with tenofovir for more than 20 years. Hep B DNA not detected about 2 years ago. The last time someone ran his serologies was about 6 years ago. The last time he had an ultrasound was about 6 years ago. Been getting really regular HIV care. And he was actually referred for consideration of a Hep B cure clinical trial being conducted in our clinic. Liver stiffness was 5.2. So my question is this. Which of the following monitoring schedules would you recommend for individuals with HIV and Hep B? One is antigen yearly and DNA every 6 months, DNA antigen yearly, ALT every 6 months, and Hep D DNA if it's elevated. Or would you get an RNA correlated antigen and surface antigen yearly and DNA every 6 months? What is the recommended schedule for monitoring someone with HIV Hep B co-infection? I think so. So let's see, the vote is for measuring ALTs and then some for DNA. Debica, I'll put this one to you. What do you recommend? You've got a patient with HIV Hep B on tenofovir. What are you recommending your colleagues in the HIV clinic do?
Can you go back to the options?
Oops.
Yeah, I mean, I would do the surface antigen yearly and HPV DNA every 6 months. And Susanna and I were just having a side conversation. And, her point is why are you checking surface antigen yearly? Because if they're going to be positive, what is the likelihood that they're going to lose? We know that if you're not losing your surface antigen within the first 2 years after initiation of antiretroviral therapy, it's unlikely that you're going to lose surface antigen over the next several years after that. That was the data that Mark was alluding to, that actually persons with HIV and Hep B co-infection actually have higher rates of surface antigen clearance compared to Hep B monoinfection with initiation of antiretroviral therapy. But I would still say that there is benefit to even assessing, given how cheap the test is, yearly to see what their risk stratification is subsequently for things like HCC, et cetera, to see where they are with their surface antigen. I will also say that it also helps you, again, decide whether or not you can put them on long-acting therapy, right, if they lose their surface antigen. The HPV DNA every 6 months is really about measuring, just like we do for HIV, adherence. So I would have picked one.
So let me ask you, surface antigen yearly, Ken, how do you manage your Hep B patients? Anyone on the panel, how often do you check surface antigen in someone known to have positivity in the past?
Unless there's a change in the unless there's a change in the ALTs, I only do it every few years rather randomly. I do follow the HPV DNAs, but I usually am looking for something to prompt me to say what's changing, what went on. Now, as we move to some potential newer therapies, we may want to know quantitative HBsAg levels, but we're not quite there yet.
Yeah, I do it yearly. And I did just want to make that quick point about, as there are going to be HPV cure therapies available, one of the criteria, it may very well be a surface antigen within the last 6 months or a year. So having that information, which I would get anyway, but having that information may be helpful to them.
So ordering quantitative surface antigen, it's a test that's available now, how much surface antigen, not recommended by guidelines, but what the panel is alluding to is that one of the drugs in phase 3 clinical trials is an antisense oligonucleotide that's taken by subcutaneous injection weekly for 24 weeks. And in their phase 2 study, if your surface antigen level was less than 3,000, there was a chance, let's call it 1 in 5, that you might actually lose surface antigen and develop what's called a functional cure. So they went ahead and did a phase 3 clinical trial, which is fully enrolled right now. But to get into it, you had to have an S antigen level less than 3,000. And there are ongoing studies of that in people with HIV as well. Same criteria, less than 3,000. So I must admit, I've started to order the surface antigen just because I'm thinking about curative options, but I don't do anything with it, but it does give me something to talk about during these visits.
I do it yearly, but I have seen people lose S antigen, HIV patients, well after the 2-year mark. So it does happen, and I think it's a milestone, and I'm going to see them anyway. And it reminds me, I do it, and I do their HCC surveillance, and it's like not a big deal.
So he did in fact.
I was just going to say, I just think it's important for the group to know that the AASLD guidelines recommend an annual surface antigen in all these people. I think what you're hearing is that some of us, once someone's has chronic Hep B for a long time, some of us maybe do it less than annually, even though the guidelines say annually, because we know that loss is like a compounded loss, right? Over 10 years, it's a higher chance they'll lose it than in a 2 or 5 year period.
So I think what you're really hearing is that it's kind of depressing to order it once a year and it comes back positive. The patient says, well, gosh, what can you do to make this S antigen go negative? And you say, well, we just have to wait for your immune system to respond. But don't worry, in clinical trials, there's drugs coming. So it's a little bit depressing when people don't lose surface antigen. But in this case, he actually did lose his surface antigen, but he doesn't have an antibody. A bit of a surprise to everyone. It hadn't been checked for a while. What are you telling people who achieve functional cure? Do they still need to be monitored every 6 months and screened for liver cancer?
Yeah. I'm happy to jump in again. One of the studies that I was really struck by recently is not a study in persons living with HIV, but it was a large cohort study done in South Korea, I think, and they were looking at seroreversions, right? Like those who were surface antigen negative and then became surface antigen positive again. And while that overall is actually quite rare, on the order of less than 15%, the group for whom actually had the highest rate, 50%, were those individuals who had been on therapy, right, and who then lost surface antigen, suggesting that there is still some protective effect. Now, one study was in in Hep B monoinfection, and it was in a population who has a long-standing history of Hep B based on likely transmission. But I do think that is intriguing. For this person, I think what you can tell them is, one, I guess the question is, are we going to continue on, he was on dolutegravir or Vic. Are you going to continue his HBV active therapy or go to long acting? I think that's one conversation if he or she wants to have it. But then the other thing I would say is, look, you've achieved functional cure. And if you look at the Kaplan-Meier curves of both HCC and survival with those individuals who have lost surface antigen compared to those individuals who have surface antigen, the likelihood of developing HCC is less in those people who've lost surface antigen. And so I think this is kind of the happy story that you can tell your patient, this is why we're checking, so we can now tell you that your risk is less. Stop there.
You can theoretically take chronic Hep B off the chart after a period of time. But Ken, what would you do?
Yeah, so though in the studies, most of them are using just HBsAg loss as the definition of functional cure, I think the data is emerging. There were several abstracts at CROI that say that if you use an ultrasensitive assay, that those patients still have HBsAg if they do not develop antibody. And that's why we see higher rates of potential relapse in those patients. And I think we're going to continue to see an evolution of this definition. That the companies working on drugs want the simplest yes as possible, and that's just get rid of HBsAg. But I think that ultimately forming anti-HBs will be important.
Yeah, a couple of things to think about. One, in some hepatocytes, there's still cccDNA that is the template for replication. It's still there. You haven't gotten rid of that. The second is that there's antigen bound to antibody in this person's blood. So there's these immune complexes. All right, I don't want to open this can of worms, but I will. Would you vaccinate him with Hepatitis B? I recognize the can of worms. Let's just have a show of hands. Who would vaccinate this? Ken just told us we want surface antibody to be positive. Who would give him Hepatitis B vaccine? Show of hands. Yes, I would give vaccine.
On the panel. Oh, I thought you were asking that.
Yeah. I'm going to ask the panel. Yeah, it's a good question, though. I didn't specify. Let me ask the audience, because you've heard this, the erudite panel discuss this issue or reach consensus. I want to see what you took up. Who would vaccinate this guy with Hepatitis B? Show of hands in the audience.
It's not going to hurt.
Okay, how about our panel? Who would vaccinate with Hepatitis B in this case? Show of hands.
I think we're in a data-free zone, Mark.
Yeah.
Yeah. It's interesting because if this person came to you de novo, this person is going to be isolated core. You didn't tell us, but assuming that their person's going to be isolated core. And in that setting, you would vaccinate, right? But this is different. We've kind of gone through the evolution, and we've gone through the evolution with treatment. And is that evolution of treatment-induced immunity different than natural immunity? I don't know, but I probably wouldn't, and I'd monitor.
Yeah.
Just one quick one. There have been studies. We have some data on therapeutic vaccines used in this setting, and they don't generate a response.
Yeah.
So
So I'll give you what I actually did with this guy. We talked about it. This particular patient is actually a retired healthcare provider. We talked about it and said, you know what? Let's go ahead and try. Went to the pharmacy, got 2 doses, one now, one in a month. The Beehive study wasn't out yet when we did this, and he didn't respond. So never got a surface antibody, and we're still following. One point to make, though, I'm still checking him every 6 months with DNA, ultrasound, and AFP for hepatocellular carcinoma screening. I haven't discharged him from that panel yet. All right,
He could serorevert and develop S antigen again because he never developed S antibody.
Yeah, that's why I monitor him pretty closely.
How about just screening our hepatitis B patients, chronic hepatitis B patients that are on tenofovir, regardless of their stage of disease, or so they're on staph cirrhosis, or whether or not what their age is. I was talking to Susanna about this before. Should we be screening them for hepatitis carcinoma all along, regardless of their age and whether or not they have cirrhosis?
Yeah, I think I might have a case on that. I'm not sure if we'll get to it, though, just because of time. So let's talk about the recommendations for screening for hepatocellular carcinoma in people with HIV. So it's based on the incidence of liver cancer in that population. We heard earlier, Hep C, people who have cirrhosis before cure. Hep B, who are you screening? Ken, I'll ask you, you've done a lot of work in the cancer space.
Yeah, I mean, let's start with consensus guidelines. U.S. has risk-based strategy that is tied at different ages and family history to risk. There was a recommendation from a European consensus group that said all patients with HIV should be screened on the same schedule of at least every 6 months with ultrasound, with or without AFP. So that's what I've done in my practice is for all patients at all stages with HIV, I tend to screen. And in other groups, I tend to defer to the risk-based practices.
Which, so to summarize, for people with HIV, I think there have been recommendations for sort of screening everyone with B, people with cirrhosis with C, and then getting ultrasounds and AFP every 6 months. That interval is based on trying to identify a tumor while you could still potentially treat it for curative intent. Question in the back there, yeah.
You were saying Hep C with cirrhosis. What about F3?
F3 is, so I'll tell you my opinion, and I'll ask Susanna. I tend to put people in buckets with hepatitis C and staging. You heard some talk about FibroScan being a little bit kind of iffy with staging. There's some error around it. So I put people in buckets of good, bad, or in the middle. So I tend to lump F3 and F4 as someone who I might continue to stage. Although there are studies showing the risk is lower if you have accurate staging. But I don't know. What do you do?
No, I do the exact same thing for what you just described, which is that we don't accurately, we have no test, including a liver biopsy, that could actually definitively say an F3 wasn't an F4, right? If they're F4, they're definitely F4, but if they're F3, they could be F4. And because of that, I have always lumped them in that same bad bucket. Not bad person, bad liver disease, need screening.
Yeah, go ahead.
I had an F3, and it took him 8 years to develop hepatocellular carcinoma. And I was ready to just, by FibroScan, ready to just let him go about his business.
Yeah, even in the Halt-C.
But do you want to miss that one?
Even in the Halt-C trial, which was only for patients with either bridging fibrosis or cirrhosis, and these were patients that were followed, closely. There were cases of HCC that developed in adjudicated non-cirrhotics, so definitely F3. So It's uncommon, but all you have to do is to see one, and then you start wondering whether or not you should be doing ultrasounds on everybody. So I'm like Mark, I'm a lumper, and I advanced fibrosis, particularly if their FIB4 was greater than 3.25 at any point. That's the group that has ongoing risk. It's lower, but it's still above the minimal threshold.
I think one of the issues to think about is just any test you order, there's going to have an error rate around it, some variability. And some tests, like our PCR assays, they're very accurate. If your viral load comes back at not detected, you can be confident in that. With liver disease staging, whether it's biopsy, elastography, blood test, it's really not a precise assessment. It's putting people in risk categories is what we're trying to do. So I think you have to be a little bit cautious about trying to split F01 or F34. But I want to get to this case. This is actually a patient I saw just a couple of weeks ago. Cured her hepatitis C about in 2015, so now 10 years ago. She has hypertension, type 2 diabetes. Before the cure, her FibroScan score was 12.2. We did not have CAP at the time. Her weight was 152. More recently, the FibroScan score has been a bit lower. The CAP score has been up. Her ALT and AST are high. Weight is up. And there's also this vexing problem of alcohol use. There's always a sort of story around it. And more recently, we added PEth as a measure of and she's been positive. So, Glenn, I've referred her to the team in the Bartlett practice many times, and she's declined to go.
She doesn't like me.
She didn't expressly say anything about you, but she did express that about, in general, 12-step programs, therapists, medications that might help with alcohol use disorder. So what should I be thinking about here with her? And because clearly she's got potentially metabolic liver disease, but the alcohol's not helping.
That's real. Those are real alcohol levels. That test is good for half-life for phosphatidylethanol.
Oh, yeah, sorry. Go ahead. Use the mic.
Oh, sorry. Yeah. So the half-life for phosphatidylethanol is about 4 to 7 days. So those are real numbers, and I think the alcohol is making a significant contribution. And I think this is a person where how's it working for you might be a good place to start, and asking her what if she's drinking to that number. I would bet there are consequences in her life from drinking that are that would come out in longer conversation. And if you could send her to us, we would have the conversation. But since she won't go to see us, if somebody has the conversation, you might be able to persuade her to go see us. There's a lot of things we do besides 12-step programs. Everybody tells me how 12-step programs never work. They never work. They never work. And then a lot of people end up going to 12-step programs and they work. But there are people who get better with just seeing us and talking about it. She might have depression, and people like this can be very evasive about the depression answers, and that could help her a lot.
Well, Glenn, I don't want your head to get too big, but I've been coming to this meeting for some time now, and I tried to use some of the Treisman techniques in the office with motivational interviewing. It didn't work. So maybe that's me and my delivery.
Wait, it doesn't always work. It's kind of like the Hep B treatment thing. Sometimes they get undetectable, and sometimes they don't.
But I will say I will say that your what you've taught me in the OPMAN course over the years has been helpful. So Simon, let me ask you, her endocrinologist started semaglutide. I don't think they were thinking liver at all when this happened. I think it was really her A1C had been up to about, I think it was a little bit over 8. So what are your thoughts in terms of it wasn't for weight loss, it was really for diabetes. What are your thoughts on her sort of picture?
Yeah, so I think in terms of the semaglutide, she has, we don't know her BMI, but she does have an indication in terms of the diabetes. And in addition, there has been, other benefits to using these medications. We know on, MASH, as well as even some side studies suggesting that there's improvements in hypertension. Now the data regarding, I did mention the use of these medications potentially in alcohol use disorder, and that's primarily based on preclinical studies. I don't think, as it was mentioned in the other lecture as well, that we have enough data to suggest that this may have a benefit on alcohol use disorder. But I think there is some sort of common pathophysiology between sort of reward pathways for food and alcohol, which may make these beneficial. Now, the other, I think anecdotally, not doing an RCT, I have had patients come to me in clinic without me even asking saying that they have had reductions in alcohol use, and even some of their partners that are also on the medication. So I do think we're seeing some of this. The other sort of, aside from reward pathways, the other thing that comes up with these medications is that they are causing satiety. So individuals, aside from alcohol, will say things like, oh, I'm not drinking as much water as I have been before. So there might be just a satiety component as well.
No, that's great. I forgot to put in she's relatively short and has not gotten taller in the last decade. So her BMI was in the ballpark of 33 to 34, in that range.
And so the other thing is, if this person was initially started on the semaglutide for diabetes, you can maybe switch over to an indication of obesity, and there's a higher dosing. And then in addition, if you're starting to plateau with semaglutide, in terms of weight, and you really want to, if her weight is 170 and you're trying to, for, liver benefit, get about, if there is MASH, about 15% weight loss, really a semaglutide will achieve that. But if you are reaching sort of a upper threshold with that, you can potentially switch to tirzepatide, which should offer more benefit.
That's enough work doing the Hep C prioritizations. I don't know. I think I'll leave that. But Richard, let me ask you, her FibroScan score dropped, but does that CAP score, what do you think of those liver enzymes? Maybe a question for our card-carrying hepatologist.
Right. So I think that first of all, I'll make the comment that at least in our practice, we have a saying, in God we trust, and everyone else gets a PEth. So we do a lot of PEth testing. And so this person looks like they clearly have med ALD. And so I think from a prognostic standpoint, there's a lot of, she's going to be worse off over time. And so I think I would probably, the drop in the FibroScan from 2014 to 2023 is encouraging, but that may or may not have been due to the improvements in inflammation from HCV cure rather than from other things. Although given it's been so long, you could sort of assess that's her new baseline thing, but I would repeat it now and see, where we are. I didn't see platelet counts. So it's probably a patient, again, with med ALD. And so you need to get both on control of the diabetes and control of the alcohol for them to have optimal, spending a lot of money on a drug when they could actually save money if they didn't drink.
So, Ken, let me ask you, remembering something from medical school about AST being higher than ALT, what should I think about that ALT and AST pattern?
Yeah. So first, almost everything that you learned as a clinical pearl was probably wrong. So the original observation came from Hy Zimmerman, and he said that if AST is higher than ALT and less than 8 times the upper limit of normal, you're probably dealing with an alcoholic hepatitis as an etiology. And over the years, that got translated into, if AST is higher than ALT, then alcohol is doing it. And that is not really the case. There's many things that do that, including in later stage disease. We often see that kind of transition.
So don't read too much into that. But those are not normal ALT and AST levels. We can agree on that?
This is a woman. She should be at 19. So she's losing liver cells at 2.5 times the normal rate that she should be.
And so to ballpark it, at least in there's some debates about this, but for men, ALT normal less than 35 or 30, women 25 or 20. That's normal, not what your lab reports. So she's at least 2 times normal. So let me just go ahead. So how would you classify, Richard kind of blew this one, but, how would you classify recurrent disease? Obviously what I was going for was the MASL D plus alcohol and met ALD. So maybe we'll skip the voting in the interest of time since Richard gave you the diagnosis. I did want to just, maybe not. But I did want to just highlight, what a standard drink is. It's 10 grams of alcohol. I actually find these charts very useful. And in the clinic, certainly asking what people are drinking, there's 24 ounce malt beverages, which would actually be more than a standard drink. And it's worth kind of classifying where someone's drinking, how they're doing it. So I find this kind of chart actually pretty useful when I'm talking to someone and really getting pretty granular about what they mean when they have a 6-pack of beer or some other beverage. And then Richard didn't quite show, I just wanted to highlight this as well, where that middle section to make this diagnosis of metabolic plus alcohol, you sort of grade the amount they're drinking and suggest whether one is more predominant than the other. But I think in a sense, I think this is the chart that kind of split up the steatotic liver disease. So I'll just jump to what I observed just 2 weeks ago in clinic. And I had no idea that we were going to have this conversation today, but her weight was 10 pounds lower a couple of weeks ago. Her A1C was now down to 6.4, and she had reported less cravings. I took the Dr. Sterling approach and said, that's fantastic, amazing. I'm going to check her. I'm going to order a PEth. I did, and it actually came back as negative. So I put in, you saw this study a bit earlier from JAMA Psychiatry, which is suggesting it may work with alcohol use disorder. But I wanted to, so it was quite, I felt like I learned a lot from her case just in this most recent visit, and that I was thrilled to learn more about management of obesity and how these may work on the reward pathways. So she's been undergoing liver ultrasound and AFP for every 6 months for about 10 years, and she's actually pretty good with going to liver ultrasounds and getting your AFP test done. She does like to come into the clinic and is pretty regular with doing that, does not like to see Dr. Treisman. So she asked if she can stop the ultrasounds. They're kind of a pain. Blood work we can do in the clinic. The ultrasounds, because of Medicaid, we actually have to send them off out of the hospital into an unregulated clinic, which is literally, she has to get a ride to about 30 minutes away, and it's kind of a pain. So she asked if she can stop the ultrasounds. So we'll go ahead and vote here. Yes, you can stop all liver cancer surveillance. 2, yes, you can stop ultrasound, but continue the blood AFP, or no, continue both ultrasound and AFP. So it looks like the majority of people would want to continue liver cancer screening for her, even though her liver stiffness score is 7.5. Is there anyone that would change their hepatocellular carcinoma screening pathway?
Why did you repeat her finding? Did she normalize her liver function test after hepatitis C was treated? And why did you repeat? Were you in a serial virus?
That's a great question. We can have a conversation about that. I repeated it in part because I was worried that her ALT and AST were elevated, and I didn't have a CAP score on her before. So I wanted to see, number one, was she progressing? Number 2, did she have evidence of fatty or steatotic liver disease? And number 3, I was worried the ALTs were a bit up, which I thought I knew why, but I wanted to see. But how often do you guys repeat fiber scans?
Debica was literally just asking me that. And I don't generally repeat these yet, but in our clinics, we have folks who do. And so we have that data. And I'm always like, why do you get a test that you shouldn't necessarily be acting on? I mean, I think, and I'd love to hear what other folks think. I mean, right now, I don't think I've seen data. I think data is coming, and there's some data that's reassuring that says, and I think you heard someone say, I think it might have been Ken, but that after someone's cured of their hepatitis C, we do know that some patients, if you trend their elastography scores, will decrease, because remember, that reflects both fibrosis and inflammation. And so you expect if someone has inflammation from chronic hepatitis C, that's going to get better, but that doesn't mean the fibrosis has gotten better. And we also talked about just recent data in the DAA era that says even 6 years out, people's risk of HCCs are continuing to occur. And so I just haven't seen data yet that says at 5 years out or a year out from SVR, if your FibroScan is this or your FIB4 is this, that you can safely stop doing HCC screening because that person's risk is now low enough. I think there's some data out there, but I have not seen sufficient data to change my clinical practice in that way.
So the ASLD guidelines tell you not to use non-invasive testing to monitor after therapy. Yeah. And that's because there's just not enough good data. But I think there might be a point at again, kind of depending, that where the risk becomes not that much, greater, particularly when if this person was just to show up now, you would never do HCC surveillance because they didn't meet the threshold. So I know that risk is lower, drops about 70% after cure for HCC. So at some point there's going to be, you haven't developed it by now, and you probably aren't going to, because it is costly and inconvenient. But we don't have that. We started the treatments in 2014. And so we're just now at the 10-year mark with a lot of those SVR patients. So I'm thinking that we'll have that data in the next couple of years.
So I guess the last comment I'll make on this topic. So liver becomes stiff when it's inflamed. So the scores we use, the 12 or 12.5 for cirrhosis, that was done on people with active Hep C and liver inflammation. It's not clear that those same cutoffs, so now you've cured someone, their ALT is 20. It's not entirely clear that you would expect them to have the same liver stiffness. You're going to see improvement just because their ALT normalized. So I think there is caution with repeating serial fibroscans. We have one, it's literally 2 doors down from where I see patients in the clinic, and it's pretty easy to do. But I think in her case, I did it because I was worried about steatotic liver disease.
I will say that if the patient met criteria for endoscopic surveillance for varices because their stiffness was really high and you were able to treat them, there are data that show that if the liver stiffness drops below that 20 kPa threshold and their platelets are over 150, using endoscopy as the gold standard, they may not need endoscopic surveillance for varices. So that's when I will consider repeating elastography, but not necessarily to stratify my HCC risk.
So one last question. She's on the diabetes dose for semaglutide. She's lost about 10 pounds. It's been about 6 months. Is that 10 pounds down from 170 to 160? Is that enough? Is she doing okay? Or is it worth, doing that painful prior authorization and try to switch?
Yeah, so I mean, thank you. Yeah, so I mean, keep in mind that when we're talking about averages of weight loss achieved on these medications, and I say 15% with semaglutide, and we may be thinking this patient hasn't reached that threshold, but there are individuals that are getting more weight loss from these medications, which means that there are individuals that get less sort of weight loss. So that's an average. So you're going to see this wide spectrum of how much an individual can achieve in terms of weight loss. Now, with regards to the percentage, again, you want to think of those thresholds that I showed you, kind of general thresholds when we think about 5 to 10% as being sort of the goal for MASLD, and maybe 10 to 15% for MASH. So you can keep that in mind. I think, part of this is like a balance of side effects. So if the patient's like bordering side effects, I wouldn't push it. If there are other things that you need to sort of improve metabolically, like perhaps her BMI still may not be at target, you may consider going up on the dose for other reasons, because it seemed like there were multiple indications for this individual to be on that medication.
Well, great. Well, she'll be back in about 6 months. So we'll have that conversation. So we're going to wrap it up here and try to get you all over to the round table. So if I can have the closing slides. Excellent. So first of all, certainly want to thank everyone for joining us. I want to thank our speakers for just a wonderful series of lectures today. And really an engaging panel discussion. We settled many debates, but not the core antibody approach. So we'll save that for next year. We'll have to tackle that one again. Maybe the guidelines we updated, and we'll go from there. So really a wonderful couple of days. Yesterday was a fabulous day regarding HIV, STIs, and today I think we really dug into a lot of issues. So I do want to remind folks that there is a post-conference CMEC evaluation that will be sent your email early next week. As I said earlier this morning, you'll keep getting emails for 5 straight days. Just respond to the first one. You can reduce the email clutter. And we really do use these. We will meet and we will discuss the feedback. Don't be too hard on us about the Hep B core. It really is a confusing topic, but we'll try to settle that. And then again, 2 to 3 months down the road, you'll get another email. We want to see kind of what you've taken home, truly home, back to the clinic. That's the optimal management piece of OPMAN. There will be an archive around early April. You'll get the email that takes you to this. The archive will be available for credits if you haven't already got those. Once again, a great big thanks to our commercial supporters who wouldn't be able to do this program at the prices that we can do it at without their support. And the last part of it is to remind folks of the roundtables. So I don't see the locations here, but you can ask the folks at the practice point. There they are. Hepatitis C challenging cases in the state room. Hep B, more questions. The commerce room, and metabolic dysfunction associated steatotic liver disease, aka fatty liver, in the treasury room. So with that, I want to thank everyone for coming and really appreciate everyone's contributions to a really wonderful OPMAN 33.